Good morning, ladies and gentlemen. On behalf of the organizing committee of the 8th Annual Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe. Before starting the session, we will play the national anthem of this great country, the UAE. Please. Once again, I would like to welcome all viewers from all over the world. Today is the second day of the 8th Annual DPC Conference. This conference is conducted in collaboration with NMC Specialty Hospital Dubai. I would like to thank the management of this hospital. Well, I would like to thank all speakers, chairperson, moderators, panelists, and all involved in this conference for the active participation. We have a lot of sponsors. I would like to thank all the sponsors, especially New Country Head and Vitabiotics, the country business manager of this company, Mr. Tawfiq Ali, who always support us. I would like to thank all members who are always with us and supporting us. Well, I would like to thank our chief guest, Mr. Frank Delisi, the Senior Vice President of Operation NMC Healthcare, who accepted our invitation. And now I would like to request him to deliver the inaugural speech. Please, sir.
Good morning. I'm Frank DeLacy, Senior Vice President of Operations of NMC Healthcare. It's my great pride and privilege to welcome you to Day 2 of the Dubai Pediatric Club DPC Summit 2022. I'd like to recognize the organizing and executive committee members of the CME, led by Dr. Sarab, who is the chairman of the conference and is the president of the Dubai Pediatric Club, Dr. Kalpana, who is the secretary of the Dubai Pediatric Club, and Dr. Diari, who is the chairman of the academic affairs of the Dubai Pediatric Club. Also welcome the other functionaries of the conference, the doctors in attendance both online and offline, and my dear colleagues of NMC. Greetings and welcome to this distinguished conference. This conference brings together over 80 speakers and moderators and over 1,000 delegates from over 60 countries together in one forum to discuss what it takes to provide world-class care to our youngest population of patients, our children. So I commend you, your commitment to this conference and to your commitment to serving our community. Thanks to the DPC, Dr. Sarab, and countless others, and to the academic team, which put together a spectrum of fascinating and interesting topics that cover an array of care for our children. Also, a special recognition of our sponsors who made this conference possible. So I hope you're having a great time, and I hope this day continues to meet all of your expectations. And I thank you for your attendance and once again for your commitment.
Thank you very much, sir. We are honored. I would also like to thank the members of the organizing committee, especially Dr. Kalpana Sengupta, Senior Specialist Pediatrician and Head of Department at NMC Specialty Hospital and Secretary of the Club, and Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital, Dubai, and the Chairman of the Academic Affairs. Well, our first session is Pediatric Endocrinology. This session is sponsored by Novo Nordisk, UAE. But now I'd like to welcome the chairman of this session, Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital and Chairman of the Organizing Committee of the 8th Annual Dubai Pediatric Club Conference. Dr. Diari, over to you to introduce the moderator and panelists of the first session. Thank you very much for joining us.
Thank you, Dr. Zorab, and good morning, everybody. I am glad to introduce the moderator of the endocrinology session, Dr. Asma Deep. Dr. Asma Deep, she is a consultant and chair of the endocrine session of today, and she is working in Sheikh Shakhbout Medical City, Abu Dhabi. Dr. Asma, please join us and introduce the panelists of the talk of today of session.
Thank you very much indeed, Dr. Sarab and Dr. Diari, for this introduction. We are so grateful and so excited to deliver the endocrinology session right fresh in the morning. We've got 4 prestigious speakers, and we have chosen very relevant topics in pediatric endocrinology, including growth, puberty, and diabetes. And our 4 speakers will speak at 10 minutes each. It's now my pleasure to introduce our first speaker in this panel, Dr. Manal Mustafa. Dr. Manal Mustafa is a consultant pediatric endocrinologist who is currently practicing at Al Jalila Hospital in Dubai. Manal is going to give us an introduction to growth, which is a case-based presentation. And the floor is yours, Manal. Thank you very much indeed.
Good morning, Dr. Asma. Good morning, Dr. Surab, Dr. Diari, and good morning, everybody. It gives me a great pleasure to participate in this conference today. And I am going to thanks for organizing committee who gave me the chance to participate. And my talk today is about interesting cases of short stature treated with growth hormone. My first case is a girl who is MA. She is a 3-year-old female complained of short stature when she presented for the first time to my clinic in January 2018. She was not on any regular medication and she did not have any significant past history. Upon examination, she had a normal vital signs and her growth parameters showed a borderline weight on the 1.8 centile and her height was below the third centile, 0.47 centile minus 2.6 standard deviation. She had a low hairline, webbed neck, and widely spaced nipples. There was no goiter. Her remaining of the clinical examination was unremarkable. She was prepubertal with a normal external female genitalia. I did not get the approval to share her pictures, but these pictures are from the literature and they are very similar to her. This is her growth chart. You can see that when I firstly saw her, her weight was below or just on the third centile, but her height were below the third centile minus 2.6 standard deviation below the mean. So the first differential diagnosis came to my mind that mostly it is a Turner syndrome. I did for her the initial lab investigations and it showed normal or acceptable levels of IGF-1, IGF-PB3, normal vitamin D, HbA1c, normal thyroid function, negative celiac screening, and negative thyroid antibodies. So as we all know that karyotype is a must in all short females, so I did for her the karyotype and it confirmed the mosaic Turner syndrome with the presence of Y gene. And this was confirmed by the fish, which showed an SRY positive test. She underwent removal of her dysgenetic gonads by the help of our pediatric surgery team, and she was started on the growth hormone treatment with a good response. And this is the CDC growth chart showing how she grown up well and nicely after starting the growth hormone. And she was almost between the third and the fifth centile on the CDC growth chart, while on the Turner growth chart, Turner syndrome growth chart, she showed a significant improvement and her height was almost on the 90th centile. Even her IGF-1 level improved significantly with the treatment of growth hormone. This is a very nice article published in the Hormone Research in Pediatrics about the final adult height after growth hormone treatment in patients with Turner syndrome, and it highlights the importance of early diagnosis and early treatment to ensure an optimum final adult height for these patients with Turner syndrome. My second patient is RA. She is a 9-year-old female who presented to my clinic recently in November 2021, almost 1 year back, with severe obesity and short stature. She was on vitamin D3. She was not physically active, not on any low-calorie diet. And she was the second child from a non-consanguineous parents who were having a normal body build and they were not obese. Her birth history showed an uneventful pregnancy, normal vaginal delivery. Her birth weight was 2.48, but she had severe hypotonia with head lag after birth, which improved with the age and physiotherapy. Her past history showed that her weight gain started to be noticed at the age of 2.5 years. She was hyperphagic. Mother was looking at the fridge to prevent her from continuous eating. She had a delayed motor developmental milestone. She walked at the age of 18 months. Also, she was having a low IQ of 80 with learning difficulties at school. On examination, she had a normal vital signs. Her growth parameters showed a borderline, a short stature. Her height was 118, which was minus 2.48 standard deviation below the mean. She was severely obese. Her weight was 62.3 kg for a 9-year-old girl. Her weight was on the 99th centile, and here her BMI was 44.8, where the value was of the chart. She was obese, active, with a downturned mouth angles. She had no goiter, and she had severe acanthosis nigricans around the neck, and she was prepubertal. These pictures are from the literature because I did not have her pictures, and they are very similar to what I saw in this patient. This is her growth chart at the time she presented, November 2021. You can see that her weight is high above the 97th centile, and she was having short stature, her height below the third, and her BMI was of the chart. It was not, we were not able to plot it. Her karyotype showed a 46XX, low IGF-1, normal IGF-PB3, slightly high TSH 6.44 with a normal FT4, which highlight the typical clinical hypothyroidism commonly seen in obese patients. She had a low total vitamin D, normal HbA1c, normal fasting lipids, and normal liver function test. By the way, her thyroid function normalized with the follow-up without any intervention. So the first thing came to my mind that mostly I am dealing with a Prader-Willi syndrome. I did for her the methylation test, and it confirmed the result of Prader-Willi syndrome. I started her on growth hormone treatment, and she showed a good response over the last 1 year. And you can see that how her weight dropped nicely with the treatment of growth hormone, or also with the diet control, and also her height significantly improved. This is on the CDC growth chart, and her current height is on the 10th centile. Even her BMI improved significantly and dropped to 32 from the beginning, where it was 44 upon diagnosis. So I just highlight what are the FDA approved indications to treat with growth hormone. This table summarizes all the FDA approved indications for growth hormone with the year of initial FDA approval. The first indication approved was pediatric growth hormone deficiency, followed by growth failure secondary to chronic renal failure till the time of the renal transplant, then adult growth hormone deficiency, HIV wasting in adults, Turner syndrome, Prader-Willi syndrome, small for gestational age with failure to catch up growth, idiopathic short stature, and this is a debate area for some of the centers, short bowel syndrome, CHOX gene deficiency, and lastly, Noonan syndrome. We have many formulations of growth hormone to treat with. The mostly common used is the once daily formulation given as a sub-Q injection. We have several brands of recombinant growth hormone. They are all equally biopotent, and they are available in multiple dose pen devices. And we are all familiar with the norditropin, genotropin, as well as Cyzin. And recently we got the sustained release formulations of the growth hormone, and Skyforta was the first FDA-approved long-acting growth hormone, which it got the approval in August 2021, approved for a treatment of growth hormone deficiency beyond the age of 1 year and beyond the weight of 11.5, and is given as a once-weekly injection. And what we have here in UAE and recently approved in Canada, Australia, Japan, and in all EU member states, and also approved here in UAE, and we started to use it for our patients in Al Jalila Hospital, is the Ngenla or somatorgone. It's approved for a treatment of growth hormone deficiency in children from the age of 3 years, and it's also given as a once-weekly sub-Q injection. So the take-home messages. Please, as a pediatrician, a primary healthcare physician, or even as an endocrinologist, keep a high index of suspicion for syndromes that require growth hormone treatment, especially Turner syndrome, Noonan syndrome, Prader-Willi syndrome, and CHOX gene mutation. Early diagnosis will help for early treatment and for optimizing the final adult height, plus the other benefits of growth hormone, especially in Prader-Willi syndrome. Do the basic workup before referring to endocrinology, like doing the IGF-1, IGF-PP3, thyroid function test, bone age, and don't forget the karyotype for all females with growth with short stature. Early referral to endocrinologist, and remember the FDA-approved indications for growth hormone treatment. Thank you so much for your attention.
Thank you very much indeed, Manal. That was a great start for our endocrinology session. Fantastic choice of patients. Please stay with us. We will be needing you for the discussion on this very important topic. Thank you very much indeed. Before I introduce our second speaker, may I please ask you, ladies and gentlemen, to post your questions in the Q&A chat. We will have an ample time for discussion, and you can have access to our experienced speakers. Now we continue on growth, and it's my great pleasure to introduce Dr. Anurag Bajpayee. Dr. Bajpayee is joining us from Kanpur, India. He's a consultant endocrinologist, not only for pediatrics solely, but also for adolescent medicine. And he is currently practicing at the Regency CDER. Anurag, the floor is yours to give us more insights on growth in children. Thank you.
Thanks a lot, Dr. Asma, and for the wonderful invite. I'd like to, at the very offset, thank the organizers of the DPC, especially Dr. Sohrab and Dr. Kalpana, for inviting me. The stage has really been set by a wonderful presentation from Dr. Manal, which covered the lot of topics specifically with regards to the various aspects of assessment and the management of short stature. I'll be focusing predominantly with regards to the management aspect and the assessment, particularly because right identification management is absolutely essential from that perspective. So if we talk about growth failure, a large majority of patients who present to us with growth failure will be in the physiological range. So it is a common presentation. 2.5% of all children will be short. Importantly, 80% of them will be physiological and around 10% will have a pathology. So the main challenge which a physician faces in this regards is to differentiate patients with physiology and pathology. Do not do unnecessary workup in physiological causes while not missing out in terms of pathology. And that's what I'm going to do over the next 10 minutes or so as to how do we carefully assess and manage these perspectives. So I'll largely be focusing about growth chart because that's a pivotal part of assessment. And if you look at the growth chart carefully, you will be able to make the diagnosis in most cases in that regards. Now, broadly speaking, we can classify growth failure into physiological, which basically represents a child who is short for the population, but is not short for the bone age or the pubertal status, which is constitutional delay of puberty and growth, and not short for the family, which is familial short stage. And this is around 60 to 80% of cases, which we as endocrinologists will see, the pediatricians will see is much more common. Then we have the pathological causes where the problems could be in the growth plate, which is a primary cause. And then we have the secondary cause, which can be because of nutritional and endocrine. So the key issues which a physician has to encounter while dealing with a child with growth failure is it really short stature? And that, of course, will depend upon whether the child is short for the population or not. The next question is it pathological or not? And the answer to that will come in whether the child is short for the family, short for the bone age and puberty. Then whether it is primary or secondary, which we'll basically get from the clinical examination of dysmorphism, facies, SGA and other aspects. And then finally, whether it is nutritional or endocrine. And there, the most important thing will come up with regards to weight. Now, growth chart is something which is solely going to tell us a lot about confirmation of short stature, differentiation of physiological from pathological causes, and nutritional for endocrine. So this is what I'm going to focus predominantly in that perspective and regards. So we'll start off with this case, a 12-year-old girl who was presented with growth failure, height of 132 and weight of 28. So now if we plot the child, the first thing to look at, of course, is what's the absolute status. So compared to the population, she looks short. But the next question would be what really is the relative status in terms of the family height. So what we see is that when we look at the father's and mother's height and we plot the target height range, which is pretty much 8 centimeters from the mid-parental height, we see that this child is on the normal range as far as family is concerned. So we have got a 1.5 standard deviation score of 8 centimeter range, which is there. The final question, of course, is to look at the nutritional effect. And for that, we look at the height age and weight age. That is the age at which the current height and weight become the 50th percentile. So in summary, this child is short for the population, but is not short for the family. And the weight and height both are affected equally. So there seems to be no specific nutritional effect. The most likely diagnosis is familial short stature. We have to look at the puberty and bone age. And if they are commensurate with a prepubertal child, best would be to wait and watch. So this is a classical familial short stature pattern, which is clearly there on the growth chart. Second case, a 13-year-old boy with growth failure. And what we see is that this child clearly is short when we compare to the population. So absolute terms, he is short. When we compare to the family, he is also short. And when the height, age, and weight were estimated, it was again around 9.5 years. Now, at this point of time, a lot of workup was done. Evaluation showed a normal screening test, and then further evaluation showed a peak growth hormone level, which was low. Now, this child was therefore diagnosed as growth hormone deficiency, started on treatment. but the child did not start treatment and wanted a second opinion. Now, if you look at this growth chart, what we are seeing is the child is just below the lower end of the spectrum. So this is very unlikely to be growth hormone deficiency. 99% of this would actually be constitutional delay of puberty and growth. So we answered two questions, short for the population, short for the family, but is he short for the pubertal status? Is he short for the bone age? The next important thing here before we make a diagnosis of GHD is the bone age, and we can see this yellow dot, which is approximately 11 years. And if we take the child back to 11 years, he is not short for the bone age. And he only had a testicular volume of 2 ml. So again, this diagnosis of growth hormone deficiency is not clear. And if we do a unprimed, without giving testosterone, a growth hormone stimulation in this scenario, we'll falsely label a child as growth hormone deficiency. So when we did a primed level, we found that the growth hormone level went up. And this was not growth hormone deficiency, but constitutional delay of puberty and growth. And we just followed up the child and he had a normal growth. So the most important thing when we are evaluating is to first think of common physiological causes, familial and CDGP. And I'll just show you the pattern which will tell you. So on the left-hand side, we have a child who is normal in the initial early childhood, trends to drift away from the growth chart, but continues to grow for a longer period to achieve a normal final height. This is a classical scenario of constitutional delay of puberty and growth. Puberty and bone age both will be delayed in that perspective. On the right-hand side, we have another chart in which the child is always short, has a normal growth velocity, but because the bone age in puberty is appropriate, will have a compromised final height commensurate to the family, and this is typical familial short stature. In a more objective terms, if a child's height standard deviation for bone age is more than -2, it is most likely to be a constitutional delay of puberty and growth. And if the child's corrected height standard deviation score corrected for the family is more than -1.5, this is familial, and we'll show how this all can be used in an algorithmic manner to get the right diagnosis. Moving forward to the next case, a 12-year-old girl who was short, had a weight of 15 kilograms. Parents were in a reasonable expectation and the bone age was mildly delayed. Now, this child, the basic workup, the hemoglobin, TSH, all the screening tests and TTG were normal. Evaluation was done in the form of IGF-1 and basal growth hormone, which was found to be low, labeled as growth hormone deficiency and advised growth hormone, actually, with which there was hardly any response in terms of therapy. But when we plotted the chart, we found that this child clearly had a distinct pattern. What we are seeing is the weight is more affected as compared to height. So this is much more likely to be a nutritional cause. Rarely you can have growth hormone deficiency with less weight, but typical presentation is a short and plump child. So in this scenario, I would be very wary of making a diagnosis of growth hormone deficiency. Remember, IGF-1 may be falsely low in the setting of malnutrition, so it's not going to be reliable in this scenario. And basal growth hormone is actually a waste of money because it has a lot of variations, and growth hormone is a pulsatile hormone. So what we need to be wary in these sort of cases is to consider celiac, which is a strong pretest probability. And in this scenario, we need to basically look at a possibility that there are some other situations. And what we found was there was an IgA deficiency, which was causing a falsely negative diagnosis for celiac disease in that perspective. So this child was misdiagnosed as growth hormone deficiency just because the growth chart was not interpreted appropriately. Next case, a 10-year-old boy, again very short, and the weight seems to be reasonable. Family is slightly short, the bone age is reasonably delayed. Now, this child, the workup showed a slightly elevated level of tissue transglutaminase antibody, and without a biopsy, a gluten-free diet was initiated. Now, this is again unfortunate, but a common practice in which we are diagnosing celiac without a biopsy, unless and until your TTG is 10 times the upper limit and the endomycin antibody is positive, we should not label somebody as celiac. This child had no response to gluten-free diet, again referred for evaluation. And when we looked at the growth chart, what we found that the pattern was entirely different than the last case. What we are seeing here is that there is a much more compromise as far as height is concerned than the weight. This is an endocrine pattern. And when we evaluated, this was a short and plump child with micropenis, pot belly, and found to have growth hormone deficiency. So again, if we look at the growth chart, we can make a correct diagnosis in that perspective, in that regards. So to compare nutritional for endocrine, the most important thing is weight. If you have a child who is short and lean, this is nutritional cause, weightage will be more affected. If the child is short and plump, this is endocrine cause, you will have much more effect on height as compared to the weight in that perspective. Now to put all these things into perspective in an algorithmic manner, the first question is the child short? For that, we look at height standard deviation score. If it is more than -2, the child is not short, do not evaluate. Then the next question is it a familial short stature, short for the family or not? We look at the corrected height standard deviation score. If it's more than -1.5, don't worry, this is familial short stature. Next question is whether this is constitutional delay. For that, we look at whether the child is short for the bone age or not. Height standard deviation score for bone age, if it's more than -2, this is constitutional delay. So if the child is normal for the population, normal for the family, normal for the bone age, 80% of all your referrals, no need for evaluation in that perspective. Next, if you have excluded all that, look at various illnesses, do a routine screening. Very importantly, blood gas before 3 years of age becomes important. This will be the tier 1 screening, include TTG and FT4-TSH. If it's abnormal, we'll get the diagnosis. If it's normal, the tier 2 would basically be a IgA. We can do IgA in the beginning as well, and karyotype in girls to identify Turner syndrome. Once we have excluded everything, then only we should go ahead with growth hormone levels, and particularly a primed growth hormone stimulation. If it's low, it's growth hormone deficiency. If it's not, we'll go for IGF-1 and then diagnose whether it is a growth hormone insensitivity or idiopathic short stature. Of course, in the beginning, we'll look at syndromic features and disproportion to identify the cause. So this algorithm, which we published recently in JPM, provides a cost-effective analysis of a child with short stature with no need for extensive workup. And we have developed a mobile application in which, based upon these findings which are there, if you just enter that, you will get the pattern. So the 3 key questions are, is the child short? Short for the population, short for the family, short for the bone age. If the answer is yes for all, then only do evaluation and you can do that. So what we have tried to do is to develop and validate this mobile application in our databases, and we found a high level of concordance on that. So overall, the approach of growth failure starts off with regards to a careful clinical assessment with predominant focus on 3 aspects with regards to the growth chart, bone age, and puberty, which will give you a clear-cut diagnosis in most cases and use of selective cases specifically in that regard. So I'll again thank the organizing committee of DPC for inviting me for this wonderful opportunity. Thanks, Dr. Asma, and we can carry forward from the discussion part there.
Okay, Dr. Anurag, that's amazing, as always. Fantastic wrap-up of how we should approach children with short stature. As everybody know or might not know, short stature is the most common reason or indication for referral to the endocrine clinic. So what you said, Dr. Anurag, comes very handy for our education. It's now my pleasure to move to the second part of this webinar, and growth is never complete without talking puberty. So I'm gonna invite my friend and colleague, Dr. Asma Jassim, who's gonna open the second half of this exciting webinar. So Dr. Asma Jassim is a consultant pediatric endocrinologist, very well known in UAE. She worked in Dubai and is currently in Ajman. And Asma is gonna talk to us about precocious puberty. The floor is yours, Asma.
Dr. Asma,
Please
you're
go ahead,
mute.
Asma.
Please unmute yourself.
Showing you this. Yeah, my screen is here. Hold on a second, just sorry.
No problem, Asma. Take your time. We are good.
No,
So-
can you just, this is the screen I want to share, so I don't know if I'm able to share it or not. Share the screen. I have the presentation on the desktop, but I don't know how to share it.
Are you clicking
Okay.
on the green button with the
Yeah,
arrow, Asma? You are?
Yes, I am.
Okay.
Okay,
You
but
cannot
then
see your screen.
No, I can see myself, but I can't see my presentation. I don't know.
Mr. Tawfiq, do you have a presentation with you? Maybe you can share it.
I would say,
No problem, Asma. Take your time. We can start with Dr. Nando while you are fixing your sharing. Does that sound okay to you?
okay, great. Okay, no worries.
Okay, you have 15 minutes to do that, no problem. Okay, so Dr. Nando, you are around. I'm sorry to put you on the spot at this very short notice, but if you could kindly prepare your slide. Dr. Nando Thalanji, another colleague and friend of mine and of everybody in the panel. He's a senior consultant pediatric endocrinologist with huge experience, extensive one in endocrinology. Nando is currently the chair of pediatric endocrinology at Al Jalila Hospital in Dubai. We're going to shift, we will leave puberty, but very important emphasis of childhood diabetes with highlight of type 2 diabetes. That's what Dr. Nando is going to teach us today. The floor is yours, Nando. Thank you very much.
Thank you very much, Asma. Thank you to the organizers for inviting me, and I'll press on. Let me tell you about Cindy, who is referred from adolescent medicine due to glycosuria with high HbA1c and morbid obesity. She was hypertensive and had hypercholesterolemia and was breathless on modest exertion. She had a history of a recent UTI, but there was no history of weight loss, polyuria or polydipsia, so this was not really the picture of type 1 diabetes. And this can be actually quite difficult to differentiate in obese adolescents. But her type 1 antibodies were negative, which confirmed really that by far the most likely diagnosis was type 2 diabetes. So when really throughout the 1990s and 2000s, this was the standard management pathway for type 2 diabetes, and it wasn't very good even then. But I'll show you how this really has changed in the recent past. So one of the problems we have with type 2 diabetes of early onset in life, so this is young adults and adolescents, is that it has appalling rates of complications. You think type 1 diabetes is bad, type 2 diabetes is much, much worse. So this is the outcome data from the Today study, which was a large intervention study in type 2 diabetes in North American adolescents with new onset type 2 diabetes. And this, they were followed up, and this was published after an average of 13 years of follow-up. So these were people who were now in their mid-20s. 2/3 had hypertension, half had dyslipidemia, half had kidney disease, a third had neuropathy, half had eye disease. And more than that, they were also already in their 20s experiencing myocardial infarction, congestive heart failure, coronary artery disease, stroke, and death. So this is really a very, very poor outcome. And we have data from a little bit longer ago from Canada, which shows that the 20-year outcome data with type 2 diabetes of onset before the age of 20 is such that you have a 1 in 3 chance of being alive and healthy after 20 years. So this is a very, very drastically poor prognosis. The black line at the top is type 1 diabetes by comparison. So however bad you think that may be, you know, they're nearly all alive and they're nearly all not experiencing serious complications. So we need to do a better job with type 2 diabetes. Now, what happened with Cindy? So we started her on metformin, but you can see here a year later, her HbA1c was up. Her HbA1c was down, but it was still above our target in type 2 diabetes, which I'll come back to. She was morbidly obese, actually gained weight. Her blood pressure was still high despite antihypertensives, which was largely due to non-adherence to her antihypertensive medication. And she had still had a high cholesterol, although it was better than before. So what treatment options do we have? So she's failed on metformin therapy. The average duration of efficacy of metformin is around 9 months in adolescent type 2 diabetes. So here is a summary of the adult data in type 2 diabetes. So on the top, we have insulin, the sulfonylureas, like, for example, diamicron, and the glitazones, which cause weight gain, hypoglycemia, complications, and premature death. And then on the bottom, we have the new generation drugs, in addition to metformin, the GLP-1 analogs and the SGLT2 inhibitors, which are associated with weight loss, no hypoglycemia, reduced morbidity, and reduced mortality. And I don't think you would really be wanting to choose anything from the top row if you could avoid it. Obviously, there is a situation where we have to use insulin in diabetes, but you definitely want to avoid that if possible. The DPP4 inhibitors are quite popular, but they don't help you one way or another. They don't improve your prognosis. They reduce your glucose a very small amount. What about GLP-1 analogs? So GLP-1 analogs basically help your insulin to work better, and they act centrally to reduce your appetite. And they also have an effect on stomach emptying. So it delays gastric emptying, which if you try and eat too much leads to nausea and vomiting, which is a significant side effect of these drugs, but is also part of how they work. So you have to educate the patient who's going to start one of these drugs that they need to have smaller helpings. They can't just go and eat the same as they always ate. They can't go to McDonald's and tuck into a Big Mac and fries. They need to moderate their helpings and think differently about eating. One of the other benefits of these drugs, at least in adults with type 2 diabetes, is that they are associated with improved cardiovascular and renal outcomes. 3 GLP-1 analogs have been evaluated in pediatrics. They are liraglutide or Victoza, exenatide or Bydureon, and dulaglutide or Trulicity. So those are the 3 that have been evaluated. What about the SGLT2 inhibitors? So these are drugs that cause you to excrete glucose in your urine. So they essentially lower the glucose threshold from about 180 in someone without diabetes to about 120, depending on the potency of the inhibitor you're using. And by getting rid of the glucose, you actually lose some calories, so you lose a little bit of weight, but they're also massively renoprotective, and in fact also have huge cardiovascular benefits as well in adults. And that's true even if you don't have diabetes. So these are now, preferred first-line agents in the treatment of adults with CKD and heart failure. And there are several ongoing studies of SGLT2 inhibitors in adolescents with type 2 diabetes. And we recently did have a study reported on dapagliflozin in adolescents and young adults. And this is it. This was 72 patients with type 2 diabetes, 18 to 24 years of age. And in those, unfortunately, there was a lot of non-adherence in this study. So they analyzed the group who actually took the treatment as opposed to the group who was supposed to take it and didn't. And if you actually took it, then you reduced your HbA1c by 1.1%, whereas those on placebo increased their HbA1c by 1.3%. So back to Cindy. So she'd failed metformin, and we advised her that she needed to start something else. Now, if you're looking at potency, if you really want to get a good effect, then GLP-1 analogs are more effective than SGLT2 inhibitors. So that would be reasonable, but many patients don't want to have injections. So then in that case, use the SGLT2 as the first next step. But in Cindy's case, actually, she wanted to lose weight. And so she actually preferred to start liraglutide, which, because of the approval of liraglutide as Saxenda for adolescent obesity, she could actually have Saxenda, so the higher dose of liraglutide. And obviously, you can't just throw medication at the patient. It's not going to work on its own. The patient has to change their habits. So I mentioned how you have to change your eating habits, for example, to avoid some of the more unpleasant side effects. So back to our type 2 diabetes treatment pathway. So yes, we do need to have diet and exercise. So lifestyle measures are important, but what we also know, I haven't shown you the data because time doesn't permit, is that lipid and blood pressure control are as important in type 2 diabetes as glucose control. We cannot neglect lipids and blood pressure just because we're pediatricians and we're not used to dealing with them, because these children are dying in their 20s of cardiovascular disease. And we're not going to leave them without medication at this stage. They've already shown what not having medication, not having lifestyle, not having lipid and blood pressure control does for them, which is it's delivered them to the point where they have premature onset of type 2 diabetes. We're going to start with metformin. I suppose a bigger question might be, would you start with metformin and an SGLT2 inhibitor at the same time? And that's a reasonable question. And I think that's probably what we'll move to in the future. But for the moment, still metformin on its own, but as I mentioned, mean duration of efficacy is 9 months, and GLP-1 receptor analog or SGLT2 inhibitor, or potentially both, as the next step. And beyond that, sorry, I forgot to mention that in patients with a high HbA1c at diagnosis, they may need a period of intensive insulin therapy at the beginning, normally only for a few weeks, perhaps 6 weeks before you can stop the treatment. And this actually is very, very important because it can salvage the remaining beta cells by rescuing them from glucose toxicity. So hyperglycemia poisons your surviving beta cells and can render you much more rapidly insulin dependent. So intensive insulin therapy at diagnosis is a very good strategy for avoiding that rapid deterioration in beta cell function. Now, the sulfonylureas used to occupy the spot after metformin. There's no role for sulfonylureas, no role whatsoever for sulfonylureas in type 2 diabetes. I would say that's true for adults and children, to be frank. My adult colleagues might be rotating rapidly at the moment, but really these drugs cause weight gain, complications, hypoglycemia, and premature death. That's not acceptable outcomes to me when we have drugs that do the opposite. And then when we do get to the point of starting insulin, I use detamir, but actually once you're on basal insulin and GLP-1 receptor analog, it will be rare to need to intensify insulin therapy beyond that. So I think we would try to avoid insulin intensification if at all possible. Adherence is poor, doses tend to be very high, and it tends to lead to rapid weight gain and general deterioration in health. So in summary, type 2 diabetes of childhood onset is very difficult to treat. The lifestyle management is important, but on its own, it's not going to work. If you could get someone to lose enough weight, then they will reverse their type 2 diabetes, but that's very difficult. So in adults with type 2 diabetes, weight loss alone will completely reverse type 2 diabetes. But actually getting adolescents to do that, that is something that is rare to achieve, I would say. The prognosis of type 2 diabetes when you're young is extremely poor. We're talking about 2 in 3 being dead or disabled after 20 years of diabetes. And so that means that we need aggressive multimodal therapy to reduce cardiometabolic risk, to get that blood pressure down, get the lipids down, get the glucose down. And newer agents are transforming the prognosis of type 2 diabetes. And we really should be moving to these newer agents rather than using the old war horses, such as sulfonylureas. Thank you very much for your attention, ladies and gentlemen.
Thank you very much, Nando. That's very interesting, very worrying and scary indeed. Do stay with us, please. We'll come back to you for questions. Thank you very much. I would like now to go back to the puberty session, and I would like to invite Asma to give it another go, sharing her slides. Please, Asma, do you want to try? Again, Dr. Asma Jassim is one of our senior endocrinologists here in UAE. She is currently working in Ajman, and hopefully her slides will work. I know we have a backup. If Asma cannot, then Mr. Tawfiq.
Mr. Tawfiq, can you just go through them, because I have them in the background, but I cannot. If you can do them, that will be great.
Thank you, Asma. Mr. Tawfiq, please come to the rescue. Fantastic. The floor is yours, Asma. Please go ahead.
Okay, can you go next, please? Okay, so I'll start my case. This was actually a case which I saw maybe less than 6 weeks ago. So it was by the end of the day around 5:20 p.m. I received a call from my colleague in the pediatric clinic. He said, listen, I have a patient who was a 4-year-old boy. He's brought by his parent for checkup, but he's like in full puberty. I said, fine. I mean, definitely he will need a lot of workup and investigation. So let him come tomorrow morning by 7:30 and we'll see how can we start from there. Next, please. Next, please. Next. Can we go next, please, Mr.
It's not moving. Let me see.
It's okay. Okay, so the next morning, I see a patient who comes for me. He's still not a 5-year-old. And can you see the picture, how he's looking? Can you see how muscular he is and the sebaceous, look at his forehead. Can we go next, please? Okay, next, please. Okay, so here, next. So I have a patient who's a 4-year-old and 10-month-old who comes with early puberty signs. Okay, he was noted by having increased body pubic hair since the age of 1 year, which has been progressive. He, as per parents, he only plays with elder boys. He's very aggressive and he has a sexual behavior and sexual gestures. He's chasing girls and he has acne and muscular body build. Apart from the history, he had nocturnal enuresis, never been on medication, and have no medical advice sought at all before. His review of system is not significant, and neither his past medical history. Born at term, normal delivery with a birth weight of 4 kilos and eventful pregnancy. And he's not known to have any allergies or never been on any medication for a long time. His growth and development. So his growth has always been advanced, but regarding his development, there is an issue about speech delay. And when I asked the parents, he's 4-year-old, did he attend any daycare or something? He told me we never took him to any school. His behavior is so aggressive and he's like having very bad sexual behavior. So we could not even take him to any school yet. Family history, the parents are consanguineous, they are first cousins, both parents are healthy, they have, the patient have other 5 siblings who are all fine with no significant medical history in the family. Okay, so this is on the examination. If you see the boy, look at, he's still not 5-year-old. Look at the muscular build he has. Look at the skin, how it's shiny, sebaceous, little acne. Look at the mustache he has. Okay, next, please. So, next, please. So on examination, he was active, pink, he had no dysmorphism. He has facial acne, muscular body build, acanthosis nigricans at the neck, and his skin tone was quite dark. I could not appreciate any hyperpigmented lesions. Only I noted one cafe au lait spot at the left back, which was around 3 by 3 centimeters. He had no goiter, his blood pressure was fine, heart rate was okay. His height, he's 4 years and 10 months, and his height is 131.5 centimeters, which is definitely more than 100%. And the Z score is plus 5.2 for his height. The weight also was, he was a hefty boy, and his BMI was 21, between 110 and 120 percentile for age. Next, please. His other examination of the cardiovascular chest abdomen was unremarkable. His standard stage, he was almost fully pubertal, normal external male genitalia, circumcised testes in the scrotum, measuring between 10 to 12 cc's, and the sternal length was 11 centimeters, like a normal adult size, and normal breadth, with no testicular masses were felt. His fundus, next please, fundus examination was normal, well-demarcated fundi with no papilledema seen. So lab work, we started investigation. So the initial lab work, his CBC, his renal function, his blood sugars, LFT and TFT were normal. The IGF-1 was 62.6 nanomole. It was a bit high, but it's a high for his age, but normal for his standard stage. The IGF-BP3 was normal, and his AM cortisol was on low normal side. Next, please. So his LH now shows it was at a pubertal level with 6.6 and FSH of 3.3. The testosterone level was high as a 13.4, almost an adult level. His other androgens, 17 OHP. The next please, 17 OHP, DHEAS, the ASD, well, all normal. He had prolactin level was also normal. We did for him also the alpha fetoprotein and the beta HCG, which were normal. Okay, so look at his bone age. This is his bone age. Just remember, he's not 5 yet. And can you see his bone age, how advanced it is? So the bone age was almost suggestive. Next, please. So the bone age was almost around 14 to 15-year-old. So because of his AM cortisol was a bit on the normal low normal side, we did an ACTH simulation test for him, and it was quite normal. He peaked to 510 nanomole per liter. Next, please. And this is his MRI. So this is the sagittal view. If you could see the MRI, how beautiful the sella turcica and the, sorry, I don't have the pointer to point for you, but to see the sella turcica, the stalk and the pituitary, the posterior pituitary bright spot. But look at the hypothalamic mass which he has. Maybe the arrow next, please. The arrow will show it Yeah, look at this mass and maybe in the other view. So this is an hypothalamic mass he had. Next, please. So the feature was suggestive of pedunculated hypothalamic hamartoma originating from the tuber cinereum and projecting into the suprasellar cistern. Okay, so the management, now we have a 4-year-old and 10-month-old boy with advanced precocious puberty secondary to hypothalamic hamartoma. So the management we started for him, next please. So the management plan was we started him on LHRH therapy. So we said we plan to give it till the age of at least 8 years. And the next thing, because his bone was almost about to close, so I tried for him, just resecute started him on aromatase inhibitor, letrozole, which is an anti-estrogen. And I explained to the parents that this is really an off-label medication just to try to prevent any epiphyseal closure, because we know that the estrogen will cause the epiphyseal closure, and he, no matter what, he will end up with short final adult height. So maybe giving him an aromatase inhibitor for a year or 2 might help in allowing him to grow further. So the third was the neurosurgery referral, though there was no pressure symptoms at all, but we referred him to the neurosurgery just to see if there is anything from their side that can be done in this case. The scrotal ultrasound was done and it was normal. There was no masses felt. And don't forget that he also was a bit obese. His BMI was between the 110 and 120 percentile, but this is likely from his precocious puberty. His obesity workup, the thyroid, the liver function test, the HbA1c, fasting blood sugar, triglyceride were all normal. The only thing, he had a lower normal HDL. Next, please. So this was a case of the hypothalamic hamartoma. We know that the hypothalamic hamartoma is one of the most important causes of central precocious puberty in male children. And hamartoma are malformation composed of ectopic gonadotrophic hormone neurons, which secretes pulsatile gonadotropin releasing hormone causing central gonadotropin dependent precocious puberty. And it's usually seen in children below the age of 3 years. And thank you.
Thank you very much, Asma. It was well worth waiting for your case with all those technical. This is an amazing presentation and very important topic of precocious puberty. Okay, we have around 12 minutes for the this discussion time. And while we're waiting for people to post their questions in the QA, I would like to start the discussion on growth. So Dr. Anurag, you gave the introduction of your basic approach to children with short stature. So though you went second, I would like to start by you. And I cannot resist not to highlight a very important message or 2 messages from your talk that I learned today. Short children, you said, look for the stature is the child. Short for population is the child. Short for parents is the child. Short for bone age is the child. Short for puberty. This summarized the whole growth in my opinion. And you beautifully highlighted some false interpretation of investigations. You highlighted to people to be careful, not to be carried away in interpreting IGF-1 as low in thin children. At the end of the day, IGF-1 is a protein. And if the child's problem is mainly weight, please remember, low IGF-1 might not or does not mean growth hormone deficiency. Dr. Anurag, please, if you could very precisely and in short, please tell us about the constitutional delay of growth and puberty. We are used to these young adults or young boys coming to clinic feeling very upset psychologically because of that. And you said it's a benign condition, but how would you deal with their psychology in not accepting being short and with no signs of puberty? Thank you.
I think that's a very, very valid and important question about CDGP, which is by far one of the most important causes, especially in boys with regards to both delayed puberty as well as for short stature. Now, the management usually is a watchful expectancy. We generally advise them, counsel them regarding that things will become normal. Often they will have a family history in parents, especially fathers. So that will be a reassuring aspect. But however, if we have waited till around 14 years of age, it becomes very, very difficult for them to carry on from there. We have to do something often in that intervention. So if you are around 14 years of age and the bone age is touching around 12, 13, 12 years or something like that, and there is no sign of puberty, it is always better to have some sort of an induction of puberty so as to push them into puberty. And I would say that I generally prefer the injectable forms of testosterone, maybe 50 to 100 milligrams given monthly for 3 to 6 doses. In most cases, 3 doses of 100 are pretty good. And once we stop it, we watch for the testicular volume to increase, do a morning testosterone, maybe a couple of months later, if it's gone into the pubertal range, it would mean that the child has now entered puberty. So yes, it is a common condition, it is a physiological condition, but we know there are impact on the psychosocial outcome. There are some concerns about the bone health as well, so we don't want to wait them for a long time because the peak bone accrual may be limited in that perspective. So I would say if the child is around 14 years for boys, we would be probably in a reasonable shape to start off with testosterone. Remember also that in girls also CDGP is common, and often we say that girls do have a pathological cause of delayed puberty, but 25 to 30% of girls with delayed puberty also have CDGP. So if you have waited beyond 13 years, they are probably giving a short course of estrogen, maybe estradiol valerate somewhere around 0.25 milligram for a 3-month period. That will also trigger puberty in that perspective. So I would say pushing and counseling, of course, becomes very important. Beyond 14, waiting is not something which I would advise.
That's amazing. Thank you very much. So do remember short course of testosterone, ladies and gentlemen. May I move to Manal, please? Amazing cases you chose, Manal. Congratulations. Now, tell us, your first patient, Turner syndrome, she had an amazing growth spurt on growth hormone. Do you think we don't normally see that great catchment? Can you comment, is it the karyotype, the different karyotype have different impact on the response to growth hormone? Because her karyotype was not the usual 45XO. Can you comment on that, please? If you unmute yourself, thank you. Yeah, you're good now.
Yes. Thank you, Dr. Now, early detection will have an impact on the response. So she was diagnosed early by the age of 3 years, and that's what was good. I think this has an impact on the response for the growth hormone, plus the dose for the growth hormone dose. Usually for Turner syndrome, start them on a higher dose than for growth hormone deficiency. So we can give them up to 50 microgram per kg per day. Plus, I think being mosaic Turner syndrome will have a better response to growth hormone rather than the monosomy. I don't know, I don't have an evidence on that, but I have noticed that mosaic Turner BK girls have a better response to growth hormone compared to girls with monosomy Turner syndrome.
Right, that's a very good answer. So also the karyotype have an impact. And just one final point, more of a comment, I would like to highlight to people the efficacy of growth hormone, not only in increasing growth velocity in Prader-Willi, but you showed nicely how it affected the body composition and also the improving the hypotonia. So thank you very much for that, Manal. Asma, can I go back to you on this fascinating case? I wouldn't like a 7:30 morning call with this complex case. So well done for your diagnosis. Now, you started the child on triptorelin, and I'm just, can you advise us when we have a clear cause for the puberty, would you not go and treat that cause and surgery rather than going to endocrine? Can you comment on surgical/medical? I'll come to you in a minute, Dr. Kalpana.
Okay, yeah, thank you for this question. So actually, you know, see, in my facility, what happened that I contacted the neurosurgeon and I asked him, you know, I had such a case in this one, and said, I don't have the facility to do anything intervention, so you better refer him to another center with have a pediatric neurosurgery. And I told you the case was very recent. It's less than, if I saw him just around our SP time, it was, so I saw the patient, so it's within a month or 5 weeks. So I referred him. I did not get any feedback from the neurosurgeon, but meanwhile, I'm started him on the treatment. So definitely, from my experience, because of the area, I'm not a surgeon, but I can tell you, I had a similar case, not that severe, long time ago, and I was sure that the neurosurgeon did not do because the area is very difficult to manage. If there was not causing any pressure symptom or anything, so they, in that case, they left it, and they said when he go to puberty, it will be fine. The only thing with that, my previous patient, he had, with hamartoma, they can have seizures, they can have gelastic seizures. So he was on anti-epileptic medication for a period of time. But this patient, he have no neurological symptoms, nothing. So yes, he will need to be seen by neurosurgeon. We'll wait for their decision. But meanwhile, waiting for that, I opted to start him on the treatment.
Okay, thank you. Thank you very much, Asma. Thank you for alerting us to the MRI of the brain, because especially in boys, when they present with this early age precocious puberty, then we need definitely to exclude brain tumor. Thank you, Asma. Dr. Kalpana, I see your hand raised. Please go ahead.
Yes, thank you, Doctor. I have a question for Dr. Asma and just a comment for Dr. Bajpayee's talk. Dr. Asma, in this particular case, after the treatment, what is the kind of prognosis we are expecting? As far as I understand, the child had very aggressive sexual behaviors. Would that all subside? What is his prognosis, no matter what the treatment? And,
well, the prognosis, I mean, if you think about his growth, it definitely will end up with short adult height, because he's almost his bone age is around. Yeah, so 15. Even giving him the anti-estrogen, it's just, like a salvage or a rescue to see whether it will help or not. It's very late, I mean, but it's a trial to see. I think for the time being, when you give him the LHRH therapy, agonist therapy is definitely what's the aim of the treatment? Is suppress his gonadotropin levels and ultimately suppress his androgen and testosterone level. So we hope though that it will improve, because you will not have anymore, your LH, FSH, your testosterone will be suppressed. So hope that will improve his behavior. To what extent, I cannot say. I mean, I have to wait and see, and we'll keep you posted. But he just received his first dose. He even didn't receive his. It's not been 3 months, so he just had maybe last month or his first dose of LHRH agonist therapy.
And do you think he could have presented earlier to you?
Pardon?
Do you think he could have presented a bit earlier to you?
Of course. I mean, the parents know since the age of 1 year. I don't know, I had no answer why they waited. I was shocked when they told me that it's been from 1 year when they noted the pubic hair. I don't know what to say. I was like sitting in the clinic and I didn't know what to do.
Ladies, I need to stop you there, because I have only 1 minute that I'd like to finish up with Dr. Nando, please. Dr. Nando, you did manage successfully to scare us about type 2 diabetes. Can you please, in short, tell us why type 2 diabetes is worse than type 1 diabetes? I know you mentioned that. Just summarize for us, please. Thank you.
In type 1 diabetes, you take a basically healthy child and give them glucose intolerance. In type 2 diabetes, you take a profoundly unhealthy child or adolescent and give them glucose intolerance as well. And that's the difference. They're already much further down the road of diabetes complications at the point of diagnosis. In fact, it's not uncommon for young adults at onset of type 2 diabetes to already have complications.
Dr. Asma?
Thank you very much. Thank you very much. Yes, somebody's...
Yeah, this is Dr. Diari. I think we have to end the session, please.
Yeah, exactly. We are spot on. It's 9:15. Over to you now. Thank you very much.
Thank you very much for all the speakers. Thank you very much.
Thank you very much, Dr. Asma, Dr. Anurag, Dr. Asmadeep, Dr. Manal, Dr. Nando for the excellent session. And now we are moving to the second session, pediatric orthopedics. Now I'd like to request Dr. Kalpana Sen Gupta, the secretary of the club, to introduce the chairman of the next session, please. You.
You introduce him, doctor. You introduce him.
I think Dr. Kalpana is having a problem connection. I would like to introduce the chairman of the next session, Dr. Fowling, senior consultant pediatric orthopedician, earlier in the Mediclinic City Hospital. Now I think he has moved to the King's College Hospital, if I'm right. Now I would like to request Dr. Fowling to start the session and introduce Dr. Sattar, please.
Hello, good morning, everybody. It's a very pleasure to be here. Thanks, Dr. Sarad, for the invitation. Thanks for the committee colleagues from the organization. It's really enjoying to have this. Thank you for the invitation. So it's a pleasure for me to introduce Dr. Sattar Al-Sharid, that is trauma and pediatric orthopedic surgeon consulting at Al Jalila Children's Hospital. He has a huge experience on the treatment of children and also the teaching. He has books published, and so I think it will be a very interesting topic. He will for the pediatricians. Without any delay, I would like to introduce Dr. Sattar to start his presentation, and after that we have some questions that he can take. Okay, thank you very much, Dr. Sattar, please.
Thank you very much. Thanks, Dr. Fowling. Thank you very much for the organizing committee to invite me. I must confess, I woke up early this morning just to listen to the initial lectures. And it was really interesting to listen how things advanced in other fields and how to interact with each other, bring us a lot of knowledge that we can use in our practice. I hope what I'm going to present today to you guys will you find it useful. I'm going to share my presentation. You give me 2 seconds. Can you see my screen?
Yes, Sattar.
Yes, Doctor, please.
Go ahead.
Okay. So I'm Sattar Al-Sharid. I'm a pediatric orthopedic surgeon and I work at the Jalila Children's Hospital. The objectives of my talk today, which hopefully we develop a safe approach on how to handle pediatric orthopedic conditions, overview of the kind of orthopedic conditions that you may face in your practice, and at the end, I'll pay a tribute for a pediatric orthopedic legend who really contributed a lot to the pediatric orthopedic services across the world, and some of the useful resources that he founded for us to use. As I'd said, we published several books to cater for different people need. One of the books that I'm really proud of is the one I edited with Dr. Nando, who presented earlier, where we put a book for pediatric orthopedic for primary healthcare and pediatrician. If you have a chance, there are a few copies in Muhammad bin Rashid University. Please have a look at it. You might find some of the topics useful. So, why children come to orthopedic? Most of the children, if I put them in 3 categories, they come for one of these reasons. Either deformity, abnormal function, including limping, abnormal walking, and pain. Rarely they come for other conditions. And our pragmatic approach was, is this within normal? If it is, then we reassure the patient and discharge them. We try not to follow children unnecessarily. However, we come across some very worried parents that we offer them a review in a year or 2, just to ensure that they're not going to go around trying to shop for different advice. If they're abnormal, we advise these children to be referred to us for treatment. If you are unsure, which is a common situation, not just for you, even for us, either we advise to refer them, call and discuss, or review again. I like this graph because it will always shows this element of uncertainty. This is the present state of knowledge. This is the perfect state of knowledge. Whether you have the present state of knowledge or the perfect state of knowledge, there's always an element of uncertainty there. And this sometimes is irreducible. But what is reducible is this gap between the present state of knowledge to the perfect state of knowledge. This area can be reduced. This area of uncertainty can be reduced with educations, with courses like this, with experience. So this is what we aim at. And this is not going to reduce on its own. It needs active work on it to be reduced. What things that we don't like it to be missed because they are time sensitive, in the first 6 months of life is DDH and club feet. Between 4 to 14 years old, we don't want birthdays or surgery to be missed. And at any age, malignancy and sepsis should not be missed. So if you remember, if you don't take anything from today's talk, if we focus on these 4 areas and not to get them missed, that will be great. We'll start with normal variants because this is almost shared area between pediatrician and orthopedic, particularly in this part of the world. Before we talk about normal variant, we need to know what is normal. I don't know whether you have a chance to visit the Sharjah Science Museum. It's a beautiful museum. They have a lot of things really fascinating, but one of them is the probability machine. As you go in the door, you see it in front of you. And I love that one. I hope it will start. Sorry, let me remove the laser. Yeah. So this little bees, these can be anything in life. Height, weight, hemoglobin level. When you throw them through the probability machine, they look like as random. But amazing how no matter how many times you repeat this experiment, they always follow this normal distribution, the inverted bell curve. So as I said, whatever observation we see, for example, this is a child height, if we measure enough and we plot it with the frequency, we'll get the typical inverted bell normal distribution. We have the mean in the middle, and we have the spread of it measured by standard deviation. We as a scientific committee, we took the 2 standard deviation as the normal. And everything outside this standard deviation, 2 standard deviation is abnormal. So it could be outside the graph, but they're still normal. I'm sure you've seen this one, the box and whisker. The normal distribution curve can be presented in this way, where the middle of the box is the mean or the median. This is 1 standard deviation for the box, 2 standard deviation with the whiskers, and you have the outlier there. Okay. This can be plotted as quartiles, where the middle quartile in the middle, the third and first quartile on either side of the box, and lower and upper quartile is at the end of whiskers. But also, if we draw everything there, if we draw the outliers as well, we'll end with the centiles here. If you measure them 1, 2, 3, 4, 5, 6, 7, 8, 9, exactly the same 9 lines here. So most of us familiar with this one, but now we know the origin of this one, where it comes from. And we knew if it is something on the outside, this is really extreme. So probably is abnormal if it is outside these, the top line and the bottom line. Okay, so the 3 commonest variant we see, the end-toeing, flat feet, and both legs or no knees. And if we have time, we talk about the footwear. End-toeing, when the toes of the foot pointing inward, and this can come from any part from the spine to the big toe. And sometimes it is dynamic, caused by the muscles. But by far the commonest, really the commonest, femur tibia foot. I would say more than 95% of that I see in my practice who come to us the problem in one or all of these parts. If it is in the femur, we call it femoral torsion or persistent femoral anteversion. If it is in the tibia, we call it tibial torsion. And if it's in the foot, we call it metatarsus adductus. How we know where it's coming from? Very simple. We just lay the patient on their belly and we examine first the feet. Is the lateral border of the feet straight like this, or is it curved like this? If it is curved, this is metatarsus adductus. And sometimes we measure the severity of metatarsus adductus by using the heel bisector line. If we draw the bisector line, normally should go between the second and third toe, or the second interdigital space. For mild, it goes through the third toe. For moderate, between the third toe and fourth toe. For severe, it goes after the fourth toe. And this is called the black grading. In our department, we felt black grading is a bit too restricting. So we developed what we call the Dubai grading or degma, in which we use the toes. The normal goes between the second and third, mild is the third, moderate is the fourth, and severe the fifth and beyond. And this classification is being validated now in our hospital. If we go higher to the tibia, is there tibial torsion or not? We measure what we call the foot-thigh angle. This foot-thigh angle normally expected to be 0 to 20 degrees external. But if it is internal, this is defined the tibial torsion. Some children don't lie on their belly because they fear from injection or whatever the reason. So we can measure a sitting position. And this is how we measure it. It's not as accurate as their bone position, but it is better than nothing. At least we can monitor them when they are severe to make sure that they're improving. We go higher to the femoral torsion. How we measure it? We measure how much the thigh internal rotated versus external rotated. And normally the thigh should be internal rotated more than the external rotation by around 20 degrees, which denotes the femoral anteversion angle. Anything more than this considered abnormal. Most of the children with femoral antetorsion, they sit in the classic W position, which initially make it worse. That's why the in-toe secondary femoral torsion usually present more commonly after the age of 3, rather than at birth or when they start walking. And part of the reason because they get worse by sitting in the W position. So treatment, all these torsion, they correct spontaneously. For metatarsus adductus, usually resolved by the age of 5 or even earlier. We usually get the parent involved with serious stretching. Also, the evidence doesn't support that they make a difference. Usually, naturally, they get better. But when you get them involved, at least they feel they are doing something. If the deformity is rigid with medial crease, sometimes we use serial casting, put them in a cast slightly to make it outside. There are several orthoses has been described, which I have no objection if somebody wanted to use them. I'm going to show a couple of examples. Surgery is rarely indicated and definitely not before the age of 5. This is a rigid metatarsus adductus. You can see the medial crease there, but it is sort of correctable. So this is, it was severe because it goes beyond the 5th toe, but it's correctable. We put 1 or 2 set of casts to improve it. This is important picture here because it differentiates this from club foot. Metatarsus adductus, it is a forefoot deformity. It's not a hind foot deformity. So the hind foot here is normal, excluding the club foot. Something you need to bear in mind when you treat or when you give advice for this condition. These are commonly used orthoses to treat metatarsus adductus, reverse forefoot shoes, and the buyback shoes, where you can change the angle there. This is usually, I use it very young children with severe one, and this is older walking children. But as I said, I rarely use them, but if the parent wanted something to be done, this will be my options. Persistence after the age of 5, particularly severe one, and I see this more in neuromuscular patients, I do surgery on them. And the surgery, usually, I shorten the lateral column. If you imagine the lateral foot is a curve, so I shorten that curve. If the foot is shorter than normal, But if the foot already short, I do medial column lengthening so that I wouldn't lose any more thing. This is an example for a child with spina bifida who had severe metatarsus adductus. We did a bit of serial casting to improve it, but later we did some shortening of the lateral column to give them a better foot to walk on. We move to the second part of intern, which is tibial torsion. Tibial torsion, usually they spontaneously rotate outward by the average 2 to 4 degrees a year. So if you calculate, if you take an average of 3 degrees a year, by age of 5, most of them, they rotated outside by 15 degrees. Statistically speaking, 3% of the adults show persistence of major tibial torsion. And usually this is, again, in children with a neuromuscular condition. Orthosis is unnecessary and often ineffective in tibial torsion. Now we move to the second part, which is board legs and knock knees. And I love this picture. This is my little daughter on the left, and this is her friend. They're born in the same week. They celebrate their birthday on the same week. And my daughter has gena varum, and this daughter has gena valgum. And this is what worries parents. This is when they see two children of the same age, or they compare their children and they find different, it gets them worried and they come for advice. I'm sure most of you are familiar with Selenius curve. Selenius in 1969, he did a study on around 1,000 X-ray, and he studied whether the lower limb of a child in varus or in valgus, and he measured how much the varus and valgus. And he found that children, when they're born, they have gena varum of about 15 degrees. And as they get older, this is the age here, it becomes straighter and straighter and straighter till the age of 18 months usually, when the knees become fully straight. Of course, there's a spectrum of that. And the green area is the 2 standard deviation of the mean, which is the blue line. When they reach at 18 months, they become straight, but then they go into valgus. And this valgus increase to the age of 3 and 4, which reach around 10 degrees, sometimes even more if you look at that spectrum. Then after the 3-4, it will come down till the age of 7 to 8, where it stays around 5 degrees. And this 5 degrees will continue with us for the rest of our life. So that's interesting observation that slightly give us more insight to the condition. So rule of thumbs, when I get worried about gena varum and gena valgum, gena varum is likely to be abnormal if present after the age of 2. If it is unilateral with asymmetry of more than 5 degrees, if the child is short in stature or short-limbed, if it is severe, beyond the 2 standard deviation of the mean depicted by Selenius curve, or in obese children. These five things make me really worried about gena varum. For gena valgum, again, if it is unilateral, or if it is severe. By severe, we measure the intermalleolar distance, the ankle intermalleolar distance. If it is more than 15 centimeters at 5 years or more than 10 centimeters at 10 years, I consider these are abnormal and merit referral or indeed intervention. This is how I measure the intermalleolar distance. I don't measure them supine because it can be inaccurate, but I make them stand and knees just touching, then I measure this distance. Even if they were normal, what I mentioned earlier, even if they were normal, it doesn't mean that we become oblivious. We should still think about potential causes. If they have any features of any of these conditions which cause both legs or knock knees, it doesn't mean that we dismiss them. So we still look for causes if one of the, if for any of these on the list. If they are there, even if the measurement within normal, I still take it seriously. How we treat gena valgum and gena varum, if they do need treatment, is usually we use guided growth. Basically, this is the mechanical axis. We love in orthopedic. When we draw a line from the center of the hip to the center of the ankle, it should go at the center of the knee. We call this mechanical axis, and this indicates where the force or the body weight goes through. And we need it to be in the center of the joint. So this child had gena valgum. You can see the mechanical axis outside the knee, and we treat it with guided growth, where we slow the growth on the medial side of the femur, so it continues to grow from the outside, and it's corrected to normalize that. Mechanical access, this is has what we call them the zones. Normal mechanical access should go in zone 1. If it is in zone 1, it is normal. Zone 2 is abnormal, but if the child is asymptomatic, we usually just observe it, doesn't need treatment. But if it hits zone 3, even if the child is asymptomatic, we recommend treatment. Now, when we face gene variant, we always ask ourselves, is this a plant disease? And the first question we ask, do we need to get X-ray on these one? We love the cover-up test because really it is very specific and very sensitive test. When we cover the foot and the lower limb, and we check, is the knee still in varus or in neutral? If indeed, if it is in varus or neutral, we do get X-rays on these children. This is the indication for X-ray. And the several studies show that's very, very specific and very sensitive. Just this is the next, another photograph to show you what we expect the cover-up test. This is a child who came to us with gene variant. We did the cover-up test, and you can see his knee in valgus actually is not in varus. So this child have apparent gene variant, not true gene variant. What I mean by apparent, we see the back of his knee. So this child, we don't X-ray them at all. But the child before, we do X-ray them. And this is a comparison between the two children. This is gene variant in neutral, while this is gene bulgum. This child doesn't need an X-ray, but the child does need an X-ray. And when we do the X-ray, we have several angles and lines we draw on these X-rays. Usually there are 6. We call them the 6 digit of Blount disease, namely tibiofemoral angle, mechanical axis deviation, epiphyseal metaphyseal angle, metaphyseal diaphyseal angle, femoral metaphyseal diaphyseal angle, and the femoral tibial ratio of a McCarthy. And there are certain numbers in physiological, and there are certain numbers in Blount disease. Most of the time we see overlap between these angles. But in general, a rule of thumb, if they less than 2 of them are positive toward the Blount disease, we consider this as physiological. If there are more than 4 with the Blount disease, it's most likely to be Blount disease. In the gray zone, it depends on the age of the child. If the child is still very young, we might see them in 6 months' time. But if the child is closer to 3 years old, we might start treatment for Blount disease. Okay, so now I think we've finished with the gene variant, gene bulgum. We move to the flat feet. Again, the message I hope I cross to my colleague is that flat feet is a clinical sign and not a disease, and it should be treated as such, similar to pale, tachycardia, and tachypnea. Pale, some people could be pale because of anemia, but some people could be pale because it's the color of their skin. So flat feet is not any different. We see it in physiological condition, like developmental flat feet, hypermobile feet, calcaneal valgus feet. All these are physiological. And the characteristic of them, they are common, they are benign, they are asymptomatic, and they are flexible. But also it could be part of several diseases, like tarsal coalition, congenital vertical talus, neuromuscular foot, tibialis posterior dysfunction, accessory navicular bone, could be result of trauma. Usually these ones, they are uncommon, they require treatment, they have symptoms, and they are stiff. But all of these conditions, they present as flat feet. People try to define what is a flat feet, and the common definition we find in the book is a foot with larger plantar contact area. And what is larger than normal, but normality never known in the flat feet. There are several people try since to measure the flat feet as early as 1957. Morley tried this method, then another guy tried this method, and Stahedi tried this method, but these never correlated with a clinical finding. So never taken off. Many people don't bother with measurement. So in children, the commonest cause for flat feet is the developmental one. When the children born, they have flat feet. And the reason why they do have flat feet, because most of the tarsal bones are still cartilaginous. Young children have intrinsic laxity of ligament and tissues. And neuromuscular control and muscle strength in children is still developing. They're not strong enough to restore their arches. And young children also possess a fat pad beneath the medial longitudinal arch, which bulge medially on standing. This is plain X-ray of a newly born child. You can see from all the tarsal bones, which 7 of them there, only 2 are ossified. This area here is not empty. There are several bones here, but they're made of cartilage, and we cannot see them on the X-ray. That's why the child is stand, the arch disappears. So we get worried about flat feet in children if one of these three signs are present, and we call them red flag signs of flat feet. Number one, if it's rigid. Number two, if it's painful. Number three, if they are severe. By rigid, what mean when the child with a flat foot stand on the normally, we see the heel in valgus and there's no arch there. On tiptoeing, they stand on their toes, we see the heel move inward and the arch is formed. So this is flexible, this is not rigid. I hope I have an X-ray. Sorry, yeah, so this is flexible. Children who cannot stand on their toes, we can do what we call the jack test, either in supine position like this or on standing position. This is a comparison to a rigid flat foot. If you can see, this child had a flat foot on the left side, the heel and valgus, but on tiptoeing, you can see this side moving inward and the arch is constituted. But on this side, the heel does not move in versa and the arch remains flat. So this side is rigid. Okay. And you can see what we call it the too many toes sign. You can see the toes from this side. And also you can see some skin scaling here because he was treated in a cast, indicating that it was symptomatic, this side. By severity, what we mean by severity, remember the three red flag is flexible, is rigid, painful, or severe. Severity, we mean by severity when they stand, the lateral border of the foot is off the floor. This is happening, we consider this as severe. It doesn't mean it needs treatment, but it needs follow-up. We don't discharge children who have severe flat feet. We discharge children who have who doesn't have any one of the red flags. If it's not severe, if it's not painful, if it's still flexible, we reassure parents from discharge them. We don't keep them in follow-up. But if they have severity, if they severe like this, we simply follow them up. Pitfall, I find often people confuse a flat feet with ankle deformity. There are certain ankle deformity present as a flat feet like this child. And the clue for this one is the lateral malleolus should be lower than the medial malleolus by around a centimeter out. But if they are the same level, the deformity usually in the ankle, not in the foot. And when they stand, these children, they have normal feet. And how we know these, we get X-ray. And you can see this child have very tilted distal femoral angle. And in fact, the whole epiphysis is like a wedge shape. And this one is usually different from the other one. Sometimes they do need treatment, this condition, either by orthosis or sometimes what we call a medial epiphysiodesis. Similar to the guided growth we saw earlier in the knee, we can use it in the tip. And we change it from this tilt into a straight line. A flexible flat feet on its own doesn't need treatment, just reassurance and discharge patient. As I said, if there's no red flag sign, orthotic and operative treatment are often not required. If there's tightness in the tender Achilles or gastric muscles, the exaggerated flat feet, and these might need stretch. There are several trials showed no benefit. One of them looked at 129 patients, properly conducted trial, and 3 years, there was no difference between control and all these orthoses. No long-term effect on the shape of the foot. One study by Tim Theolakis in 1994 showed children who have symptoms, the symptoms might get improved with orthosis. Again, remember what I said, if they are symptomatic, probably they are not flexible flat feet. There's other sources for it. Staheli, 1997, he showed a detrimental psychosocial effect on children who use orthosis for flat feet. Never to mention
you have 5 minutes, Dr. Sattar, for
sure.
question and answer.
Sure. Yeah, thank you very much. Thanks. Yeah, I love this study by Benjamin Joseph, who looked at over 1,000 children, really. He didn't do anything about the fact that he grouped them into 4 groups: barefoot people, children who wear slippers, children who wear sandals, children who wear shoes. And he found children who walk barefooted, 2% only remain flat-footed, to compare to the children who wear shoes. They have 13% flat-footed. So the more you support the foot, thinking that you're going to improve the shape of the arch, actually you're achieving the opposite. I really would like to finish with a different condition. We call it adolescent acquired flat feet. And this is completely different from the flat feet we mentioned earlier, the developmental one. These are children who already develop arch, but they lost it. And we see it commonly nowadays. Why? Because there's lifestyle change. Now, most of our children are really hooked to tablets. They're almost addicted. If you take it from them, they do cry. Before, in my time, our parents struggled to bring us from the street to home. Nowadays, the opposite. We see mothers struggle to get their children out. So what could go wrong with these children? What could go wrong with these children? The muscle become very tight because the bone grow, and normally the muscle gets stretched when we run and when we play. But when this doesn't happen, they become short and the children start walk on their toes. I'm not going to dwell too much of this one, but what would happen, they develop acquired flat foot. They already had arch, but they lose it. And when we do the x-ray, we see the subluxation of talanavicular joint. And this is unfortunately become really common. Yes, we can fix it. We can do surgery. We can lengthen the tendon and we can correct the foot and we get nice arch. But it's really, this is a preventable condition. So this is pre-operative and post-operative. We restore the talanavicular joint. But the sadful thing is this condition is really preventable. And we need to bring people awareness for it. Finally, tribute to this man. He died last year. He's Linus Tahiri. I'm sure most of you heard of him. He was a legend. He developed what we call a global health org. He's a pediatric orthopedic surgeon, so initially start for pediatric orthopedic. This is the website he developed. You can click any part of this child and you have valuable information. He had a lot of useful videos in this website, and not just for physician, but also for parents, and in many languages. For example, this one of his leaflet, which I really love, about flat feet in towing bentload, and in many languages from Arabic, English, Greek, Russian. So whatever your patient is, you can print it to them and give it to them. And I'll stop here. Thank you very much.
Thank you, Dr. Sattar. I don't know if we have time for any question. Dr.
2 minutes, 2 minutes, please.
So I have just 2 minutes. I think, Sattar, one thing that the pediatricians may be interested, we don't have questions yet. How about the growing pains, the pains in the lower limb, and what is the red flags, if you can tell us like in 30 seconds, what's your red flags, and because it's quite common that complain about lower limb pain. Sometimes we see some misdiagnosed because growing pain.
Yeah, so thank you very much. This is a really very good question. I really hate the word growing pain. I do believe it's real, it's present, and I explain in this diagram, but that's why I went back to it. But the problem is that look for other side, make it diagnosis by exclusion, not by inclusion. What we knew children grow from their bone. Each long bone had two centers, one at the top, one at the bottom, one at the top, one at the bottom. Initially, the bone grew, then the muscles followed. How the muscle followed? When the child plan or run, all these things. But when they don't do that, the attachment of the muscles become painful. And not just the attachment of the muscle, sometimes if it's attached to epiphysis, for example, Sever's disease at the back of the ankle, Osgood-Schlatter disease at the front of the knee, all these type of growing pain. But also sometimes a less named one, which is when the muscles have too tight and you have to fight, the child fighting when they play and run. So these are real, they are present. The growing pain is real, but because people use it as a diagnosis and can really make them less willing to investigate other causes, it might put children at wrong diagnosis. So for me, growing pain, although it's real, although it's a present, is a diagnosis by exclusion, not as a primary cause. I hope.
Thank you very much. Thank you very much. Yeah, Dr. Sattar, sorry, we have to move to the next session.
Thank you very much.
I would like to thank Dr. Eddie for that. He's a senior consultant pediatric orthopedician at Mediclinic, Parkview Hospital. Now he has moved to new place. He will announce it. And I'd like to thank Dr. Sattar also. Dr. Fognit, please tell your new hospital so that the viewers can know. Because it was formerly Parkview.
Formally, no, currently now, isn't it?
Dr. Fognit, where is your current hospital? I think he's mute. Thank you very much. Thank you very much.
Parkview, currently Parkview. He was in King.
Yeah. So I will correct Dr. Eddie at Parkview Hospital, Medical Clinic, Parkview Hospital, Dubai. Thank you very much, Dr. Dr.
Thank you.
Nice session. We enjoyed. Now we move to the next session. Very important session, pediatric immunization. I would like to request Dr. Kalpana Sen-Gupta, Secretary of the club, to introduce the chairman of the next session and start the session. Please, Dr. Kalpana, over to you.
Thank you, Dr. Sohrab. It's my pleasure to introduce Dr. Ahmed Al-Suwaidi, who's the pediatrician and infectious disease physician, associate professor at UAE University, Alain, UAE. Dr. Ahmed Al-Suwaidi, I now request you to take charge of the session. Thank you.
Assalamu alaikum and good morning, everybody. Thank you very much, Dr. Kalpana, for the nice introduction. It's a great pleasure and honor to chair this important session. I've been enjoying the discussion, the presentation from early morning. It's well done presentation. So it's also a pleasure here to introduce the moderator for the session, Dr. Subramania Krishnamurthy, who's well known to most of us here in UAE because he worked in UAE in several institutions, including Al Jalila Hospital before moving back to India, where he's currently head of a department at GG Hospital in Trivandrum, Kerala. Dr. Krishnamurthy, the floor is yours. Thank you.
Thank you. Thank you, Dr. Suwaidi. And thanks for the viewers for joining the session. I would like to introduce my panelists at this stage. We have three eminent panelists joining me in this session. One is Dr. Fatma Alama, who is very much known to you. She is the head of Child Health Services at the Department of Health in Dubai and is involved in making policy decisions regarding immunizations and child health activities in Dubai. The second person is Dr. Waleed. Waleed is the head of pediatric infectious diseases at Al Jalila Children's Hospital, and he has been my colleague and a very senior professor from the US initially. He has settled down in Dubai, and I very much respect his opinions. And the third, but not the least, I've been fortunate to get in touch with Dr. Shamas Ladani, who is a pediatric infectious diseases consultant at the St. George's Hospital in London. And he is also a member of the advisory panel for vaccinations in the UK and is an authority on pediatric vaccinations. So with this, I would like to share the screen to start our presentations. Can you all see the screen?
Yes, doctor.
Okay.
You can go to the presentation.
Right. So this was the introduction, right? The panelists, and Dr. Ahmed Al-Suwaidi, senior consultant, has kindly taken over as the chairperson for this session. Now, the learning objectives of this session are, at the end of this presentation, it is expected that the learners will have a better understanding of the vaccines used in children, will be more confident to answer parental queries on childhood vaccines, and be able to adopt changes to their practice on the basis of the information shared, and most important, be advocates to vaccination, which has been the most useful intervention of the century to prevent childhood mortality and morbidity from vaccine preventable diseases. I believe the objectives are quite simple enough. Moving on, the way that I would be conducting this session is in the form of questions that have been asked many a times on various vaccines, and the panelists, I would invite the panelists to give their answers on these sort of questions that are often raised. So let us start with the BCG vaccine. The queries often raised are, is it necessary, safe, and effective? Many of you might be aware that in the US, BCG is totally not given to any of its people. So is CDC fair to its people in the US by withholding BCG totally when TB is still rampant elsewhere in the world and cross-country travel is becoming more frequent? And second, is there a better and safer BCG vaccine in the pipeline? I shall try to answer these questions in the next couple of slides. What is known about BCG vaccine is that it is a live attenuated vaccine containing a strain of Mycobacterium bovis. Meta-analyses have shown that it offers 70 to 80% protection against severe forms of the disease, and the protection lasts for about 15 years minimum, with some studies showing that it lasts even up to 60 years. Protection may wane with time, but repeat vaccination is not advised at any stage. And in endemic countries in the world, according to a WHO study, the vaccine coverage exceeds 80%. This is available as a freeze-dried vaccine to be stored between 2 to 8 degrees centigrade and reconstituted just before use, and to be used within 4 hours. 0.05 ml intradermally at the insertion of the left deltoid is the conventionally recommended dose in children under 12 months of age, and 0.1 ml in those who are more than 12 months of age. No other vaccination should be done in the arm receiving BCG for at least 3 months to reduce the risk of regional adenitis. And live attenuated vaccines can be given anytime before or after the BCG vaccination. I think you must be fairly aware of these. Now, what is the global position regarding the BCG vaccine? UK recommends BCG vaccine soon after birth in infants with a parent or a grandparent born in a country with an annual TB incidence more than 40 per 100,000 population. In infants living in areas of UK having a TB incidence more than 40 per 100,000 or staying in any part of the world for more than 3 months with high TB incidence, it is given. Previously unvaccinated children under 5 years with the above history or living in high endemic areas, there is no need for a PPD testing. They straight away get BCG. And any previously unvaccinated tuberculosis negative individuals of 5 to 16 years of age are offered BCG, and it should not be given in pregnancy. Now, answering the question, I personally do not think that it is fair from CDC point of view to withhold BCG vaccination from people in the US. BCG is not recommended there, but with 10 million new cases and 1.4 million deaths reported due to TB worldwide, I don't find a reason. And with cross-country travel becoming more frequent, I believe that they also have the right to be protected against severe forms of the disease. Now, because this conference happens in the UAE, UAE is classed as a high endemicity area for TB by the WHO, and BCG is given straight after birth. If you do an IGRA test, that doesn't affect, previous BCG vaccination does not affect the IGRA test. And the good news is that recombinant BCG vaccines are in phase 3 trials and are promising. So let us hope that with the passage of time, we would have more stronger or safer vaccines, safer and effective vaccines against tuberculosis. Moving to the next question, the query often raised is, do we need DTWP, which is a wholesale vaccine, or do we need the DTAP? Are we compromising efficacy for safety by recommendation of routine DTAP in the West, while DTWP is still being used in other countries? I would invite Dr. Shamis Lidani, pediatric ID consultant and member of the UK Advisory Panel on Childhood Vaccinations, to try to answer this question. Dr. Shamis.
Thank you very much for that question. You're absolutely right. We had some amazing wholesale pertussis vaccines in the past, and they worked extremely well in terms of protecting against whooping cough. And the reason that we moved away is that these wholesale pertussis vaccines were very reactogenic at the time and therefore caused severe reactions in a small proportion of children. And some of them could be very severe. And there was a concern that parents would stop vaccinating their children against pertussis and then against other infections as well. So there was a gradual shift from wholesale pertussis to an acellular pertussis containing vaccine in the 1990s. And these acellular pertussis were found to be protective against pertussis disease, but they only contain a few antigens from Bordetella pertussis, the pathogen that causes whooping cough. Both the wholesale pertussis and the acellular pertussis containing combination vaccines have been shown to be protective against pertussis disease. But the acellular pertussis vaccine looks like it doesn't protect against infection. So you can still get infected and maybe pass it on to others, but you may not get disease yourself. Also, there's some studies suggesting the acellular pertussis containing vaccines may give a shorter duration of protection compared to wholesale pertussis, which means that we may need more boosters than we would have had with wholesale pertussis. The wholesale pertussis vaccine has been very successfully used in many parts of the world, and it continues to be used very successfully, but many of the other countries have moved on to acellular pertussis. The most important new event in these vaccines recently is an increase in severe hospitalizations and deaths in infants under 3 months of age. And many countries, including the UK, have advocated an acellular pertussis containing vaccine in pregnancy to protect newborns until they're vaccinated at 3 months of age. We and others have shown that maternal vaccination is very effective in preventing neonatal and young infant infection and death due to pertussis. Next slide, please.
Thank you, Dr. Shamas, for enlightening the audience on the current issues with the wholesale pertussis vaccine, as well as highlighting the need for the vaccinations during pregnancy to prevent newborn infections. Let us move on to the next vaccine, the pneumococcal vaccine. We have moved, the questions that are often raised are, we have moved from 7 to 10 to 13 and maybe higher valent vaccines for pneumococcus over a short span of 10 to 12 years. Why do we need to keep on increasing the number of serotypes in the pneumococcal vaccine? And do we need to administer polysaccharide vaccines after 2 years of age, even if you have given the pneumococcal vaccine? I would invite Dr. Fatma Alama, the head of DHS Child Health Services, to answer these questions now. Dr. Fatma.
Assalamu alaikum. You can hear me? Assalamu alaikum wa rahmatullah. Good morning, everyone. Many thanks for this very nice, excellent organization. So regarding a pneumococcal vaccine, actually PCV13 is a conjugate vaccine coming after PCV7 and 10. And it is effective against 13 common pneumococcal serotypes that cause serious illness in children. Usually 3 primary doses at 2, 4, and 6 months, and booster dose at 12 to 15 months is recommended in UK and CDC, and 2 primary doses with a booster in Europe. But in UAE, we used to give 3 primary dose and 1 booster dose. And since October 2019, the recommendation is to give 3 primary dose, 2, 4, and 6 months without booster dose. And regarding polysaccharide pneumococcal vaccine 23, it is a 23 valent vaccine. It is ineffective under 2 years, as all known. It is given to high risk population over 2 years of age. It's single dose 0.5 ml given sub-Q or IM. It is repeated once after 5 years in immunocompromised people. Usually PCV13 and polysaccharide pneumococcal conjugate vaccine 23, if being considered scheduled it should be spaced by 8 weeks. Routine PPSV only for high risk situation like aspilinia or immune deficiency given. And for catch-up vaccination with PCV13, we can all go to download CDC because there is very nice recommendation is there. So if PCV catch-up vaccination, if first dose is taken less than 12 months, we are giving 2 further doses at a minimum interval of 4 weeks if a child present before 15 months of age, while if the first dose was taken between 12 to 14 months, we have to give another 1 more dose at least 8 weeks after the first dose. And if child presented after 15 months with no previous PCV, only 1 dose of PCV is recommended. A single dose of PCV13 is recommended for healthy children 24 months to 4 years of age with any incomplete schedule, including those who have never been immunized. So serotype replacement regarding your question, pneumococcal disease happens after all PCVs, so we need higher valent vaccine to keep up. National surveillance and early identification of invasive pneumococcal serotype is the key to prevention. Continuing research and PCV is necessary to lessen the impact of disease.
Thank you, Dr. Fatma, for the wonderful insight about PCV. Let us move on. The human papilloma virus vaccination. I know that it is recommended in many parts of the world, and there has been queries on its recommendation in several parts as well. Now, here is a question that is often raised. Even though HPV infection is universal in women and clears spontaneously, it has an oncogenic nature. So by offering routine HPV vaccination to teenagers, are we condoning teenage sexual behavior? Dr. Waleed Abu Hamor, head of pediatric infectious diseases at Al Jalila Children's Hospital, will try to answer this question. Dr. Waleed, over to you.
So Dr. Waleed has some technical issues. So if someone else can take it, Doctor.
Any other panelists want to debate, to discuss this? Dr. Shamas, would you like to take this on?
Yeah, so essentially the HPV vaccines were originally designed to protect against the main HPV serotypes that cause cervical cancer. And cervical cancer, as you know, is a serious and fatal condition that that is one of the major causes of cancer deaths in young, healthy women. The vaccines that were produced have continued to increase over the time to provide better and better protection. And one of the advantages it has is it can protect against genital warts, but we're also finding a whole new range of conditions that were previously not known to be caused by HPV and cancers in men that we weren't aware of that were responsible with HPV. So the new vaccines are in a really good place right now in helping protect against not only cervical cancer, but other cancers, male cancers, and genital warts. The question about whether HPV vaccines are used to condone HPV is used to condone sexual activity has been going on for many, many years. There is no evidence at all that this is happening. Sexual behavior in teenagers is very different in different parts of the world, and one has to take into account the local attitudes towards sexual behavior in different age groups when considering this question. Early sex, multiple partners, and such risk factors have been proven to be the main cause of HPV infection, persistence, and progression. HPV vaccine certainly prevents HPV persistence if given early enough, and therefore the priority should be to get the vaccine into your local community as soon as possible, and ideally before sexual behavior begins. Vaccination does not condone teenage sex or high-risk behaviors, but it does reduce the risk of malignancies such as cervical and oropharyngeal cancers in young, healthy adults.
Thank you, Dr. Shamas. That was enlightening the audience on the importance of HPV vaccination, both for boys and girls, and how it can protect them. Moving on, Now, this is a question about rabies vaccination as well as immunoglobulins. I think people who have been looking at the lay press in India would have been worried about rabies that has been still reported in the press in fully vaccinated individuals in India. How do you account for this? This is a question that is often raised here, and in the Indian Academy of Pediatrics, this was raised, and at many levels this came up for discussion. I shall try to answer this question for you. Now, stray dog bites are the commonest cause of rabies in India, and control of stray dogs and mandatory vaccination of pets is possibly the solution to control of the disease in the long run. However, this is not possible in the short run because there are any number of stray dogs, roaming around in many parts of India. There are universal guidelines that exist on the timing of vaccinations and the use of immunoglobulins in dog bites. And it also mentions what is it that should be given in the different classes of dog bites as well. Physicians, unfortunately, are not fully adhering to these guidelines, and people also don't adhere to these recommendations, and that is one of the reasons why the disease is still rampant. They take immunizations partially and say that they have taken it fully, and that is why the disease is still making its appearance. Now, obviously, when a person develops the disease after receiving the vaccine, there is always a question mark on the efficacy of the vaccine, about the storage of the vaccine. Did it help to retain its potency and all that? And this was studied at length in India. And the questions on efficacy as well as maintenance of potency has been dispelled through studies and rational investigations of the circumstances in reported cases. And therefore, I can say with confidence that the current used anti-rabies vaccine is definitely effective, and people should be following the guidelines more to make sure that people don't get rabies. Unfortunately, rabies is a disease for which once you get it, there is no treatment available, and therefore it's always worth preventing the disease. Now let us move on to the next vaccine, which has been a bit of a controversy of late, right, about the meningococcal vaccinations. You are aware that UK and US follow different timings. In the UAE, it is completely different. There is a quadrivalent vaccine, there is a pentavalent vaccine, there's the Men-B vaccines and all that, which adds to the confusion and all that. I think the audience would very much appreciate an explanation from Dr. Shamas Ladani, who is an authority on meningococcal vaccinations, about further highlighting the audience on this, please. Dr. Shamas.
Well, thank you very much for that question. The first thing I want to mention is that there are 12 different meningococcal groups that can cause a meningococcal disease, and 6 of them cause invasive disease in humans in different parts of the world. So it's really important to understand the serogroups that are causing meningococcal disease in your region to decide which vaccine to use. Just because a vaccine is available doesn't mean that you should be using it if that risk is very low in your area. Next slide, please. So the most important thing to remember is that there are 2 types of meningococcal vaccine. The first type of vaccine is a conjugate vaccine, so the Men-C vaccine and the Men-ACWY vaccine is designed by taking the outer sugar capsule of the meningococcal bacteria and connecting it to a protein to make a conjugate vaccine. These vaccines are very, very effective, not only in preventing invasive disease, but they also block infection and transmission, and they can cause herd immunity. So meningococcal ACWY vaccine is given to teenagers in the UK, for example, and because they are the main carriers of these meningococcal serogroups, you get herd immunity and the whole country benefits from the ACWY vaccine. In contrast, there are 2 different vaccines against against Men-B, which are made out of sugar, which is not made out of the sugar coating of meningococci. The reason for that is that the sugar capsule of Men-B is very similar to human nerve cells, and therefore it's very poorly immunogenic. And the pharmaceutical companies are concerned that if they make a vaccine against MenB and if it induces autoimmunity, then that would be a waste of a vaccine. So they've taken more than 20 years to make a protein-based vaccine. There are two big protein-based vaccines for meningococcal B. Both of them are very effective, but they only provide personal protection and they don't provide herd immunity. So for that reason, we use MenB vaccine in the group with the highest incidence of disease, which is in infants. I understand that the UK currently recommends the Men ACWY vaccine at 9 and 12 months, but not the MenB vaccine. And what you have to appreciate is what you have to do according to your local epidemiology to decide which vaccine to use. And that would be completely appropriate for your situation if you don't have a lot of MenB disease. There are two different types of pentavalent vaccines that you have to be aware of. One of them is the ABCWY vaccine, which is being developed by two different companies, and that will soon be out in the market in the next 3 years. But there's another pentavalent, which is the ACWY-X, which is being developed for the meningitis belt, especially for Africa, which is likely to come in much sooner and will provide protection against different meningococcal serogroups. So be careful when people talk about pentavalent vaccines. So the quadrivalent conjugate vaccines, ACWY, are recommended as 2 doses from 9 months of age and after 3 months of age. In the US, the CDC recommends 1 dose of the quadrivalent conjugate vaccine at 11 to 12 years, followed by a booster at 16 to 18 years in low-risk infants, and a higher schedule for high-risk ones, especially for infants who are recommended to have a 3+1 dose and then 1+1 if they're older. The CDC does recommend MenB vaccine as a single dose for young adolescents, the ones who are the second highest group of meningococcal disease after infants. But we in the UK have a much higher incidence of MenB disease in the first year of life. So we vaccinate our babies at 8, 16 weeks and then 1 year booster. And that has shown to be very successive in preventing MenB disease. The UAE currently recommends quadrivalent vaccines, as I said, at 9 and 12 months of age, but MenB is not licensed because the endemicity of MenB disease appears to be very low. The pentavalent vaccines ABCWY is going to come, and it may be that will be the only vaccine available, and then everybody can use the same vaccine. Thank you.
Thank you, Dr. Shamas, for providing clarity on the reasons why MenB vaccination is still not being used in the UK, because pediatricians have always been at loggerheads to think as to why it is happening, while elsewhere in the world it is not being given. And your explanations have been really an eye-opener for the pediatrician community here. Moving on, we have the rotaviral vaccines. We have the monovalent vaccines, the polyvalent vaccines, and there are different vaccines available in different parts of the world. And with people moving, is there a possibility that we can freely interchange between the vaccines? Which is better, mono, poly, or a combination? So this has been in the minds of pediatricians for quite some time. And I would request Dr. Fatma Lama to answer these questions, please. Dr. Fatma, over to you.
Thank you. So monovalent vaccine, RV1, they are giving at a 2 dose. It is oral at 2 ml, 2 to 4 months. And usually it is, we should not initiate the first dose if it was after 16 weeks of age, because safety is not proven. And we have another vaccine called pentavalent vaccine, which they are giving at a 3 dose. It is oral at 2, 4, and 6 months. And usually the maximum permitted age for the last dose should be 8 months. Usually it is not interchangeable and is preferable to complete vaccination using same vaccine. May not be practical due to some migration issue, because we have so many people coming from abroad and have taken the vaccine in their country and different series. So if only those include pentavalent when used interchangeably due to supply issue, 3 doses must be administered. India has indigenously developed other monovalent and polyvalent vaccine, both administered orally as a 3 dose and of 5 drops each time, starting at 6 weeks of age. I believe that 5 drops is very good because 2 ml is too much for a babies when you are going to give. It takes long time to give them. Rotaviral vaccine has been claimed to afford some protection against developing type 1 diabetes mellitus. So both RV1 monovalent vaccine and pentavalent vaccine are very effective in preventing rotavirus disease in infant. RV1 is 2 doses, but pentavalent is 3 doses. Aim to complete course with same vaccine wherever possible, but keep to the other recommended interval because risk of intussusception. Vaccinating infants will also protect those around them, parents, and also grandparents. Thank you.
That was excellent, Dr. Fatma, to give clarity on these questions that have been lingering in the minds of pediatricians for quite some time. And I have heard these in several conferences. So thank you for providing clarity on that. Moving on, now we have polio vaccines, the oral polio vaccines, the inactivated polio vaccines, and all that. And obviously the question that is, the world is aiming at polio eradication, and the commonly used oral polio vaccine is only bivalent. So should we move to inactivated polio vaccine, which contains all 3 polioviruses to achieve polio eradication? Why are we continuing with pulse polio immunization with OPV, particularly when it is only bivalent? This is a question that many pediatricians often ask, and many parents also ask us. I shall try to answer those questions here. Now, the Global Polio Eradication Initiative of the WHO, 2019 to 2023, aims to make the world polio-free by year 2023, which is next year. Oral polio vaccine has been in use for several years. It's a trivalent vaccine containing all 3 serotypes. But the major advantage is the cost, and the major challenge was the maintenance of cold chain, particularly in tropical countries. Mutations of type 2 in oral polio was noted to be responsible for vaccine-associated paralytic polio worldwide. However, the world was declared free of wild poliovirus 2 by the WHO in 2016. So we thought, why should we have, if the world is free of the wild poliovirus 2, why should we have the type 2 in the vaccine, which can cause vaccine-associated paralytic polio, and therefore the recommendation was made to switch from the trivalent to the bivalent OPV in 2016. UAE uses a combination of IPV and OPV. DHA recommends 1 dose of IPV at 2 months and subsequent 4 doses of OPV, whereas Health Authority of Abu Dhabi recommends 2 doses of IPV initially and 3 doses of OPV. Right. However, if oral polio is not available in any situation, there is no harm in giving IPV at that stage. And interestingly, with the increasing use of IPV, which is obviously costlier also, there has been issues regarding its supply. The world is not able to produce enough IPV for use of the population there. And therefore, people have innovated using smaller doses of these. India uses fractional doses of 0.2 ml intradermally of IPV, 2 doses for all children for reasons of availability as well as cost containment. And there have been studies to look at whether this is effective against full IPV. And interestingly, it has been found to be equally effective. So the message is that to keep the world polio-free, we don't need to have OPV totally. IPV and OPV, a combination, is equally effective with no incidence of or no chance for vaccine-associated paralytic polio. I hope the message is clear here. Moving on, the chickenpox vaccination. You are aware that chickenpox is a highly infective disease. It is vaccination against chickenpox is used in many parts of the world, but in the UK, they don't advocate universal chickenpox vaccination for its children at 1 year of age. Why is it that this is there? There is a specific rationale for that, and Dr. Shames will answer this question, please. Dr. Shames.
Thank you. So it's It's very unique that the UK does not offer a chickenpox vaccine compared to many other parts of the world. One of the reasons was that when the vaccines did become available more than a decade ago, the UK understanding of chickenpox disease is that when you have a child with chickenpox disease, that child will pass the virus to other children who may then get chickenpox disease. But what it also does is that it boosts adults' immunity by exposing them to the chickenpox regularly, and their adults' immunity, parents, grandparents, continues to remain very high. Next slide, please. But if you take away infection through vaccination, so children don't get infection at all, they will not pass the infection to others, so the rate of chickenpox disease will go down, but also the boosting of the adults will also be reduced because they're not being exposed to the virus in a natural environment. Next slide, please. And this led to a theoretical concern that by the lowering of natural immunity and boosting in adults, we would see much higher rates of secondary infections in adults. And we were concerned that the incidence of herpes zoster will increase a lot. And one of the ways that we were thinking we could mitigate that is when the zoster vaccines become available, we would be able to use that to offset the chickenpox vaccine. Now, this has taken a long time to sort out. This theoretical increased risk in herpes zoster hasn't really been shown to be a major problem in some countries, such as the United States. And the UK is looking very closely to make a decision about the chickenpox vaccine in the next few months to years. The pandemic just slowed down the process. But it is the odd country that doesn't give chickenpox vaccine because it's not severe enough, and we have good data to show that chickenpox rarely results in severe disease in children, and therefore the decision isn't considered to be a priority at this stage. Thank you.
Thank you. Thank you, Dr. Shammas, for giving the valid explanation for withholding chickenpox vaccination from children in the UK, and for considering and for giving us the message of the UK Advisory Committee that you are looking at reintroducing chickenpox vaccination shortly in the UK, which would be promising as well. Moving on, COVID has always been an issue that we have been having in the last couple of years. We have COVID vaccines that were given to adults, and now we are saying that these COVID vaccinations need to be given almost on a yearly booster doses and all that. Is it that this is going to stay as such? This is a question that often people have, particularly with some reported incidents of thromboembolic episodes and all that. I don't know if Dr. Walid is here. If Dr. Walid is here, I would appreciate if you could answer this question. Dr. Walid.
Yeah, good morning to all. And I would like to thank Dr. Sohrab, Dr. Kalpana, Mr. Tawfiq, and all the organizing committee. And for this session, special thanks for Dr. Krishna for putting this together, and for this really hard work, Dr. Krishna. Really appreciate it, and it's very informative to everyone. Thanks for this very debatable questions about COVID. And since the start of pandemic of COVID till now, it is still debatable. Nothing clear about this COVID viral infection, nothing clear about the pandemic, nothing clear about the epidemiology, how it behaves, and also when it comes to the vaccines, a lot of questions regarding this vaccine. In general, for any vaccines to be implemented, we have to look at the epidemiology, we have to look at the vaccine efficacy, effectiveness, we have to look at the cost, we have to availability of the vaccine, winning immunity, all of these. And of course, the epidemiology of this virus. If I start with the epidemiology, to be honest with you, and everyone I think will agree with me, still we don't know how it behaves, this viral COVID-19 infection regarding the epidemiology. I cannot find any seasonal preference for this virus. It seems year around, it seems in cold, in warm areas, in tropical areas. Nowadays, you know, there is, I would say, maybe resurgence of COVID-19 in China. We don't know when it will be another outbreak in certain countries. So the epidemiology, it is not well known, not well understood about this virus. In addition, this virus is unique in having many variants. And we have noticed that each variant becoming more tolerant to the available vaccines, which means we can't guarantee which vaccine will work for this virus or this new variant, and there will be a new change in the vaccine. Regarding the efficacy and effectiveness, which is very important part in any vaccine, it is variable. We know we have many different products in the markets, and everyone is fully aware about it, that it is variable regarding the efficacy from one product to another. And certain vaccines, it has to have 1 dose, 2 doses, 3 doses to complete the primary series. So again, the efficacy and the effectiveness, there is a great variation when it comes to the efficacy and effectiveness of this vaccine. We know that the aim of this vaccine is to prevent hospital admissions and to prevent the devastating outcome, but still not clear. And we have to study more about the effectiveness. As you mentioned, Dr. Krishna, most of these vaccines got approval on the fast track under emergency authorization. Post-marketing surveillance studies is still scarce, to be honest with you, and still we don't know much about it. So this is one factor to consider. Regarding the safety also, still not clear, particularly as you mentioned, in young age, you know, there is increased thromboembolic phenomena. We don't know the long-term the side effects of this vaccine, since it was not studied properly before getting approval from FDA. So a lot of queries about this vaccine. In addition, availability. So if we have to say will be annual booster dose for this, to start with, everyone fully aware that when we have the pandemic, there is disparity and there is discrepancies in the availability of this vaccine to different parts of the world. We know certain countries almost they had coverage of more than 80%, certain countries 1%. So if we have to issue a statement that, you know, booster dose, annual booster dose to be given, what about countries that they never immunized? This is one. Two, we know the aim of these vaccines, available vaccines, is to prevent severe outcome or prevent hospitalizations. But if the COVID-19, if becomes like common cold, it's worth it to have a booster dose annually, in addition to the factors that I mentioned. To be honest with you, my personal take on this, it is too early. It is too early to say, you know, it is recommended to give COVID-19 annual booster dose for the reasons that I mentioned. And I think I myself recommend that we have to wait to have better understanding about the behavior of this virus, the epidemiology, the waning immunity, what variants will be available, what about the new variants? It will be really severe like the first wave of this pandemic or not? All of these questions should be addressed fully and should be answered before we issue a statement that annual booster dose to be given.
Thank you
so much.
Thank you, Dr. Walid, for opening up your mind. about open thoughts about how COVID-19 vaccine was introduced and how it has caused tragedies the world over, and why it has been successfully taken in some parts, not in some parts, and why we cannot have a universal recommendation. That's really enlightening the audience on that. Thank you for that. Moving on. Now, there is often this question that is asked, right? Vaccination is as much for the individual as it is for the society. And these vaccines are provided free by the governments. And if the disease really happens, it causes a big impact on the public spending and all that. So given that the governments are providing these vaccines and that it protects children, proven to protect children, if parents say that, no, I don't want to give vaccines to my children, should it be accepted or should it be made punishable by law? How does this happen, or how should we be looking at this? Dr. Fatma, could you please answer this question?
Yes, thank you. Regarding legalization of vaccine requirement in UAE context, there are Articles 18 of Chapter 4 of Health Right under Wadima law in UAE stipulate that the child will have the right to receive health services according to the law and regulation of health care applicable in the state. And UAE believes in mandatory vaccination for all children to protect the society and is working toward invoking neglect under child protection laws to parents who default vaccination. There are other countries like Singapore where withholding vaccine from children is treated as a punishable offense. I hope that we also will reach that state. So legalization of vaccine requirement, it is debated topic. Some consider it as an infringement on their personal freedom of choice. Unvaccinated children pose a public health burden in addition to the danger for themselves from disease complication, with the state providing free vaccination, monitoring their safety and compensatory program being rolled for the odd, unfortunate, misshaped in vaccinated individuals, no valid reason to deny vaccination to children from personal and public health viewpoint. So education rather than legislation could be the solution, and we have to stop the rumor about vaccine from social media. That is the best way. Thank you.
Thank you, Dr. Fatma. This is really the situation that everywhere in the world we are debating this. Should there be the sort of open talk in social media about people who are against vaccinations and all that, particularly given the fact that it has been proven that vaccines have been the most successful interventions in the century. Moving on, people would still be saying, okay, you are all saying about these various vaccines. There are killer diseases like malaria, dengue, etc., still rampant in many parts of the world. Why is it that we are not shifting our focus on preventing these diseases while you are trying to give vaccines for rotavirus, all those things? Well, malaria and dengue are still rampant in many parts. I'll try to answer this question here. Now, understand that an investigational malaria vaccine against Plasmodium falciparum has been in recommendation of the WHO since 2021 for high-risk areas. And there has been significant progress in the research in vaccines against 2 candidate vaccines for malaria. They are in phase 3 trials, and we hope that they would be introduced shortly. But the promising news that we can say is vaccines against the respiratory syncytial virus and group B strep are under advanced stages of development and are likely to hit market in the near future. Beware that RSV is a very, very common disease in the younger children, particularly in winter seasons and all that, and group B strep, causing early onset group B strep as well as late onset group B strep have been killers in infants, and vaccines against them would really come as a blessing for them. Now, dengue has been there in different parts of the world. You know that it is transmitted through by Aedes aegypti mosquitoes and all that. And the incidence varies in different parts of the world. I have seen back in the UAE, probably in my 15 years of working in UAE, I might not have seen many cases of dengue, probably a couple of them. While back in India practicing for the last nearly 2 years, I must have seen more than 10 cases of dengue here. So its endemicity is a variable in different parts of the world, but it is good to understand that dengue vaccination has also been licensed by the WHO for use in high endemicity areas, and it is being used in the Far East at this stage. So be aware that investigation or research into vaccinations is an ongoing process, and newer vaccines against killer diseases are always being there, and there are new vaccines in the pipeline. I would open the stage for questions from the audience and would request the chairperson to pass on any questions to any of the panelists to answer these questions. Dr. Suwaidi?
Yeah, thank you very much, Dr. Krishna and colleagues, for these interesting discussions and trying to unresolve some of the ambiguity around common questions, common misunderstandings around vaccination issues, which are really cornerstone for us as pediatricians. Looking at the Q&A section, I can read here there is one question from Isra, and she's asking about that during COVID years, we missed some of the grade 1, the 6 years old vaccine. Can we give it when the child is 7 or 8 years old? So I think any one of the panelists can answer this question. So maybe Dr. Krishna, you can answer this.
Yeah, I think, because we have been, Dr. Walid has been dealing with COVID vaccinations, and honestly, in the UK, Dr. Shamas has been an authority on COVID. He was in the committee for prevention of COVID and research into COVID. I would, request an authentic answer from either of them, please. Dr. Walid, Dr. Shamas?
I just lost you. Could you repeat the question again?
Yeah, so the question is not about the COVID. What the question was about the issue that during COVID-19, and this is not only unique to UAE, it's like everywhere in the world. Many kids, they missed the opportunity to be vaccinated on time. So for example, in UAE here, we give the grade 1 vaccination, the DTaP, the oral polio vaccination is given and also the second dose of varicella is given in that age group. And many children or some children miss the opportunity. So the question here, if they present to us later, let's say they present in grade 3 or grade 2, can we still give them the vaccination? So that's the question, basically.
So sorry, I misunderstood your question. Yes, yes, please.
Yeah, it is the standard care of treatment, or when it's given to vaccination, we have to give any missing doses, and there is accelerated schedule. So this is the standard care. Any missed dose should be given according to the accelerated schedule.
Yeah. Thank you very much.
May I ask one question? Sorry. May I ask one question?
Completely. Yeah.
Yes.
Now, I would like to ask one question, permission of Chairman Dr. Soidi. I read recently the WHO position paper 2021 that Rota vaccine can be given up to 2 years. The explanation was that the incidence of intussusception is 1 in 12,000. We are depriving the children because of one intussusception in 12,000, and many children are dying of gastroenteritis. So in countries like India, they give up to 2 years. Do you think this will change the 15 weeks, what CDC says in future? I want the opinion of panel.
I can try and answer that.
Yes, please.
Please go ahead.
It's all about risk benefit. In most industrialized or high income countries, rotavirus is an extremely rare cause of death. In the UK, we haven't had a death due to rotavirus for many years. And at the worst case scenario, there may be 1 or 2 deaths at most before the vaccine came in. So in those scenarios, any risk of health, such as intussusception, would not be balanced by the benefits of vaccination. And therefore, most high-income countries would not accept a risk of intussusception. In lower and middle-income countries where rotavirus is a major cause of death, there is ongoing work to increase the risk, to increase the age at which you can give rotavirus vaccine, because it still continues to save more lives. So the answer to your question is yes, countries like India should continue to give rotavirus, and we should be pushing the boundaries for this vaccine. And no, not every country should do it, because if they have a very low risk of severe disease and they have a good healthcare system that can deal with gastroenteritis, then the risks of intussusception and deaths may not be beneficial. So in France, for example, several children died of intussusception because they couldn't access healthcare after vaccination. So the balance needs to be done properly. But low-income countries and many of the middle-income countries should continue to provide rotavirus vaccine to as many children as they could, because it's life-saving. Thank you.
I fully agree with you, my dear. I think one size does not fit all. And when it comes to vaccines, we have to look at the risk, benefit, and cost also, and the epidemiology of that virus in certain countries. So if like in India, yeah, why not? But in general, we know the peak of intussusception, it is the first year of life, and it's becoming less after the first year. But in certain countries, they die from gastroenteritis, not from intussusception. So if we have to give to prevent severe outcome of this rotavirus infection, and again, you know, what's applied in London should not be the same in Zimbabwe. Thank you.
Thank you, Dr. Walid and Dr. Shamas, for enlightening the audience on that question. I think for short of time, we would go through the take-home messages from this presentation for the audience. I would believe that you all would agree with me if I say that vaccines have been the most life-saving accomplishments of the 20th century. Consider vaccinating your child as a societal responsibility to make your child safe, as well as the world safer for all children. Opposition to vaccinations is not a new phenomenon and has existed from the time of Edward Jenner. The Anti-Vaccination Society of America was founded in 1879 even. Now, the issue why people think that vaccines are not needed is because vaccines have in fact become a victim of their own success. The diseases that have been prevented by vaccinations have vanished from the world, and once out of sight, the deadly diseases, the necessity becomes out of mind. And that is where they have become a victim of their own success. And often the question is, you know, why is it that, you know, are these vaccines being rolled out for benefit of the pharma companies and all that? Be aware that vaccines, like any other pharmaceutical product, undergoes extensive testing in labs, animals, phase clinical trials, etc., before approval for human use, particularly for use for children. And even after licensing, extensive post-licensure follow-up arrangements are in place worldwide to ensure safety of immunizations. So if any of you are having any doubts about safety of the recommended vaccines, the efficacy of the recommended vaccines, I believe it is time to shed those fears and be advocates to vaccinations. That's what we as a panelist would recommend here. And that's essentially what we would like to convey here. And any other questions or any other comments, the chairperson or?
Yeah, thank you very much, Dr. Krishna. I think we are reaching the end of the session. It's almost 10:50. I see Dr. Kalbana, you raised your hand. You want to say something?
Just a comment. I would request Mr. Tawfiq to take down the audience questions, because we've had quite a few questions on this session which have gone unanswered. So I would request the chairperson and the moderator of the session to please answer them, send them to us, and then we will forward them. Thank you so much.
Certainly.
Thank you.
We'll be happy to answer the audience questions on a personal note for want of time. I would certainly want to thank our panelists, who have taken a significant amount of their time and have provided expert views on the various vaccines that are currently in use for children. And I would say authentic information has been shared with the audience, and I would really appreciate the efforts done by the panelists in this regard. Thank you very much.
Before you close, Dr. Krishna, I really apologize for I missed the first part because there was a glitch in the connection with the Zoom. My computer was acting up. And I would like to thank my colleagues and the panelists here and the chair, Dr. Ahmed, Dr. Kalpana, everyone, and a special thanks to you, Dr. Krishna.
Thank you. Thank you very much.
Thank you very much. It was excellent discussion and presentation. I would like to thank Dr. Soidi, Dr. Shamiz, Dr. Walid, Dr. Fatma, and Dr. Krishnamurti. As usual, it was the best presentation. I'm sure our viewers have enjoyed. This is the most important bread and butter of the pediatrician. For the lack of time, we have to move. Now we are moving to our next session. Again, bread and butter of pediatrician, pediatric gastroenterology. It gives me a great pleasure to introduce the chairperson of this session. In this session, we are having a speaker and panelist, very eminent from India, from United States and UAE. The chairperson of this session is Dr. Kalpana Sengupta, the secretary of the club. No need to introduce Dr. Kalpana. Over to you, please.
Thank you, Dr. Sohrab. So we move on to the pediatric gastroenterology session, and it's my pleasure again to invite Dr. Mohammad Miqdadi. He is a very well-known pediatric gastroenterologist and hepatologist from SKMC Abu Dhabi. Over to you, Dr. Miqdadi, for moderation of this session. Thank you.
Hi, good morning, everybody. How are you? Hope all
Morning,
are
all
great.
good.
I'm very pleased to be part of this very interesting event, the Dubai Pediatric Club. The GI session is probably one of the big highlights of this conference. And we decided to do 4 cases, and we'll have plenty of time for discussion. Today, we are very honored to have 4 very excellent presenters who will share with us their experience. Without any further ado, I'd like to start with my dear colleague and friend, Dr. Michael Woolsey, all the way from Florida. And he's a clinical professor at the University of South Florida there. And also he's the division chief of the pediatric gastroenterology. Michael Woolsey, thank you very much for being with us today. I understand it's 2 a.m. Back home, and you just came back from vacation. So we really appreciate your commitment to this important conference. Michael Woolsey, the floor is yours.
Thank you, Dr. McDaddy. Thank you for the kind invitation, and it's a real honor and pleasure to be here. I'd like to thank the organizers for asking me to speak. And today we're going to talk a little bit about, I was asked to present a case, and we see so many different cases with pediatric gastroenterology. And this one, I want to focus on abdominal pain. When children come into the office, when they come to see us for abdominal pain, vomiting, and jaundice. So this is a previous 10-year-old girl who came to see us in the hospital, presented with 4 days of abdominal pain, right upper quadrant abdominal pain, vomiting, and this was non-bloody, non-bilious, and new onset jaundice. And this sought presentation. She'd had a history of stomach aches on and off, but really once she developed jaundice, she came in for medical evaluation. She was tall but somewhat thin and poor weight gain. Her family history was unknown as she was adopted. Her growth parameters, we would talk on the previous talks about growth parameters. Her height, she was in the 74th percentile for height, less than the 20th for weight, and her BMI was less than the 5th percentile, a Z-score of negative 1.67. Her physical examination was otherwise unremarkable. She had some jaundice, some mild scleral icterus, right upper quadrant abdominal pain to deep palpation, and no other physical findings. And so some baseline laboratory evaluation that was performed in the emergency room, normal comprehensive blood count, based on metabolic panel. Which was interesting is that her bilirubin is elevated. She had a total bilirubin of almost 3 with a conjugated component. She also, her elevated liver enzymes. So she had a transaminases, both an AST and an ALT. I always like to remember the ALT is more specific for the liver. It has the L in it. Also is a bit cholestatic with a GGT of 250. Normal in our labs is less than 30. The lipase was elevated as well. And so what's the problem list? You know, when we have our trainees and such, you know, always thinking through what's going on with the patient, the child that we're seeing, vomiting, abdominal pain, and new onset jaundice. You know, has a what appears to be obstructive jaundice. Elevated liver enzymes, the lipases level is elevated and also is a bit undernourished. So what's the differential diagnosis? What could be causing this? You know, could this be primary liver problem? Could this be an intrahepatic process? Could this be a gallbladder? This is what we see most commonly in the United States, especially in the setting of the obesity epidemic. We also see, you know, onset with jaundice with hemolytic processes such as thalassemia and sickle cell disease. Or could this be a primary pancreas problem, you know, unusual presenting, but also in the differential? So that gives us an idea of what's the problem list and the differential diagnosis. And when we think about differential diagnosis for cholestasis, always like to divide, could this be coming from within the liver or is this outside the liver? You know, within the liver, could this be a viral hepatitis A, B, C, D, E antigen, all the large DNA viruses, EBV, CMV, HSV? Could this be drugs and toxin related, alpha-1 antitrypsin deficiency, Alagille syndrome, usually not an acute onset. Sclerosing cholangitis can have the intrahepatic portion, but also the extrahepatic, that common bile duct involvement. Could this be a PFIC, a progressive familial intrahepatic cholestasis? And could this be an infiltrative process from TB, sarcoid lymphoma, and in older patients, you know, could this be pregnancy cholestasis, but not in a 10-year-old? Or could this be outside the liver? Could it be an extrahepatic process such as gallstones? And this is what we see most commonly in the United States, especially in the setting of the obesity epidemic, or in a hemolytic process. Could this be a congenital biliary issue, a cholangiopathy, such as a choledochal cyst, sclerosing cholangitis, especially if there's a family history of autoimmune disease, strictures after a surgical procedure, especially duodenal atresia repair. Could this be parasites, ascariasis, Fuchs? I just reviewed a paper on ascariasis and common bile duct. Could this be a pancreas issue, or rare in children, but we see more commonly in adults, cholangiocarcinoma? So what are our next steps as a clinician, as pediatricians? So we can do more further laboratory evaluation. We can do further imaging studies, trying to find out where this obstruction is, and we can consider other diagnostic testing. So in this patient underwent a CT scan, which showed extrahepatic biliary dilation. The common bile duct was dilated at 7 millimeters, but interestingly, the pancreatic duct was dilated as well, almost 9 millimeters. An MRI was performed as well, which showed no mass, didn't show a tumor, but did show a filling defect of about 1.4 centimeters, quite large, which they think, and at the time weren't sure it was the pancreas or the common bile duct, but no evidence of gallstones. So what are the next steps? You know, typically we do a diagnostic study, such as an ERCP. But what's an ERCP? It stands for endoscopic, the use of an endoscope, retrograde, and it's a combination of endoscopy and fluoroscopy. And retrograde means that we inject contrast in a retrograde fashion, into the biliary tree and the pancreas tree. So that's the cholangiopancreatography. But this really helps to both diagnose and treat biliary and pancreatic disorders, you know, to see what's the cause of this obstruction. And this particular child, she had an ERCP that I performed, and showed a dilated bile duct. And you can see this is the scope that we put in. It has a nice hockey shape position, and the scope itself is about 11 millimeters. So you can see the common bile duct's about 9 millimeters that we injected, but no obstruction was seen in the biliary tract. So no strictures, no stones. What we did see is when we looked at the pancreatic duct, it was tortuous, it was beaded. It looked like a chronic pancreatitis, which we weren't expecting in this child, and showed some obstruction. This white part here is actually a stone. And when we did a sphincterotomy and put a balloon in there, there, we actually pulled out 2 stones causing obstruction. And so in follow-up, we worked her up a little bit further. Why does she have chronic pancreatitis? Why does she have pancreatic stones? Well, it turned out she had 2 gene mutations for cystic fibrosis, although her sweat chloride test was normal. We did a stool pancreatic elastase to see could she have, although she denied steatorrhea or diarrhea, and of course her pancreatic elastase is quite low, less unmeasurable, normal is greater than 200, suggesting an exocrine pancreatic insufficiency. And so in this child, we started pancreatic enzyme replacement therapy and saw her in the clinic in 1 month, and she had gained 3.4 kilos. Her BMI had increased up to the 25th percentile. And so in this patient, obstructive jaundice is an atypical presentation of pancreatic stones, typically and most commonly involves common bile duct stones from hemolytic process or obesity-driven stones. And acute biliary obstruction can occur when a stone occurs because there's this common channel, right? And this is where the pancreas and the common bile duct drain. And so if you have a stone here, whether it's biliary or pancreatic in nature, this can cause obstructive jaundice. And pancreatic stones in adults are common, up to 60% with chronic pancreatitis. But pancreatic stones in children are uncommon. But when they do, they usually occur in the setting of chronic pancreatitis. So this was an interesting case, and we wrote it up and published it in JPGN reports earlier this year, of how obstructive jaundice can present not from a liver cause, not from a biliary cause, which is always the top 2 differential diagnoses, from a pancreatic cause. And I'll go ahead and stop here for questions. Thank you.
Thank you, Mike. This is a very interesting case and really highlights an important disease that sometimes, unfortunately, we overlook in pediatrics. Excellent job in this room.
Yes. Also, too, just going through the differential diagnosis and what can cause jaundice. We see children with jaundice quite frequently. And is this a biliary? Is this a hepatic? Or could it be unusual, a pancreatic cause?
Yeah. And in this patient, it's interesting that she did not have pulmonary manifestation.
Exactly. No digital clubbing. Other than occasionally, retrospectively, just some stomach aches in the past. And that was the main presentation.
Yeah, superb. I mean, because normally we would see these patients much earlier in life. So I think with this advanced technology with the ERCP and the genetic testing, otherwise this patient would not have been diagnosed. No. All right, I'm looking at the chat box. I don't see questions there. I'm looking at the Q&A. I don't see any questions. I think people maybe will be asking there. Okay, for the interest of time, let's move to the next speaker. Thanks, Mike.
Can I ask a question to Michael?
Sure. Go ahead.
Michael, are you around? Yeah, here,
Yes.
Dr. Poddar from India. Hello, Michael. How are you?
How are you?
Yeah, I'm good. My question is, can it be pancreatobiliary duct abnormality, which is there congenitally present? They can have long common channel with upstream dilatation of both biliary and pancreatic duct. You can have stone, which can give rise to both pancreatitis and biliary obstruction. So when there is a no chronic pancreatitis, can it be a case of congenital pancreatobiliary duct anomaly?
It can be, yes. So very interesting. It's uncommon. I've only seen 1 case in the last 10 years. So it's a congenital anomaly. I always like to say it's just a miracle we're born with 10 fingers and 10 toes. Sometimes on the inside, you can have an abnormal of the pancreatic. That's an abnormal junction, that common channel between the common bile duct and the pancreatic duct. And that can lead to chronic pancreatitis, just like pancreas divisum is associated with a higher risk and others. So any congenital anomaly of the pancreatic duct can lead to chronic pancreatitis. Absolutely.
Excellent job. I mean, we in pediatrics who don't perform ERCP, only very specified centers. And my understanding in the state of Florida, you are one of the very few who do pediatric ERCP. Am I correct?
Yes.
Okay. Fantastic. All right. I think we'll move to our next speaker, Dr. Dalia. I think Dr. Dalia does not need much introduction. Everybody knows Dalia. Dalia, she was trained in the UK. She had an extensive experience in pediatric gastroenterology, and she moved to UAE around 6 years ago, I believe, and she's currently practicing at the American Hospital in Dubai. And feel free to send her all the difficult patients and difficult parents as well.
Thank you very much, and thank you for the Dr. Maqtadi and for the organizing committee for inviting me. So I'm going to present a case, a pediatric GI case. So this is a 13-year-old boy, Ahmed, who presented to us with a 2 months history of abdominal pain, and which was coming on and off. His family noticed that he has been losing weight recently, and over the last 6 months, he lost around 6 kg. He presented to as well with lip swelling and some mouth ulcer, which has been going on and off for the last year or so, the mouth ulcers and the lip swelling. Interestingly, he has a long history of constipation, and he was looked after the general pediatrics for at least 2 years with long-standing constipation and need of Movicol. He had some anal fissures, and that has been attributed to constipation. So on examination, he did have a lot of ulcers in his mouth. His lip was quite swollen, and his gingiva was inflamed. On examining his perianal area, the skin tags, which looked more like inflammatory rather than constipation type of skin tags. On examination, he does have some evidence of fecal loading, but he does have as well tenderness in the right lower quadrant. He has some evidence of erythema nodosum as well on his shin. So this is the mouth ulcer. You can see it looks like a little bit inflamed, as well as the swollen lips. And this is the erythema nodosum. So we've conducted a few labs, and that showed that his hemoglobin was low, platelet high, with slightly raised ESR and CRP. His calprotectin was elevated as well at 350. So he underwent an endoscopic assessment to see what is going on. And he did have evidence of gastritis, duodenitis, and his colon looked a little bit erythematous, but his main area of inflammation was at the terminal ileum. So you can see in this endoscopic picture how the ileum is ulcerated and inflamed. So to the right-hand side is just a little bit of inflammation, and this is on the left-hand side, there's deep-seating ulcers. So his histology from both the lips and from the upper GI and the lower GI all showed inflammatory process. So there is an active inflammatory cells within the lamina propria. There was active acute inflammatory cells in addition to chronic inflammatory cells, and there's granuloma as well. So you can see the circular things around. This is the granuloma, the multinucleated giant cells granuloma. So the patient had a lip biopsy as well by our oral health doctor, and this showed granulomatous inflammation as well. So this child has an OFG, which is orofacial granulomatosis, in addition to Crohn's disease. In order to complete the assessment, we did MR enterography, both the oral and the IV contrast, and this showed thickening of the terminal ileum as well as some pre-stenotic dilatation. So this is the images. You can see the thickening of the terminal ileum as per the arrow. This is quite thickened and inflamed. And this is the pre-stenotic dilatation, which means that before the thickening, there is a dilated bowel loops. As well, it has mesenteric lymph nodes, quite inflamed, which is typical finding in inflammatory bowel disease. So to treat this child, and after counseling with the family, they were keen to go ahead with the exclusive enteral nutrition, which works really well for the Crohn's disease. We started him on immunomodulator, so he started on azathioprine. And because of his orofacial granulomatosis, he received cinnamon and benzoate-free diet, and he had prednisolone mouthwash. He did really well initially, and he went into remission. We discussed about biologic therapy and intensify treatment, but parents were keen, and after discussion, we decided just to do immunomodulator and exclusive enteral nutrition and monitor gradually any flares. He managed to gain 4 kg, and his calprotectin at 3 months was 37, which we're really impressed. Having said that, 6 months later, he presented with what seems to have a perianal fistula and a recurrence of abdominal pain and intermittent fever as well. We decided to repeat the MR enterography in view of the fistula, and that showed an intersphincteric fistula, as you can see in the arrow, and ongoing inflammatory process with the ongoing thickening of the terminal ileum 15 centimeter, and you can see what we call fibrofatty infiltration in the mesentery, which is typical of active on chronic Crohn's disease. And at that time, we decided to go ahead with the biologic therapy, immunomodulator continued, and we opted to try Crohn's disease exclusion diet while he is building up on infliximab. And thankfully, he did really well, and his biology therapy as well as immunomodulator continued until now, and he is achieving good therapeutic range, and he's maintaining his growth and development. So just probably from this presentation, some of the take-home messages is like IBD can have different presentation. It's not always present with diarrhea. You can have a case of chronic constipation, which can present as IBD. Looking for clues for inflammatory bowel disease, mainly tenderness, which most likely in the right ileal fossa, lip swelling, perianal disease, and erythema nodosa. Thank you.
Thank you, Dalia. This was really a very interesting presentation. And again, it teaches us that Crohn's disease can present anywhere between the mouth and the anus. And this is a very good example of that. And I can see that this case can be missed if they did not go to the right position. While we're waiting for the question, let me ask you, Dalia, you mentioned that this patient had MRI enterography twice, which is essentially an MRI of the small intestine. Sometimes I get patients who still get CT enterography. And would you like to comment on the uses of MRI enterography versus the CT enterography?
Versus wireless capsule?
MRI versus CT.
Versus CT, okay. I think MRI is the modality of choice because obviously there is no radiation effect. So we always prefer to go to the less invasive, and it is a quite like I think the radiologists, especially the expert radiologists, they are quite customized with the assessment of these inflammatory bowel disease and all the features that we've seen. They have all special markers on grading of inflammatory bowel disease, acute and chronic, and it's all being customized according to the MRI. I think I would use only CT scan in cases where patients are really like agoraphobic, who are not keen to go through the MRI scanner. We can do CT enterographies, but this is probably the only case that would go for CT if the patient is really agoraphobic and not keen to go for MRI.
Yeah, thank you. That's an excellent comment. And because the CT enterography is associated with a lot of radiation, and some of these patients, they might need the study to be repeated, and that's too much radiation. So I think in the MRI should be the first option, as you said, CT only in special cases if the patient cannot tolerate being in a closed space. There's a question from Dr. Yasmin Mirza. When to do the biopsy? That's her question.
When to do the biopsy?
Yeah.
So at presentation, definitely. I think for any case of GI endoscopy, if you are to put the child under general anesthesia, I would take biopsies, because 10% of the inflammatory bowel disease can be microscopic rather than macroscopic. So biopsies with all cases of GI endoscopies, in my opinion.
Yeah, and that will guide you the therapy, because without biopsy, you cannot confirm diagnosis. All right, and now we'll move.
Daddy, can I make a comment to Dalia?
Yes, Professor.
Dalia, it is a beautiful presentation. You have nicely highlighted that extraintestinal manifestation may be the first presentation of IBD. So we need to keep our eyes open when a patient coming with joint symptom, skin problem, eye problem, or oral cavity ulcer. The patient may have underlying IBD, and you rightly pick this up. Only thing is, in this patient is that within 6 months of starting therapy, the disease behavior progress from B1 to B3, from non-stricturing, non-fistulizing to fistulizing despite being on therapy. So that is an intriguing point in this patient.
Yeah, I mean, IBD, sometimes it can be the non-classic presentation, just like this patient. All right, thank you, Dalia. We'll move to our dear colleague, Professor Podar. Professor Podar, can we have your slides, please?
Yes, this is my turn now?
Yes, sir. But Tawfiq, can we have the slides for Professor Podar?
Yeah, is my slide visible?
Yes, we can. If you can go to
slideshow.
Slideshow, yeah. Professor Podar is the head of pediatric gastroenterology in Uttar Pradesh in India. He has extensive experience in pediatric gastroenterology, and we asked Professor Podar to be with us today, and he kindly agreed to this. With your vast experience, but I asked him to give us a simple case that we all can learn and see in our practice. So, Professor Podar, the floor is yours.
Thank you, Migdadi. At the onset, am I audible?
Yes.
Yeah. So at the onset, I must thank Dubai Pediatric Club for giving me this opportunity. Dalia has shown you a presentation of predominantly IBD, means what we talk about the large bowel disease. I will keep a simple case to discuss about how to go about a small bowel type of diarrhea, right? So this is a child, 4 years old, who presented to us with a history of failure to thrive since 1 year of age. She was having chronic diarrhea for since 2 years of age. Over the last 1.5 years, she was having diarrhea. There's also history of rectal prolapse over the last few months. And towards the end, for last 5 days, she developed anasarca, swelling of whole body. Now, if a patient comes to you with diarrhea and failure to thrive, we need to dissect out what type of diarrhea this child is having. So you ask more questions to the parents to find out what is the characteristic of the stool. So this child was passing loose stool 5 to 8 times a day. The stool characteristic is a pale, bulky, means large volume, occasional frothy, and offensive, foul smelling. However, there is no blood, there is no mucus, and there is no apparent fat droplets in the stool. If you go into the detail of history, she didn't have any pain at any point of time. She was not having fever. There is no features to suggestive of recurrent sinopulmonary infection that we start thinking whether there is the underlying immune deficiency or not. Is not there. She was breastfed till 8 months, and then solid was introduced. She's from North India, where wheat is a staple. Family history unremarkable. When you examine this child, see this child, absolutely run down state. She's looking like a marasmic child. Weight and height are significantly, there's wasting and stunting. She was having anemia, edema, angular stomatitis, glossitis, flaky dermatosis. Just in a pediatric scene, you can think about a severe malnutrition. He has been wasting. However, abdominal examination was unremarkable. So, what are the problem with this child? She was a 4 years old girl who is having chronic diarrhea going on for last 1.5 years. She was having significant failure to thrive. Her weight was just 50%. She has multiple water-soluble vitamin deficiency features. So this glossitis, angular stomatitis, dermatosis, everything, severe malnutrition. In addition, she was having edema as well. So when you analyze this kind of patient, so this is no doubt chronic diarrhea. Everybody will have diarrhea going on beyond 2 weeks. You think chronic diarrhea and with significant failure. So what we have to dissect, is it a small bowel type of diarrhea or large bowel type of diarrhea? Dalia has already shown a prototype of large bowel diarrhea when there is a blood and mucus, pain, etc. If it is a small bowel diarrhea, is it a malabsorption or maldigestion? Or if it is a malabsorption, is it because of mucosal disease or it is a post-mucosal malabsorption? How will you dissect it out? I will tell you. So we have the 3 phases of digestion. The luminal phase where the pancreatic enzyme bile comes into the play and you have the bigger particle becomes smaller, right? So when there is a defective of the pancreas, then we got it maldigestion, means undigested food, fats, steatorrhea, etc. you get. But when there is a mucosal problem, we have this brass border enzyme. Prototype is your lactase. This lactose intolerance happens when this lactase enzyme is gone, and you encounter day in, day out in managing patients with diarrhea. So similarly, the peptidase, dipeptidase, tripeptidase, oligopeptidase, all mucosal enzymes. So that is when mucosa is defective, you have the small molecular problem, not the bigger molecule. And delivery phase, some of the nutrients, especially the fat, they is transported from mucosa by lymphatic. So you have the lymphatic problem, then there will be a problem of fat malabsorption. So these are the 3 phases. So let's start with the small bowel versus large bowel diarrhea. So how will you dissect them? These are all clinical dissection. How you clinically go when a patient comes to you with a diarrhea. Is it a small volume diarrhea or large volume diarrhea? Usually the small bowel diarrhea volume is large because the main absorption takes place in the small bowel. Large bowel, little bit of water absorption takes place and liquid. Otherwise, it is a 90% of the water is get absorbed in the small bowel. So if the small bowel is diseased, the volume will be higher. Frequency of the stool in large bowel, prototype is bacillary dysentery. 10, 15, 20, this continuously they are passing. But small bowel, the volume frequency is not so much. Color, I said that pale color. Why color become pale in small bowel? Because the same amount of bile. Bile is the constituent which causes the change in color to yellow or green of the stool. Now it is get diluted because the increasing volume. So obviously the stool become pale, but the stool color remains dark in large bowel because volume is small. Usually the blood and mucus is a feature of large bowel diarrhea, undigested food. You get, I already have given you hint, when there is a maldigestion, you get undigested. You never get undigested food in large bowel diarrhea. Smell will be offensive in small bowel because of the protein. Protein gives maldigestion, gives rise to offensive smell. If there is any pain at all, see the small bowel means it's a big gut, so pain will be periamphibial. Large bowel is predominantly it's a hindgut, so pain will be hypogastric. Tenesmus, urgency, these are features of large bowel with the rectal symptom. And water-soluble vitamin deficiency features are unique of small bowel, not large bowel type of diarrhea. So let's put this information to our child. She was having large volume stool. Mother said it is a pale color stool. She has offensive stool, and there are multiple water-soluble vitamin deficiency features. So where we are putting this information, our child, which I presented, has a case of small bowel diarrhea, not large bowel. Now, once you decide it is small bowel, so is it a malabsorption or maldigestion? These are the points clinically you can elicit from the history to decide is it a malabsorption or maldigestion. The stool usually watery in malabsorption, but maldigestion is bulky and malodorous stool. Undigested food, I specifically said, will be there only in maldigestion, not in malabsorption. Now, unique features of mucosal disease means there is a carbohydrate malabsorption. So what will happen? This carbohydrate will go down to the colon. It will get fermented by the bacteria. So there will be distension, flatulence. Features of lactose intolerance is a unique features to say this is malabsorption because lactase enzyme is there on the brass border. So if there is a brass border is denuded, you get a features of lactose intolerance, like there is explosive diarrhea, perianal excretion, distension, etc. Appetite is relatively preserved in pancreatic diseases. Water-soluble vitamin deficiency, obviously, water-soluble vitamin deficiency will happen only in mucosal disease. If it is a pancreatic disease, you can have fat-soluble vitamin deficiency, but not water-soluble. Pain, as I already said. So what this patient has, she has a watery diarrhea, she has associated features of abdominal distension, lactose intolerance, and water-soluble vitamin deficiency. So she has, this patient has malabsorption. Last part is it a mucosal disease or post-mucosal, means lymphatic obstruction. Mucosal means pan malabsorption. You will get the all carbohydrate, protein, fat goes through the mucosa. So you have features of pan. But post-mucosal selective, we don't need the fat. This chylomicron gets delivered into the lymphatic and goes into the circulation. Lactose intolerance, if you have a feature, that suggests mucosal disease, and water-soluble vitamin deficiency in mucosa. So what our patient had, she had features of pan malabsorption, she had features of carbohydrate malabsorption, she had the wasting, edema, protein malabsorption, she had everything. She had multiple water-soluble vitamin deficiency features, glossitis, angular stomatitis, anemia. So what she has a mucosal. So clinically, where have we reached? We reached that this patient has chronic diarrhea, which is small bowel type, it is malabsorption and mucosal malabsorption. So these are the few hint how you dissect the symptom. Explosive diarrhea, frothy stool, gaseous distension, such as carbohydrate malabsorption. So if there is a anemia, water-soluble vitamin deficiency, iron folic acid deficiency, which are absorbed with only the proximal small bowel, you can localize the disease. Usually offensive stool, poor muscle mass, edema, protein malabsorption, and chronic malnutrition, obviously the general features of malabsorption. So this 4-year-old girl who had chronic small bowel diarrhea, this is a malabsorption, and most probably mucosal disease, probably proximal small bowel is involved because there is a water-soluble vitamin deficiency, anemia, etc. So what could be the possible? Now we are sitting in the North India. In India is a vast country. We have difference in spectrum, the north to south and east and west. So sitting in the North India, where wheat is a staple, we dissect, is it a painful or painless? When you say the chronic small bowel diarrhea mucosal, if you say the painless, these are the list of conditions. That is huge list. I have just shortened it to the common condition. Common in this part of the country, or maybe in your part in the world, is also celiac disease. Tropical sprue is less commonly seen in children, more in the older children and adolescents. Abetalipoproteinemia, agammaglobulinemia, GRDSC, eosinophilic gastroenteritis. These are the usual causes of painless causes. Pain is not a problem, significant problem. Painful condition, you can the common condition like tuberculosis, IBD, Crohn's, just Dahlia has presented the case, or there may be a IPSI, which is a very rare in children. And these are the two series I have quoted. One is, both are from Chandigarh. I worked in Chandigarh, published a series before. When you talk about the chronic small bowel diarrhea in younger children, less than 2 years, then we get more often cow's milk protein allergy type of condition. Celiac is less common, but when more than 2 years, celiac is the commonest condition besides the other. So once we suspect this is a child with chronic diarrhea, malabsorption syndrome, then how do we approach? Clinically, we have already dissected. Second phase will be the confirming, is it really malabsorption? You do the simple blood test to see whether there is a malabsorption in there or not. Malabsorption syndrome means cellular defective in absorption of any one nutrition. And lastly, we have to do a definitive investigation to find out the cause. So investigation, you can get the clue from simple like CBC, anemia, and type of anemia. If there is a peripheral blood function acanthocyte, it is abetalipoproteinemia. Thrombocytosis, very high platelet, features of celiac as well as IBD, lymphocytopenia, lymphangiectasia, neutropenia, Schwarzman-Diamond syndrome, pan-hyperproteinemia, both globulin albumin is low, means the protein losing enteropathy. You can have a LFT abnormality in celiac and IBD like that. So the investigation of our patient, she had anemia, 8.3 hemoglobin, which is microcyclic hyperchromic, no abnormal cell in the brain, nothing to suggest Yeah, total protein albumin both are low and are normal. Her stool examination normal, and very importantly, HIV was negative. So what is the next? So we proved that this child has malabsorption, biochemically also. Now demonstrating the cause. For that we need to do definitive tests, serology, endoscopy, biopsy, etc. So we did this apogea endoscopy. This is not this patient. I'm just showing that how a celiac disease patient endoscopy looks like. The first panel is showing the normal, nice, the fold in the duodenum, and you can see the macroscopic villi. Second one is showing the scalloping of the fold, bored appearance, and the third one showing the cobblestone appearance. And the biopsy, we grade them as per the Mars grade. The first one, A, is showing normal tall villi, is more than 2:3:1 villus to feet ratio. Then you have subtotal or total villus atrophy, depending on the severity, you say Mars grades 1, 2, 3A, 3B. And anybody can guess what is this case? This is anti-endomysial antibody test, indirect immunofluorescence technique. So this patient had endomysial antibody positive, endoscopy showed scalloping, and biopsy shows subtotal villus atrophy. So what is the diagnosis? We made a provisional diagnosis of celiac disease. Why did I say provisional? Because if you look at this diagnostic criteria of celiac disease, you can only definitely say it is celiac disease when there is a unequivocal clinical response to gluten-free diet. So far investigation suggested celiac, we put the child on gluten-free diet and see the picture. The first picture, you remember I showed, absolutely rundown state, like a marasmic kwashiorkor, and 6 months after gluten-free diet, this is the picture. So now our definitive diagnosis is celiac disease. She had endomysial antibody positive, she had biopsy positive, and she showed unequivocal clinical response to gluten-free diet. Thanks.
All right, Professor Budar, thank you. Thank you very much. This was very detailed and really taught us the clinical skills and points that sometimes actually we overlook. The way describing how to differentiate between large and small bowel malabsorptive, maldigestive is really impressive. And I think we all have to remember this because that will guide us to provide a cost-effective care. Fantastic. Let me see if there is any questions. I don't see any questions there. I wish this is face-to-face. Hopefully next year, Dr. Budar will have you with us face-to-face. That would be more educational. So I think what I learned from you is to go through detailed history and physical exam to direct us to diagnose the patient. And celiac disease is a permanent sensitivity to gluten. And I think it's an underdiagnosed, whether in India or in the Middle East, I think as well. All right.
Dr. Mikdadi,
yes,
I think there are two questions in Q&A.
Really? Oh, okay, I missed that.
Can I address those questions, Mikdadi?
I can read it. Dr. Budar, the first question, what about anti-tissue transferase in this patient of celiac disease?
Yeah, nice question. Nowadays, the serology is replaced by TTG, but if you see the latest guideline of scan, you need to do anti-endomysial antibody after getting a positive TTG of more than 10 times to make a diagnosis. Now, this patient, when we are doing only endomysial antibody, so we did it. But nowadays, we do tissue transglutaminase and we do the biopsy. But if you want to do only serology, no biopsy, then you need to add anti-endomysial antibody.
So in most cases, biopsy is the answer. Okay. But there's a question about, the question is, what about Marsh grade 2? I think
very interesting question. See, this problem we face day in, day out. Your histopathologist is not committing to villus atrophy. Will you start gluten-free diet or not? See, in a clinically symptomatic patient, you will expect Mars grade 3. This comes when you are doing a screening or atypical presentation, or this kind of patient you can get features suggestive of Mars grade 1 and 2. Now, if you have to take a call depending on the situation. If the serology is more than 10 times, patient has some symptom, yes, you will treat. But if it is a borderline case, serology is not supporting, then you can wait and repeat the biopsy after 6 months or 1 year.
Okay. I have to stop now to keep the flow and timing. Thanks again, Professor Kudar. We saved you the best for the last. My dear colleague and friend, Dr. Rajiv Tomar, he's the king, and he works at King's College here in Dubai, UAE. Rajiv, we're looking forward to learn from you, especially from your vast experience with the pediatric liver disease. Rajiv, the floor is yours.
So am I audible and is my screen visible? Hello?
Yeah, we can hear you.
Yes.
Can you go to slideshow?
Okay, 1 second.
Your voice is very clear.
So are the slides okay now?
Yes.
Perfect.
Okay. So first of all, thank you very much, Professor Magdadi and the entire DPC team for allowing me to share the dais with one of our idol, Professor Podar. He's been very motivational and a good teacher for all of us. So the purpose of my talk today is to help you guys in interpretation of various liver function tests in context to a good clinical history and to see whether we can arrive to a diagnosis in a child who presents with jaundice. During the course of my presentation, since it's an online web seminar, so I'll be asking some questions. So just try to have some answer in your mind, and we can obviously discuss and evaluate those answers towards the end of my talk. So the case I'm presenting today is a 9-year-old boy who was admitted with a history of jaundice and fever for past 2 weeks. Parents did mention they were not sure, but they thought their child had a mild abdominal distension for the past 3 weeks, but was much worse in the last 1 week before the admission. There was no significant past medical history. Family history, he was born to consanguineous parents, but there was no other significant medical history in the family. On examination, the child looked unwell. General examination showed he had icterus and edema. There were no obvious other signs of stigmata of chronic liver disease. His abdomen was distended. He had a liver which was 3 centimeters. Spleen was palpable, but no massive sort of shifting tenderness was noticed on examination. The rest of the examination was sufficient normal. And essentially, he wasn't not having any signs of any encephalopathy. So the first question, obviously, we should come with based on this history and examination is, are we dealing with a child who is coming with an acute presentation? Now, this acute presentation could be like a typical, we have with viral hepatitis, or could be a possibility of an acute presentation of a disease which can have a chronic course. Typical example is, autoimmune hepatitis and Wilson disease, or are we dealing with a child which has an underlying liver disease which was not picked up and then had an acute presentation on top of that. So these are the thoughts which should be coming to our mind when we see children with such presentation. I'm sure all of us will order these investigations like food blood count with CRP, obviously liver function tests, INR, renal profile, blood sugar, blood cultures, hepatitis screen, initially hepatitis A, B, E, and if the clinical history suggests to include EBV, CME, leptospirosis also. Of course, we'll all run an ultrasound abdomen. But the key message here is that in the initial start, INR should be part of this assessment. Not only because it tells you how good the liver function is, but also helps you to categorize whether we can label this child to be an acute liver failure or not. For pediatric acute liver failure, it has been defined as, there's a multisystemic disorder, essentially with abnormal INR. If the child is in encephalopathy for more than 1.5, the child is not in encephalopathy for more than 10, And ideally, there should be no underlying chronic liver disease, which was obvious. And this INR does not correct after injection of vitamin K. So this is an important thing to make sure. I know it's a pain to get this INR dust in small children, especially, but this should be part and parcel of our initial investigation. Now, the key question which should be coming to our mind, as I said, is it acute presentation or is it an acute presentation or chronic presentation? Should we be also thinking of doing these tests early in children presenting certain with these symptoms? Should we ordering total immunoglobulins? Should we ordering our antibodies, the ANA, the anti-smooth, anti-muscle, and liver kidney micro antibodies? Or should we, and also should we ordering serum soluble plasmin and 24 urinary copper? These things, if for the benefit of those who don't know, I'm sure you know, these are to essentially look for, are we dealing with child with acute, acute hepatitis, autoimmune hepatitis, or with Wilson disease? And remember, just to, I'm sure you're aware, but both these conditions can have viral presentation. They can present with, and like an incidental finding of abnormal liver function test. They can present with acute liver failure also. So these are viral presentations, so to be aware of. So we got some results back. The initial counts were essentially normal, but platelets towards the norm, towards the lowish side. The anti-hepatitis A virus IgM did come back as positive. And the ultrasound showed that he had a coarse ecotextual liver, gallbladder was normal, and there was hepatosmegaly, which was picked up on clinical examination, but there was minimal ascites. So the message here is, are we happy with the diagnosis of acute hepatitis A and we just wait and watch, or should we be thinking of something else at the same time? So the next slide is something which I want you to focus on. This is the progression of the disease in this child, and these are the liver function tests over a period of the 2 weeks. If you notice on day 1, the bilirubin is high, it's predominantly conjugated. Generally, when you have children jaundice beyond infancy, most of them will have a conjugated jaundice component to be on the higher side. The liver transaminases were high. If you look at the AST, it was high, and it did increase in the first 1 week before it started getting better, and it was still persistently high around day 2 weeks. ALT, I think, has been mentioned previously, is more specific. The liver is much higher than the AST to begin with, but then showed gradual improvement and significant improvement in the next 2 weeks. The gamma GT and ALP, more suggestive of biliary pathology, was also high and more or less did show some improvement in the next 2 weeks. The key thing, as I mentioned earlier, was the INR, which was high, and it remained high even after vitamin K. Always try to make sure you look at the total protein and the albumin. The albumin in this child was on the lower side. Some labs do suggest total globulin, but if they don't, then please do subtract the albumin from the total protein. It gives you some idea of the globulin level in these children. And remember, the antibody screenings, which we were talking about earlier, are part of this globulin pool. So if you do have your globulin fraction, which is higher on the initial presentation, you should be thinking, okay, maybe this child has some increased autoantibodies in the thing. So these are useful thing to consider. So what is not just to make it interesting, the question which should be coming to our mind is, what is the working diagnosis purely based on the history examination, the liver function test? Are we dealing with a pure acute hepatitis case? Of course, we are dealing with acute liver failure, but is this liver failure like acute liver failure on top of a chronic liver disease? And we'll discuss that in subsequent slides. So I'm sure you'll agree that why this child had initial higher AST this is because he had a hepatitis A acute infection. But what is all these things show? That he had a late AST, which is higher than the ALT. The albumin persistently remained low. He did have ascites. There was a splenomegaly and slightly lower platelets with the raised INR. So these things are suggestive this child may have underlying chronic liver disease. And so this is the thing, one message which is clear is fine. We did have a hepatitis A infection which was positive, but now we have to broaden our differential diagnosis that we might be dealing with a child who has underlying chronic liver disease, which precipitated very quickly because of a superadded hepatitis A infection. leading to the liver failure. So the diagnosis was essentially the acute and chronic liver failure at this stage. So the results which we requested earlier also came back just to make it a little more interesting. So this child did have a raised total IgG levels. He did have a raised anti-smooth muscle antibodies, but the dilution was only of 1 in 20. The ANA was negative in this child. He also had low cerebral plasma of around 80 milligrams. For the benefit of people who don't know about this, serum cerebrospinal less than 2 milligram is considered to be significant when you're thinking of Wilson disease. His serum copper was also ordered, but that was normal. I'm not sharing all the investigations so far just to make this talk slightly more interesting. So the question which should be coming to in our mind is, does a positive smooth muscle antibodies confirm autoimmune hepatitis in this child? Because if you're thinking of that, then of course the treatment is to give him steroids. And is the level of serum plasma less than 20 is good enough to make a diagnosis of Wilson disease? And do we really need a serum copper in the making of diagnosis of Wilson disease? So these are the things which you should be asking and thinking in planning, first of all, making a diagnosis and trying to tailor the treatment accordingly. So of course, just to summarize what has happened so far, we made a conclusion. Okay, this child has acute and chronic liver failure. The acute etiology is the hepatitis A infection, and the chronic liver disease etiology, because we have some mixed results which were positive. Is it autoimmune hepatitis because of raised IgG and the anti-smooth antibodies, or is it Wilson disease because of low serum cerebral plasma? Now, to make a diagnosis of autoimmune disease is a tricky thing, especially when you have any underlying chronic liver disease. So you do have the standard thing which is recommended for autoimmune hepatitis is that if you have a raised IgG, which is more than 1.1 times the normal, if you have your ANA and your smooth muscle antibodies, which are significantly positive in very light, to dilution of 1:80 or more, are considered more significant rather than 1 in 20. As regards to the Wilson disease, so low cerebroplasmin is indicative but not confirmatory. I'm sure to just remind you that cerebroplasmin is an acute phase reactant. It can be falsely high or normal in any inflammatory process. More so, this cerebral plasmin is actually synthesized in the liver, so it can be low in any chronic liver disease. So low cerebral plasmin per se is not good enough to start thinking of of Wilson disease. So what else do we need to diagnose Wilson disease? Of course, we need something called, so in this stage, we have these two things which are not clearly giving us any indication of the chronic etiology of this child. Is it autoimmune hepatitis or low cerebral plasmin? So of course, as I said, if you have thinking of autoimmune hepatitis, you have to steroid. If it's treatment for Wilson disease, do you start chelating this patient at this stage? But are we sure of the diagnosis yet? The answer is no. So what further things you do? So for Wilson disease, you always look for KF ring.
2 minutes.
Urinary protein. Sorry.
2 minutes.
And you look for a 24-hour urinary copper. So if we have a child who has low cerebral plasmin, who has a KF ring, and if we have a 24-hour urinary copper collection, which is more than 40 microgram in 24 hours, it's more or less suggestive of Wilson disease, strongly suggestive of Wilson disease. Why do we need a 24-hour urinary copper? Because the excretion of copper in the urine is variable during the daytime. So you need 24-hour collection to be absolutely sure what is the total excretion of urine in the copper. The serum copper per se is not useful because remember, the serum copper measures the copper bound to the cerebral plasmin and the free copper. So if you have any child with chronic liver disease who has low cerebral plasmin, the total copper might be normal. And if you're thinking of Wilson disease as a result of high copper levels, remember, this copper is mainly intracellular, so you won't get much out of it by measuring a serum copper level in these children. So now we have a child who had low cerebral plasmin level, who had high urine copper, but does not have KF rings. Are we still confident of making a diagnosis of Wilson disease? The answer is still no. So what would be the next suggestion? Thinking, should we do a liver biopsy or should we do a genetic studies? Remember, the genetic studies have a turnaround at least 4 to 5 weeks, and we need to make sure, can we get some answer much earlier? So liver biopsy does help us to pick up things, not only to make a diagnosis, but also to assess how good your liver is. Yes, it is a tricky one, especially if you're not being reviewed in a specialized center. Besides the histopathological features, we also look for the copper content in the liver. And if the copper content of liver is more than 250 micrograms per gram, then it is strongly suggestive of Wilson disease. So we did the biopsies, and it was suggestive of Wilson disease. And the genetics, we did some genetic studies. Obviously, they came later on, which confirmed the mutation. Which the Wilson biopsy was also reviewed again in our MDT and also with collaboration with King's in London, and it did confirm the child had liver disease. So the conclusion and the message from my presentation is history is always key. If you stop thinking about chronic liver disease after hepatitis A, I think you are missing this. Remember, hepatitis A, if it's an acute presentation, always presents with some prodromes. And as the fever subsides, then only the jaundice appears. In our children, the fever was persisting even beyond jaundice. If you have symptoms which are suggestive of a chronic liver disease like pedal edema, hepatosmegaly, ascites, and low platelets with albumin, these are suggestive of chronic liver disease. And as I said, whenever you're suspecting chronic liver disease, please always keep autoimmune hepatitis and Wilson disease as part of your differential diagnosis. Remember, the smooth antibodies and the ANA can be falsely positive in chronic liver disease, but a dilution of 1:80 or more in association with IgG, which is more than 1.1 times the upper normal, with other parameters, especially the LKM antibodies, which are more specific to the children, are strongly in favor of autoimmune hepatitis. But unless you're not sure, please do not start steroid based on the basis of just a positive serology in any chronic liver disease. Having a low cerebral plasmin is not indicative of Wilson disease. You need to make sure you have a 24-hour urinary copper collection and make sure you involve your ophthalmologist to do a slit lamp examination looking for KF rings. KF rings are much more obvious if they are seen up to 90% in children who have neurological onset, generally after 10 years of age. They are seen around 25 to 50% in children with pure hepatic illness. Liver biopsy, where appropriate and feasible, is the key to diagnosis. So don't rush in starting steroids, thinking it is autoimmune hepatitis, because things can go wrong in this scenario. So thank you very much, and I'm happy to take any questions.
Thank you, Rajiv. This was.
We can take
Sorry.
Very sorry.
Yeah.
Can I just have the learning points from
Yes,
Rajiv's
Doctor.
presentation? Thank you, Rajiv. This was really fantastic, and it taught me several things. One of them is don't take anything at its face value. As you mentioned elegantly, that a positive result or an abnormal lab result does not conclude the diagnosis, and that's very typical of this patient. For example, the hepatitis A was just a red herring. There was a hepatitis A on top of something else. So, going beyond and going back to the history and physical exam to make sure that the lab results fit with the diagnosis. And again, there's a lot of false positives when it comes to low ceruloplasmin or an abnormal autoimmune antibody. And don't rush to treatment, because as you mentioned very correctly, if you start steroids, this becomes very complicated. Then you will never know the exact diagnosis. But whatever the cause is, patients with steroids, they get better anyway. So again, looking back, make sure that whatever your findings are, they fit with the patient before treating an abnormal lab result. This was fantastic, Rajiv. Thank you. I think we are pastime, and I can see Dr. Kalpana and Sohrab are getting very itchy there. So I think we conclude the GI part.
Yes, Doctor. Thank you so much for an excellent session. We need to move on to the next pediatric hemato-oncologist session. So I thank all the panelists and the moderator for an excellent session.
I would like to thank all the Professor Podar, Dr. Michael, Dr. Dalia, Dr. Rajiv, and good moderation by Dr. Mirdadi. Thank you all. We have to move to other session. The other session is pediatric hemato-oncology. Eminent speaker and panelist, Dr. Bharat Agarwal is a pioneer in pediatric hemato-oncology in India. He is the chairman of this session is Dr. Zainul Abidin. He is the consultant pediatric hemato-oncologist and head of department at Mojid Medical City, Abu Dhabi. So I would like to request him to introduce the moderator of the session and start the session. Over to you, Dr. Zainul Abidin.
Thank you. Thank you very much for the kind invitation. I hope everyone hear me. I don't want to talk too much because you're all waiting for excellent talk by very experienced pediatric hemato-oncologist both in UAE and in India. I know all of them very well, and they are very experienced pediatric hemato-oncologist. So I will introduce Dr. Anchan. So he will be introducing all the speakers. Dr. Anchan is my colleague and my friend, and he's been in Dubai for more than 10 years. And he's very experienced pediatric hemato-oncologist in Dubai hospital. And he has very more than experience. He has publications, and he has contributed a lot in pediatric hemato-oncology. I invite Dr. Anchan to moderate this session. Thank you.
Thank you, Doctor. Thank you, Dr. Zainab. It was a pleasure getting introduced. Now, this being a hemato, I would prefer it would have been a physical one, but since we have no options, we would go for a virtual one this time. We have about 4 speakers, 3 speakers, and with Dr. Bharat Agarwal, who's as introduced, is one of the most senior, experienced pediatric hemato-oncologists from Dubai, who will share his expert views. Now we have 3 cases to discuss, all from different streams. Now we have Dr. Murad from City Hospital, Dr. Nancy from one of the private hospitals, NMC Hospital, and myself. So what I would do is that I will just go over to all over the presentations which are here, and I would request Dr. Amma Murad to be initiating the first presentation. So over to you, Dr. Murad, to start your first presentation. Welcome, Dr. Murad.
Okay, good afternoon, everyone.
So
I hope you can hear me well.
Yeah, we can hear you.
Yes, good afternoon, Doctor. We can hear you.
Okay, perfect. So I'm having technical difficulty. I just emailed my presentation. So I was wondering if anyone could probably open up and move the presentation for me.
I didn't receive, Doctor. I didn't receive it.
Do you have the email of Mr. Tawfiq?
Yes. Let me email it again.
Yeah, you can. In the meantime, yeah, absolutely.
Meanwhile, we can ask Dr. Nancy to present her first case. Dr. Nancy is the pediatric oncologist at NMC Hospital. Over to Nancy. The floor is yours, Dr. Nancy.
Good morning. Yes, sure. Is it clear now?
Yeah, it's clear now and audible too. You can start.
Okay. Good morning or good afternoon now. Thanks for inviting me for this marvelous meeting. Today I will discuss pediatric immune thrombocytopenic purpura. I have no disclosure. My objective today is to understand the natural history of ITP, know that most cases of ITP don't need treatment, recognize the clinical presentation of ITP, know the indication of treatment, and know that most cases of ITP need no admission at hospital, understand the benefits versus the risk for first line of therapy, and be able to treat emergency bleeding in ITP. As all of us know that ITP is characterized by low platelet count, lower than 100,000, with normal white blood cell and normal hemoglobin. The most common cause of thrombocytopenia in a well child. Estimated is one case every 20,000 children. Recent history of viral infection, some of them of ABV, is described in 50 to 60% of cases of ITP. The known cause is circulating antibody-coated platelet and then recognized by the Fc gamma receptor or splenic macrophage. Then it will go to phagocytosis and platelet destruction. This is a very complicated slide for the pathophysiology of ITP. Is not only of B cell immunoglobulin G destruction, but also from T cell also has a role on ITP with targeting the specific antigen receptor on platelet surface like GP2B or 3A, then like a cascade of complement activation through the Fc receptor to the spleen with ongoing phagocytosis and spleen destruction, and not only for platelet destruction, but also it can act on the bone marrow, causing low level of megakaryocyting and low level of thrombopoietin to neutralize the level of platelet in the blood. So before we treat, we have to know, first to know, is it primary or secondary, because a primary treatment has a treatment and secondary rely only on treating the primary cause. Primary treatment, secondary is due to MDS, hereditary thrombocytopenia, bone marrow failure syndrome, or immune-mediated like SLE, systemic lupus, EVA syndrome, or acute leukemia, or hepatitis C, or H. pylori, or HIV. So this is a very interesting column to, showing the most common causes of, in general, thrombocytopenia, which can be immune, like ITP, or infection, or drug, like anticonvulsant drug, or heparin, or vaccine, like MMR, autoimmune, TTP, thrombocytopenic purpura, DIC, hypersplenism, or type 2 von Willebrand. Or it can be due to bone marrow suppression, like Fanconi anemia, dyskeratosis congenita, or Wiskott-Aldrich syndrome, which we have a characteristic low mean platelet volume, or Bernard-Soulier with large platelet volume, or chemo or drug, or storage disease like Gaucher, malignancy, or bone marrow failure like MDS or aplastic. So today I will focus on the ASH guidelines for treating a child with ITP. 2019. So this is the algorithm is very interesting, showing that we are guiding to treating the child according to the bleeding score from grade 0 to grade 3 is according to we can say it's a minor bleeding with minimum health-related quality of life affecting. So we can go like no bleeding at all. It's not related to the how the severity from even platelet count can be 2, 10, 30, but we are guiding according to the bleeding. So minor bleeding, which is few petechiae, even reach 100 petechiae, but less than small bruises and no at all mucosal bleeding. But mild is all of the above, but we can increase more than 5 large bruises. Moderate, low risk bleeding. Now we can have an epistaxis, but less than 5 minutes, and oral or wet purpura in the mouth. Moderate or high risk, which is epistaxis more than 5 minutes, or hematuria. Severe with internal hemorrhage or life-threatening like intracranial hemorrhage. According to this algorithm, if we can see here on the right, from grade 0 to 3, you can go with only watch and wait, or you can go with oral corticosteroid alone, or you can go with IVIG. But the guidelines, for the ASH is recommending against to, encourage the use of watch and wait. If there is no bleeding at all, we can go from severity from 0 to 1. But 2 and 3, you can go with corticosteroid alone and encourage more than corticosteroid with IVIG. But with severe bleeding, we can go with methylprednisolone, and this need hospitalization, sure, because grade 0 to 3, no need to hospitalize the patient. But from grade 4, you can go encourage the hospitalization. And grade 5, you can go with platelet. This is the only indication to platelet transfusion in case of life-threatening condition. First, I will show my case 1. This is a lovely child, 18 months old. He presented with purpura after MMR vaccine and mild runny nose. He is presenting with TLC 4000, hemoglobin 10, platelet 10, peripheral smear showing giant megakaryocyte. Coagulation profile was normal. On examination, no splenomegaly, no lymph node, 2 oral mucosal bleeding. My plan I choose to just observe the child and to watch and wait. He actually took, but I mean, in this child, you should make sure that the parents are very well educated, that any emergency, they are very accessible to the hospital, avoid any trauma. So I choose in this child to watch and wait, and he fully recovered in 5 months with no complications. And this is a most common peripheral smear showing a giant or macrothrombocyte, or in another case showing the reactive lymphocyte. As we mentioned before, that EBV is one of the most common viral triggering the ITP. Case number 2, it's 13 years old, presented with epistaxis for more than 2 times, more than 5 minutes. So we can give him like grade 3 for the score of bleeding. History post-viral infection, TLC was 10, hemoglobin 13, platelet was only 2, peripheral smear was normal, only apart from thrombocytopenia. On examination, he was free, but he has, as we mentioned, also his body full of purpura and petechia and ecchymosis and many oral wet purpura, as we mentioned. So what is the plan of treatment and course of, in this patient? So in this patient, I can't choose just watch and wait. So according to the guideline, you can go whether to steroid alone, short course, or steroid methylprednisolone IVIG. I choose the steroid and IVIG, and he is fully recovered with only 1 dose of IVIG. And with, I follow him with no rebound thrombocytopenia, and he's fully recovered. And this is the one. This is very interesting case. This is a child, he is around 6 years old. He has a history of more than 2 years struggling with the thrombocytopenia. He was in India and then he came to Dubai. His presentation, when presented to me, I think this is an acute event. His CBC was, TLC was 4, hemoglobin 12, platelet 6. And he has very characteristic or interesting thing in his CBC was a very high eosinophil count, and peripheral smear was normal apart from eosinophilia and macrothrombocyte. Coagulation profile was normal. I choose in this patient to go with anti-nuclear antibody. In ASH guidelines, they are discouraging go for anti-nuclear antibody in acute case, but in chronic case, more than 6 months or more than 12 months, you can go for anti-nuclear antibody because maybe there is a hidden autoimmune disease like SLE. Anti-nuclear antibody in this case was highly high titer, more than 10,000, and I took consultation from the rheumatology, and they did the lupus profile, but all came negative. So the only marker was anti-nuclear antibody positive. This plan and treatment of this patient, actually he went through a trial of SURE IVIG and methylprednisolone, then again another trial of short course of steroid, long course of steroid, rituximab. Then I try with him L-Trombopac with very in the beginning showing no improvement. Then I advised him to go for splenectomy. Also, I tried immunosuppressive MMF, but all the time he is not showing the optimum response, which is more than 30,000 in more than 1 month of treatment. We went for splenectomy, and again he go for platelet count decrease. But the interesting that after splenectomy, and platelet count decrease, we started L-Trombopac and showing now sustainable response for more than 6 months. But I didn't wean him yet. So this is very interesting also slide showing the beginning of the ITP for the treatment since 1735, then how they describe that it's an autoimmune blood disorder, first trial of rituximab in 1998, and then first trial in pediatric rituximab with 2006. As we know that all those trials is done on the adult because of the huge number of population. In romiplastin started in adult, but L-Trombopac in pediatric started in 2016, approved, and 2018 it's romiplastin approved for children, and is the FDA approved for romiplastin and L-Trombopac. Romiplastin is injection, is giving every week, and L-Trombopac is daily oral treatment taking. Romiplastin is kg waiting, by kg, but L-Trombopac is by oral treatment, and both of them show treatment-free response for more than 60% of the patient taking this medication. But till now, there is no consensus about when to wean the patient, or if there is weaning, or to stop gradually, or stop. It's according to the patient, and trial and error. And this is my hospital, and thank you so much.
So, Anjan, do you want to have comments now or later? No, I think you're mute, Anjan.
Yeah, Dr. Bharat, you can have your comments. I'm sure many of the audiences would have comments, and especially the third case, would you go for a splenectomy or not? So you can give your expert advice.
So I think as a practicing pediatrician, it is very important to first make a proper diagnosis. And many times we have seen, mistakes, especially between acute ITP, the clinical presentation is very classical. So it's a very acute onset, multiple ecchymosis, and sometimes mucosal hemorrhages. But then what I recommend as a pediatrician is to look at the CBC carefully to see not just the low platelets, but the absolute neutrophil count. That's a very important clue. If you have a normal absolute neutrophil count, then you can take it as an acute ITP. But if you find that the absolute neutrophil count is on the lower side, especially below 1500, then it is important to consider a bone marrow examination. I don't routinely advise for a bone marrow examination because I see my own slide and peripheral smear, but not all pediatricians have that access to see their own slide or peripheral smear. So this is an important clue from your perspective to see whether the absolute neutrophil count is low. That will give you a clue. And it's very important that we don't miss a malignancy, especially leukemia. And once you start steroids, and if you have missed a leukemia, that's a disaster, because that's a very partial treatment of the disease and incorrect treatment. So that's from the point of view of diagnosis. Another clue, which is a very good clue, is the mean platelet volume, MPV. We look at the platelet count, but at the same time, if you look at the MPV, so it will give you a clue whether if the MPV is high, then which is expected in cases of ITP, then it almost clinches. So a normal absolute neutrophil count and a high MPV, which is a very good bedside clue for you to make a judgment. whether to go ahead with a bone marrow examination or not, because that's a very important question that always parents have in mind. It is always safe to do a bone marrow test, but it's not really, even the ASH guidelines don't recommend.
Not recommended, yes, because it's aggressive intervention, yes.
Yeah.
But all these patients, as you mentioned, the mean platelet volume is going to the high, like 11 to 12. Yes, not that, and neutrophil count was normal, yes, because sure, the steroid, to use the steroid is catastrophic in suspected case of ALL. Thank you for your...
Finish it first.
The second point that I want to make about treatment, for acute ITP, it's not the platelet count that's important, because as you saw in case number 1, the platelet count was just 10,000, and with simple observation, the baby has improved. That's very good that we don't intervene when it's not necessary. So it's not really the platelet count, but you find the emphasis on the clinical parameters. How much bleeding is there, how much mucosal bleeding is there. That's really very crucial. If you have mucosal hemorrhages, you can't wait. If you have only ecchymosis, you can wait. So it's not the platelet count, but it's the clinical picture that is relevant here. So you have to distinguish between acute and chronic. I think that point should be made very clearly, that most of the patients, almost 90% with acute ITP, will recover within 5 to 6 months or even more. In my experience, it could go up to even 95%. So there's really not much to do in cases of acute ITP. And on the other hand, in cases of chronic ITP, as Dr. Nancy pointed out, nothing works. So it's really all or none, because in chronic ITP, in her case number 3, she has used multiple drugs were tried and things were used, including immunosuppressants, but nothing seemed to have worked. So it's really a catch-22. And splenectomy for a 6-year-old baby, unless there is real indication, I would not recommend. Definitely, I would hesitate up to the age of 10 years to recommend for a splenectomy, and maybe just wait and watch. Many kids, even with a count of 20,000, 10,000, just have a few skin bleeds, no real mucosal bleeds. It's only when you have recurrent mucosal bleeds that you need to think about some intervention. But otherwise, and even these newer drugs like romiplastin and L-Trombopag have a very short-lived action. Until you use them, they will work. When you withdraw, there's no permanent remission. So that's the natural history of ITP, where the acute cases will recover in 6 months. The chronic cases may go on for years, and it may take some time to recover. So those are my observations about ITP.
But what also my observation that younger get, cure more than adult.
Of course.
Yeah.
Just wanted to add something. Younger means above 1 year. Now, the more younger, like if you have less than 1 year in 6 months, 7 months, where you think it is an ITP, it takes a little, becomes refractory. Now, I completely agree with Dr. Agarwal saying that the mean platelet volume as well as the neutrophil count is very important in diagnosing or excluding an ITP. There's something which in some hospitals, like we have the luxury to see immature platelet fraction also actually. So that is one thing which is upcoming up. And then when you have a very low, then you think it's a bone marrow failure, and then immature platelet higher. Everything is actually not perfect, but we can actually combine these tests with it. And I fully agree that till date, I haven't gone with a splenectomy to any child actually. It was only because you have an armamentarium of drugs. I have chronic ITPs having with 8,000 living well actually. Each time
there is a situation where splenectomy may be considered as an adolescent girl who has menstrual hemorrhage, which is uncontrolled. Then it's a problem. Where we first do try hormonal therapy, but if that doesn't work, then you may. That's a situation which you can't allow to persist.
Sorry, this patient was on he took rituximab, Trombopag, and immunosuppressant, and platelet count never go above 20. But I didn't, push the patient for splenectomy because only the platelet count. Because on treatment he has severe epistaxis, as I mentioned in this picture. When he has epistaxis, he was on treatment. So that's why I find that my last hope was splenectomy, and his response to the L-Trombopag was better after splenectomy.
So I do agree there are sometimes very difficult cases, Now, in my experience over like 10 years in Dubai itself, I have done splenectomy for only one child who was more than 12 years of age. And this was of the like refractory, like we started Dapsone, had severe allergic reactions with Dapsone, trial of steroids that the child would get better. But over a long period of steroids, the child had stunted growth and there was some problems with the vertebrae. That was the time when I had actually opted for splenectomy after finishing all the drugs which were there actually. And the
So,
child came
yeah,
with repeated bleeding.
I will put this in a nutshell. 90% of patients with ITP would recover within 6 months.
Yeah.
Another maybe 10% would have chronic, which might recover in a few years. And very few, less than 1% are refractory, which might require some intervention. I think that's in a nutshell that we should think about.
We'll go with the next presentation. Now, Dr. Amar is the senior pediatric hemato-oncologist at City Hospital. Over to you, Dr. Amar, for your presentation. I hope the presentation is now sorted out, actually.
Okay, great. Well, thank you for the invitation. The topic today is to discuss neurofibromatosis and basically tumorigenesis. One would ask, why would a pediatric oncologist be involved in children with neurofibromatosis? And I'm hoping that my presentation will highlight for you why we have an interest in this condition. So neurofibromatosis is basically made up of two types. I will start by discussing type 1, which is the most common one. The frequency in the general population is 1 in about 3 to 4,000. The inheritance is autosomal dominant. However, only 50% of the cases are new mutations. So often we may not find that there is a positive family history for NF. The gene has been mapped to chromosome number 17. The gene encodes a protein called neurofibromin, which has been involved in the tumorigenesis pathway. There are manifestations that may be related to tumoral presentations, and then you also have what we call the non-tumor manifestations, which are plenty. Not to mention the least is the development of the skin findings that we call the cafe au lait spots, skeletal dysplasia, very common learning disability. But where an oncologist comes in is really based on the tumor formation that we see in NF1. Typically neurofibromas. If you do a lot of pediatric neuro-oncology, you will be bound to see gliomas. We see also malignant peripheral nerve sheath tumors that may evolve de novo or could be a transformation from a previous plexiform neurofibroma, pheochromocytoma, and then a very unique form of leukemia, non-lymphocytic, that we call JMML, or juvenile myelomonocytic leukemia. Next. For the less common neurofibromatosis type 2, the frequency is about 10% of NF1, so it's 1 in 40,000 for the entire population. Again, the inheritance is the same. It's autosomal dominant with 50% new mutation rates. The gene locus is mapped to chromosome number 22. The gene encodes a protein called schwannomin, or we also call it Merlin. The non-tumor manifestations are not as evident. Mainly these are confined to ophthalmologic findings. But the tumor types are very distinct. Schwannomas are very common, specifically vestibular types, and these children present with diminished hearing. Other formations are ependymomas, meningiomas, and also gliomas. Next. So the diagnostic criteria for NF1 are ever changing, and I will mention to you the latest publication where you would need to have at least 2 or more of these criteria. So number 1, cafe au lait spots. I will come to this point later on, but a lot of people in the general population do have those lesions. So by definition, they need to be 6 or more. As far as size, they should be over 5 millimeter pre-puberty. However, post-puberty, the measurements are now up to 15 millimeter. Skin fold freckles, typically in the axilla and in the groins, and I've seen a lot of babies actually that do present with these, and later on do show that they have neurofibromatosis. So very important for the pediatricians when they see babies to look at these freckles, typically in the axilla and the groins. 2 or more neurofibromas or 1 plexiform neurofibroma, iris/nodules, nodules, 2 or more. These do require a special ophthalmologic examination. Obviously, the optic glioma formation is always a marker of NF. And then there are a lot of skeletal dysplasia, typically in the sphenoid bone, tibial dysplasia. And obviously, if you have an affected first-degree relative, then the concern for neurofibromatosis becomes more evident. There are different complications that arise in relation to NF1, and I listed these by systems. So for the skin, typically these fibromas that we call neurofibromas. CNS, we have learning disability. We also have the tumor formation, typically in the form of gliomas. Peripheral nerves, we have neurofibromas. We have the malignant peripheral nerve sheath tumor. Cardiovascular manifestations can manifest by renal vascular stenosis, which leads to hypertension, pheochromocytomas. Gastrointestinal, there's plenty evidence of the literature about GI complications, typically due to lesions that grow in the lumen and will cause obstruction and constipation. I did make a reference to the endocrine manifestation with a pheochromocytoma, skeletal manifestations with the dysplasia, growth with macrocephaly and short stature, and finally, from the hematological system, the formation of the juvenile myelomonocytic leukemia. Next.
I think is
Yes, static. Yeah.
yeah, net is
Yeah,
lost.
it's working.
No, I think we have lost Dr. Morad.
Yeah.
Well, can we move on to the next presentation then?
We can go ahead with it. All right. Okay. The next will be mine. So I'll just share the screen. One second. Just a second. Can you see my presentation?
Yes, Anjan.
Yeah. Okay. Let's start off now. Being a pediatric hemato-oncology center, you would be mainly getting cases of all sorts. One is pyrexia of unknown origin to rule out a malignancy, basically. So this is an interesting case. As you know, pyrexia of unknown origin. 1 second. Why is it not working? Yeah. So now I'll present this case. Now this is an 8-year-old girl who had on and off fever for the past 2 months, predominantly cervical lymphadenopathy, like they were bilateral cervical lymphadenopathy. And this was post-pandemic. Now, this was rampantly a diagnosis like which I had seen post-pandemic as a multi-system inflammatory syndrome in children, and many children would get treated. So although I'm not very convinced about this entity, so one has to be really sure about this before starting it. But it has been used, like I've seen steroids, anakinra, everything has been used actually. Now this
I
child
think
got
that's more of a diagnosis of exclusion.
yeah, that's true. Now antibiotics, immunoglobulin, methylprednisolone, everything was given, and the child became afebrile. Now and was discharged on oral prednisolone for 5 days, and oral aspirin was given, and it was also given for a short period. Now I'll come back to the investigation. Now this was the initial presentation which I took out from the summary of the child. Now then the child was better. I'll tell you about the investigations were done, but what I could see is that there was only a history of contact with there was a history of contact with COVID, but the COVID tests were negative actually. So the child used to go to school, somebody had a COVID, and then that was the thing. And because of the persistent fever, it was thought about this diagnosis, and there was a bit of
Did
rash
they
also.
do the COVID antibody levels?
Yeah, COVID antibody. So they did the COVID test, but when the child came to us, that was the time when I actually investigated everything. So now this child was again became symptomatic with intermittent fever, and there was no associated chills or rigor. The mother states that the cervical nodes have been static, on and off mild leg pain. There was also wrist and elbow point, and there was occasional difficulty of breathing on upright posture. Now, this was the test which was done there in this private setup, where you look at the ferritin was slightly higher. CRP was slightly again higher. The pancytopenia with a hemoglobin of 10.4, WBC 4.1. The LDH was slightly increased. The neutrophils were to the tune of 0.9. Then they found malaria, dengue, monosport, Vidal, everything, mycoplasma was negative. Now, investigation-wise, X-ray was normal. Ultrasound had mild ascites with mild splenomegaly. Echo was normal. There was no aneurysms, and the ultrasound neck had bilateral cervical nodes, and the largest was about 2 centimeters. Now, family history-wise, when you look into it, there's an elder brother who's doing well, 5-year sister doing well. Father is known to be hyperthyroidism on medications. So we looked at, there was a little bit of goiter to me when I looked into it. Mother had on and episodes of thrombocytopenia and anemia. Grandfather had polycythemia, but otherwise no history of malignancy and all. But this child primarily was sent to our hospital, and our hospital is a government setup, it's Dubai Hospital, and primarily to rule out a malignancy, basically, because of this persistent lymphadenopathy with fever. And so that was the time when they had actually sent to us. Now, when the initial examination, the cervical nodes, bilateral cervical nodes, there were axillary nodes, but they were not significant. But these cervical nodes were about 1.5 centimeter and above. There was no inguinal lymph nodes. There was no hepatosplenomegaly. The spleen tip was just felt, actually. Now, when we looked at the investigation, that was on 5th of July. It was 5th of July. Now, the white cells were to the tune of 2.1. Platelets were 160. Here, the neutrophils were 0.9. And the hemoglobin was 11.4. There was pancytopenia with neutropenia was there. Now, we did the other investigations. Now, at this point, before investigations, our differentials for this. There was prolonged fever, on and off joint pains with previous episodes of aphthous ulcer. Mother gives a history of aphthous ulcers with them. Now, this has been like a pyrexia of unknown origin because of the prolonged history of fever. Now, most of the times we look into it with these ulcers as well as joint involvement. We think about a connective tissue disorder with persistent fever, which is there. But our differentials were, was it a secondary hemophagocytosis post and infection or a connective tissue disorder? Is there a leukemia or lymphoma which is existing in that? Is there a connective tissue disorder? Are there atypical infections which are there? So we investigated the child accordingly. Now, we looked at the thyroid profile. Now, thyroid profile was normal. Now, infection workup, the CRP was around 20, the PCT was 0.9, and then the cultures were negative. There was initial pancytopenia was there. We looked at all the bacterial, we did the whole viral panel, we did brucellosis, we did the quantiferon gold, everything turned out to be negative. Now, we then went ahead with the bone marrow with the thought that, okay, let's rule out a malignancy here, as well as we can, since the child was already on so much of medications, and we said to the parents that now the child has received steroids, the child has received IVIG. Now, many of the diseases can be masked because you have just come after this treatment with us. So still we went ahead with the bone marrow, where we thought that if there is an unusual bacterial infection or some resistant bacteria, maybe a bone marrow culture might help. We did the HLH markers, PTA, PTT, INR was normal. The triglycerides were normal. The ferritin was still in the range of 300 to 400. None of the HLH markers, where we did a soluble interleukin receptor, that was also normal. Now, we did the whole autoimmune profile to look into it. The DCT was mildly positive, 0.5. The IgG was 0.5. That was mildly positive. But your ANA was negative, and the whole markers, we did autoimmune thyroiditis panel, SLE markers, and everything was negative. Now, the whole exome was done later. At this point, I thought that, is it something like an autoimmune lymphoproliferative disorder or not, where you can sometimes have, or say, is there some immune deficiency which is actually manifesting as that? So we actually ordered a whole exome to look into, you have sometimes autoimmune lymphoproliferation, because we have the luxury to get it done, so we did it. Ideally, it is not required, but once we have this luxury, so the periodic fever syndromes and all can be actually rolled out with the whole exome sequencing. So we went ahead for that. Now, we did a bone marrow examination. The bone marrow there was no evidence of malignancy or no evidence of lymphoma or granular infiltration in this, in the bone marrow specimen, with both the aspirate as well as the Trifine showed no evidence of malignancy, or nor there was any hemophagocytosis which was there. Now, if you look, then we went again because the ultrasound itself. Now, the only thought to us was that because of this persistent lymphadenopathy which was there. Now, my thought was that, is it a lymphoma or not, actually? Because sometimes lymphoma can have autoimmunity along with it. So we went ahead with a PET scan. Now, just to see that, like, is it a PET positive? Are the lymph nodes PET positive or not? So to our surprise, we had many nodes, which are cervical lymph nodes, which were avid actually to the PET scan. This was the time we thought that, is it something like a lymphoma, like a Hodgkin's lymphoma or a non-Hodgkin's lymphoma? But so with an autoimmune, we know that Hodgkin's lymphoma may have autoimmunity, which is, so that was the time when we said, okay, the PET scan had lymph nodes. This the PET avid lymph node, the cervical lymph nodes which were there. So we went ahead with a biopsy of this lymph node which is there. So we asked the pediatric surgeon to get ahead 2 good lymph nodes which were PET positive, and then ultrasound, we did an excision biopsy of these lymph nodes. And what did we find? Now, this was the impression. Hypometabolic lymph nodes are noted in the cervical supraclavicular. So you literally have hypometabolic lymph nodes. Now, there was some focal hypometabolic lesion which was proximate to the liver margin, and focal lesion to the pubic symphysis. Now, this was the final impression which was given to us. So if you look at the cervical lymph node, these cervical lymph nodes, I didn't take the whole picture of it, but if you look at the cervical areas, these lymph nodes are really PET avid actually, which gets us a suspicion of, is it a Hodgkin's or not? Now we went ahead with the lymph node biopsy. Now, to our surprise, what did we find here? Now, there was zonal necrosis, and this turned out to be a necrotizing lymphadenopathy with crescentic histiocytes and immunoblasts were compatible with Kikuchi disease. So, like we did encounter some of the Kikuchi disease while training in India. I had seen a couple of Kikuchi disease, but primarily dealing with malignancies, we generally think about a malignancy when you have a PET avid. But having said that, PET scan is also positive in many of the inflammatory lesions, like even a fungal, a bacterial, a tubercular, as well as. But what is important is that this actually guides you where to do actually the biopsy, and then this is an answer where it is. Now, having said that, this is just an asymptomatic, so we just have to give symptomatic management for these children. So what we went ahead, so what we did is that we just gave paracetamol. That's all what we actually did it, and discharged the child. The fever subsided in a matter of 72 hours. With the thought that we did say that if it is symptomatic, we might give some NSAIDs, or we can give steroids in some cases. And then after like about a month, or because this child came in July, 2 weeks after that, we did a blood test where we said we saw the improvement in pancytopenia. This is after 3 months where we looked into it. So things have all improved actually. So meanwhile, we got the whole exome sequencing, which had actually no mutations which are there. That was an additional test which was there. So this is what I concluded with my references. I'm happy to take any questions.
Yeah, I want to make a few comments, Anjan.
Yeah, sure.
Yeah, very nice patient, and you were lucky to get the diagnosis. So my teacher was Dr. Zeenat Karim Boy. She's no more with us now, but she's one of the pioneers in pediatric hem-onco. Kalpana knows her. She has met her. And she used to say, her patent dialogue, go where the money is. So you have this patient with the lymph node sitting from day one. And definitely that's the place to go. I mean, that's what we need to, that's what we need to do. So I have some more points to make. Apart from, so lymph node biopsy should have been upfront done much before. It's just retrospective that it's easier to say that, but on the bedside,
but we got the biopsy done in a week's time actually, because we just read.
Absolutely. So I have some more clinical points, from our pediatrician's perspective. It's, malignancy is definitely number one. Kikuchi is an inflammatory syndrome, not a malignancy, but malignancy must be ruled out because malignancy, like a leukemia, lymphoma in a child, can be cured today. We can have a treatment done as soon as possible. So what are the things that you can do? Number one, we discussed about absolute neutrophil count in the earlier presentation. The same thing applies here. And if you have a bicytopenia and if your ANC is low, and if bone marrow doesn't show up the malignancy, it could be, as Anjan explained, due to the steroids or immunosuppressants received by the child. And we have to sometimes wait for months before we can make a conclusion. So, partially treated child with steroids may go into remission and may take months for it to reappear. So that's number one. Number two is a very good clue which I have found in practice is the values of LDH and uric acid. So if you have high levels of uric acid and high levels of LDH combined with a bicytopenia or
the uric acid was normal and the LDH was around 400.
Yeah. I'm just emphasizing for our audience, that these are things that can be done at the bedside to look at, what possibility is there. And then, of course, PET scan is a good methodology to find out active metabolic disease. But I think as clinicians, we can straight go for a biopsy. There is no need to wait for a PET scan. But if there is bicytopenia, I would first do a bone marrow. And if that doesn't reveal much, then I would straight take the patient for a lymph node biopsy. And the biopsy is the diagnostic for Kikuchi. There's nothing else that you can clinically tell between Kikuchi or a malignant process. So that's biopsy is essential. And earlier it is done, the better. And as Anjan described, there's no real treatment. It's just wait and watch. And we just hope that most of the children do well. There is no problem. But I want to emphasize that malignancy has to be ruled out first. That's very important. Only then you can relax. Until then, it's not fair to wait and watch. Okay.
Thank you, Doctor.
I just want to ask, do all Kikuchi do well, or after a long time there is a problem in them, or all of them across the board will do well?
So till date, like I have seen about 3 Kikuchi's disease which were there. By the time this child came to me, it was already 2 months. So I did a basic investigations and all. Within 72 hours, the fever subsided actually. With the thought that if the child, because if you look at my clinical presentation, there was difficulty in breathing also. There was one condition which symptom was there. So I was wondering in the sense that if there is some lymph node which is causing respiratory distress and all, maybe at that time, if the clinically indicated, like after ruling out a malignancy at this point, you can just give steroids for a short course. Having said that, cervical, the biopsy.
Go ahead.
So biopsy for us is like, it's not in India where you say that do the biopsy and the surgeon is sitting out here. So that doesn't, because then you have to look into various clinical scenarios which are there. Now to request a surgeon, and fine needle aspiration has no answer in these things. Absolutely. So you have to go for an excision biopsy. You have to tie up a surgeon the pediatric surgeon who is in another hospital. Meanwhile, then at that time, the parents are anxious. But by the time they know that lymph nodes persisting, fevers going on, the thought is malignancy. And being a pediatric oncologist, I also are inclined to think it is a malignancy, persistent fever, and all these lymph nodes which are there.
You also describe leg pains. So that's
leg pains. So leg pains, bone pains, one of those malignancy issues which are they often present with all these arthritic things also. Now, to me, the thing was that now you have multiple lymph nodes, and given the fact that most of the cervical lymph nodes, if you just go for an excision, but sometimes it can turn out to be a reactive node because the persistent cervical nodes. So generally, we don't agree for cervical whenever we have an excision biopsy. If you have other nodes which are accessible, we generally go for that, unless it is very significant, which was done. So this was one of the, and we had this one, and then it could be, and I thought it was, like, frankly speaking, I thought it was a Hodgkin's. So I wanted to do a staging in the first accept itself, actually. So that was the thing which is there. Any other questions we have?
I think we should move along, Doctor. We have less time left.
All right. Okay. So, so thank you all. Thank you, Dr. Bharat, for your excellent overviews on these cases.
Is Dr. Morad coming up, or is he not accessible?
Yeah, maybe I think we lost him, I guess. So. Anyway, the questions with like if you have neurofibromatosis is one of the most important things which we generally encounter, NF1. I have a few cases of optic gliomas as well as I have a few cases of malignancies. I have a child with rhabdomyosarcoma with an NF1. The most important thing is that the stigma for NF1, like multiple, like every pediatrician must be knowing about it, like more than 6 or 6 capillary spots, or if it's a large spot or a plexiform neurofibromatosis. So these are the conditions where you have to actually rule out an NF1 mutation in these cases. Now, what is important is a screening is required in these cases because of the predilection for cancers. So one has to actually do all NF1 have cancers? It's only 6 or 7% of the population do have like a risk for cancers, and mainly it is seen in younger children. Now, there could be transformations like neurofibromas getting a rhabdomyosarcoma or a sarcomas in some. So it's like a screening which needs to be done in such children. Optic examination, because optic gliomas are one of the most important thing. You can have brain tumors like SEGA, and there are many drugs which have come. Now, most of the times when we have optic glioma, we have 2 optic gliomas with NF1. Those who do not require treatment, it is just observation because they are very slow growing tumors, unless symptomatic. If you have symptomatic in the sense if there is compromise of the peripheral vision, then you start off chemotherapy. There are certain chemotherapies which needs to be given. And now there are different mutations too. Now, if you have a SIGA with an NF2, then there is something called rapamycin or sirolimus which can be given. So there are various factors which are there. And I think Dr. Murad is interested more in NF1 because he had come from Cincinnati. He is having an NF1 clinic or something. So that is what I know. But we all do have these spectrum of cases, NF1. And is there anything, Dr. Agarwal, to add to it?
No, well said. There are new drugs that are coming up which can be targeted to actually work at the genetic level. So that's what it's all experimental. All experimental. You mentioned rapamycin and others. So there are many.
Is one thing.
Yeah, many new drugs which are in the pipeline and things. I think in the next decade, the scenario for neurofibromatosis will definitely change. And he mentioned, Dr. Morad, about juvenile myelomonocytic leukemia. That you may not have clinical manifestations of neurofibromatosis, but at the genetic level, there could be defects. And again, these newer drugs and agents are being useful because otherwise JMML is a uniformly fatal condition unless you do a bone marrow transplantation. So I think that's it. I think we had a good discussion. And before we end, I want to thank Dr. Sohrab, Dr. Kalpana for inviting me and having me here. I've been enjoying since morning, and it's a wonderful scientific program. And I'm very happy to see more than 600 pediatricians joining the program online. So it's really a great effort. You're doing a very good CME, and I hope that we'll have a chance again in the future to join you. Thank you very much. Thank you.
Thank you. Thank you.
Now, I would like to thank also Bharat Agarwal. I would like to inform the viewers that Dr. Bharat Agarwal is one of the pioneers of pediatric hemato-oncology in India. He was president of Asia Pacific Society and so many other positions. It was really an honor to have you and your comments.
Dr. Sohrab, you may not be aware, but Dr. Kalpana has been my student at Wadia Hospital.
Absolutely. It's so nice to see him again. And we've been trying to rope you in since a long time, and we hope we'll be able to get you in future again.
Sure.
I would like to thank Dr. Anjan also, Dr. Ammar and Dr. Nancy for the excellent presentation. We are going to have a lunch break, and at 1:30 we will start the next session. Once again, thank you very much. See you at 1:30, please.
Thank you.
Thank you all.
Thank you.
Center of Excellence. He left me. Okay.
Good afternoon. I would like to welcome all viewers back to our session. We have a very important session, especially nowadays. Everybody, 9 out of 10 children are having respiratory problem. We are having eminent speakers and panelists. Dr. Amir has not joined. I would like to request Dr. Fatima to start the session by introducing the speaker and panelists. We are very happy to have Dr. Bhatt with us also from UK. All of you welcome. Dr. Fatima, please. Dr. Fatima is not a Dr. Omi, you please start introducing till Dr. Fatima joins.
Sure. So thank you, Dr. Saurabh, for asking us to speak in this eminent conference. We have 3 amazing speakers today. Well, I wouldn't count myself as an amazing, but I'm there as well. So we have first speaker is Dr. Rizwana Papatia, who is the medical director of Mubadala Health. She used to be working at Al Jalila, and now since then she went to King's, and then subsequently working at Mubadala Health as a pediatric pulmonologist and medical director. Then Dr. Jayesh Bhatt will take over. He used to be my mentor in UK, so I'm really glad to join this panel along with him. So he is a pediatric pulmonologist at Nottingham Children's Hospital, and he has been extensively engaged in the educational activities of ERS, European Respiratory Society. And third speaker is me, and I'm a pediatric pulmonologist who moved to Dubai last year from UK, working at American Hospital. And our moderator for this session is Dr. Fatma Al-Jassim. She's a pediatric pulmonologist at Jalila Children's Hospital. I'm sure she will join soon, might be some technical problems. So we'll start the first session with Dr. Rizwana, who's going to talk about a case presentation on obstructive sleep apnea. Over to you, Rizwana. Do you want to share your screen, or you would like me to share? Let me know.
Yes, if you can share it, that would be great, Omi, so we can have that continuity. Is that okay with you?
Absolutely, yeah. So let's see if we can do this. And can we see the screen? Okay.
Yes. Will I be able to control the slides, or should I say next and that's fine with you?
You can just say next and I will move on.
Okay, next. Yeah. Okay. Hi, everyone. Dr. Omi, thank you for the kind introduction. And without wasting time, today I'm going to present about obstructive sleep apnea.
Dr. Omi, if you can just go to the presentation mode.
Is it not in the presentation mode?
No, it's not started.
From my angle it is. Let me just see if I can see in the other mode. What about now?
It still shows the slide on the side. I don't know if there's that button on the bottom where you, on the bottom right, very bottom right. There's a presenter.
There is a glass sign, glass of wine, sign of glass of wine.
Yeah, I think it's there now. I think it should be there.
Yeah.
Still not working? Still not in the slideshow mode?
Not yet. Doctor, switch off, just close the presentation.
Okay, let's close it.
Just see whichever the PowerPoint presentations are open, close it all.
Okay.
Let not be any presentations are open. Now we can start it again.
Omid, while we're trying to figure out, if you want, I can just start, like, it's otherwise.
Sure.
Or we'll wait for a minute, yeah, otherwise we can.
Is it any better?
No, that's okay. What we can do is.
Doctor?
Yes.
Below you can see like 128%.
No, I can't on my.
No. You're already on the presentation view for you.
Yes.
Just like you have to close it, all the presentations, doctor. Once you have to escape, click escape and close all the presentations. I think once you open the presentation mode, now it is.
I think it's done. Yeah, perfect. Perfect. So let's start. Thank you so much, Omi. Thank you. Next slide, please. So we will start with a case, and this is not one case, but usually in the pediatric practice and even in pediatric pulmonary practice, you see a lot of such patients day in and day out. So for example, a school-going child or a preschool-going child presenting with recurrent colds, snoring at night, almost 5 nights out of a week, has mouth breathing despite not having a cold at that time, and wakes up thirsty in the middle of the night. So when you ask about symptoms of sleep, usually we miss it. Like, we don't ask about sleep symptoms when we take history of respiratory system. So it's very essential to ask about snoring, mouth breathing, waking up thirsty in the middle of the night. This child also wakes up and cries in the middle of the night and sleeps once his mom brings him to her own bed. So he has some symptoms of parasomnias or sleep terrors or night terrors. He wakes up in the morning tired. So when you have a good quality of sleep at night, you should not be waking up in the morning tired, but you should be fresh. And he's hyperactive throughout the day. And his daycare teachers complain of being very disruptive at school. So just to give you overall of an idea, like, we are discussing about obstructive sleep apnea. Snoring is one of the symptoms. Mouth breathing is one of the symptoms because there is obstruction in the upper airway in the nose or adenoids. So the child tends to breathe by mouth. Because the child is breathing by mouth and there is no humidification of air, the mouth becomes dry and the child wakes up either in the middle of the night thirsty, or in the end of the, when he wakes up in the morning, he's very thirsty. As I already mentioned, because of the poor quality of sleep, the child has the child doesn't wake up fresh in the morning. Now, this child does not have history of asthma, but has used nebulization few times in the past with colds. So this kind of gives you an idea that this is not your typical reactive airway disease child, and that's why he's having all these symptoms. He has frequent runny nose, sneezing, itchy eyes when weather changes. This is suggestive of allergic rhinitis. No other significant past medical history. There is no family history of asthma. He is hemodynamically stable. And again, so just to emphasize, sleep problems are usually more symptomatic. So in clinical history is very, very important to diagnose sleep-related disorders. So next slide, please. Again, when we talk about sleep disorder breathing, it's not one simple disease. It's a spectrum of disorder. So when the obstruction, as you see in this slide, goes from low to high obstruction, the symptoms becomes more severe. So initially you start with snoring, then the child has respiratory effort-related arousal, waking up in the night multiple times. Then you have obstructive hypoventilation, so you're not breathing adequately. Then you have hypopneas, where you're breathing less than 30% of what you are expected to. And then you have apneas, where you have pauses in breathing. You stop breathing for a few seconds. So as the obstruction increases, the symptoms gets worse and worse. Next slide, please. Very important to know, like, every snoring is not obstructive sleep apnea. So up to 10% of kids snore. And out of that, only 1 to 2% has obstructive sleep apnea. So we don't, just the take-home message from the epidemiology slide is, not everybody who is snoring has obstructive sleep apnea. So we must dig deeper into the history. Next slide, please. Looking at definition, and this is just for our understanding, if there is a reduction in airflow by 50% with change in oxygen saturation or arousal, it is called hypopnea. And apnea is either you have pause in breathing or your airflow is reduced by 90%, again with change in your oxygen saturation. So we all have, if we do sleep study in all of us, we will have hypopneas and apneas. We'll have pauses in breathing, but if our oxygen saturation doesn't drop down, we don't classify them as a positive events. Next slide. We can go to the next one. Again, obstructive sleep apnea happens due to many reasons. So anatomic reasons, you have big adenoids or tonsils, a big tongue in kids with Down syndrome, obesity like neck bed of fat, or craniofacial abnormalities. So these are the anatomic causes. Then if you have inflammation of soft tissues, which could be reflux, allergies, upper respiratory tract infection, can contribute to obstructive sleep apnea symptoms. Next one. Craniofacial abnormalities, neuromuscular disease, truncal hypotonia, spinomuscular atrophy, or altered soft tissue size all can contribute to sleep apnea. Now we look at the school age going children between 2 to 18 years of age. One thing, the take home message is adenotonsillar hypertrophy and obesity are the most common causes. In school going children, it's adenotonsillar hypertrophy. In teenager, it's usually obesity. And superior upper airway obstruction in most cases is related to obstructive sleep apnea. Soft pellet size is increased by 30% in patients with OSA as assessed by MRI. So we have to keep that adenotonsillar hypertrophy in mind when we see obstructive symptoms, snoring, mouth breathing in children of school-going age. Next slide. This is the picture of kissing tonsils, and you can see it's so obstructed. Next one. One thing to remember about adenoids is it grows maximum to the age of 7. And when the patient or the parents present with the history that, oh, we have removed the adenoids when the child was 2 or 3, the adenoids can regrow. So adenoids here, you can see in the picture, it is located at the roof of the nose and they can regrow. So it's very important to keep this in mind. This is again a nasal endoscopy picture of a small adenoid versus a large adenoid. And you can see the obstruction of the airway here. Next slide. This is the X-ray, and here you can see the airway, like, the air shadow, the black line. And here you can see the adenoid growth. It kind of narrows down the air passage. Again, consequences. So why do we care about OSA? You just snore at night, you breathe with your mouth open, what a big deal. Your oxygen drops down in the night few times, like, you desaturate. Why do we care? So there are a lot of cardiovascular, cerebrovascular, and metabolic consequences of untreated OSA. Excessive daytime sleepiness, hypertension, impaired glucose tolerance, poor control of diabetes, increased cardio and cerebrovascular disease. Studies have shown that there is a 6.3 times increased incidence of motor vehicular accidents, pulmonary hypertension, and right-sided heart failure. These are all general consequences. Now, there are some consequences of untreated obstructive sleep apnea, which is specific to children: failure to thrive, developmental delay, executive function impairment. So you get all these complaints from school of grades dropping and child being disruptive, impairment of memory and intelligence. And the most important thing is ADHD, attention deficit and hyperactivity disorder. So 20 years back, when in US they did a study of a lot of kids who were diagnosed with ADHD and were treated with medications for ADHD, were found to have obstructive sleep apnea. So in adults, when we do not get a good night's sleep, we tend to be tired, we sleep during meetings, we sleep during conferences, but children behave in an exact opposite way. They're more hyperactive, they're more disruptive when they don't get a good quality sleep at night. Coming to the workup, next slide. Usually there is no definite workup, it's more clinical questionnaires. There is no role for laboratory test. Sometimes polycythemia or hypothyroidism, so TSH can help. Sleep study is the gold standard of diagnosis. And next slide for me. So this looks very crazy, but this is not to scare anyone, but this is what a normal sleep study looks like. And you can see on the left-hand side, there is 8-lead EEG, then there is EOG, ocular movements, mandibular movements, limb movements, snore microphone, oxygen, carbon dioxide, nasal airflow. And here you can see the chest movements and the abdominal movements. The green one is the chest movements, the purple one is the abdominal movements, and at bottom of that, there was EKG and oxygen saturations. And here, this is an abnormal sleep study where you can see pauses in breathing. And when there is this pauses in breathing, you can see the oxygen saturation dropping down the bottom line from 90 to 78. And then the child breathes again and the oxygen saturation goes back to 97. Again, there is a pause in the respiration and the oxygen saturation goes down to 80. So this is what obstructive sleep. And then you can see the nasal airflow is a flat line over here. And that is suggestive of obstruction. So as I said, sleep study can identify sleep disordered breathing, abnormal brainwave activity because it has EEG, arousals, and the quality of sleep, oxygen and carbon dioxide. It also has an EKG, so you can determine abnormal heart activities. You can detect periodic limb movement syndrome from the limb electrodes. And again, the take-home message is not every person with obstructive sleep apnea snores. So even if you don't have snoring, if the suspicion is high, you should always order a sleep study or refer to the pediatric sleep medicine physician for a sleep study. And not every obstruction is associated with change in oxygen levels. The last part is the treatment, and please. So lifestyle changes, weight loss, avoiding allergens, sleep hygiene is very important. Medical treatment for enlarged adenoids, nasal, intranasal corticosteroids, and montelukast have been found to be helpful. If it is an anatomical obstruction, tonsillectomy and adenoidectomy, and in very resistant cases, tracheostomy has found to be helpful to treat obstructive sleep apnea, and certain orthodontic procedures if you have mandibular or maxillary issues. Next slide. We'll come to CPAP is the gold standard of treatment. This is mandibular distraction. They try to elongate and expand the mandible, has been used to be helpful. And CPAP, continuous positive airway pressure, is the gold standard of treatment. Next slide. And what CPAP usually does, it takes the room air and delivers it with predetermined pressure, and it stands the airway open. It's like if your pipe is blocked and you put air in there to open the pipe. That's exactly what the CPAP does. It gives pressure, there is no oxygen, it just takes the room air, delivers the same room air with amount of predetermined pressure, whether it is 5 millimeter mercury or 10 millimeter mercury, and it stents the airway open, as you can see in this diagram. Next slide. It was first described in 1980s. It is considered the gold standard of therapy, and just like inhalers for asthma, it is the treatment, it's not the cure. So compliance is the key. Go ahead. As I said, it stents the airway open, it prevents dynamic collapse, and there are different types of CPAPs available. They're very fancy, there are children friendly as well, and they're very portable, so you can carry them wherever you travel. So my summary slide is OSA is under-recognized and under-treated. It's not just an adult problem. It requires multidisciplinary approach and involvement, and it can recur or worsen over time. So it's like your asthma, and it carries many short and long-term risks. Thank you so much. I hope I finished in time. Thank you.
Thank you so much, Anna. That was a lovely overview and summary of obstructive sleep apnea. I would ask Dr. Jayesh to present his talk, and then we will take all the questions in the end. So Dr. Jayesh, if you can share your slide, please.
Dr. Omi, if you could, yeah, I'll do that. I'll share now. Can everyone see my presentation? Okay. Thank you for the invitation, Dr. Tomerai, Dr. Sengupta, Dr. Omi, and thanks for the kind invitation. I'm going to talk about monitoring.
Not coming, the presentation, we cannot view.
We cannot see the presentation yet, Dr. Jayesh.
Okay, so I'm able to see it and I can move the slides as well. So I'm puzzled.
Yeah, there might be other screen that you might have to share. If you go on screen share, there are like various options. So just try with the other one, because that's what was happening to me as well.
Okay, so let me stop the share.
Yeah.
And then share screen. And which one do I share? Because I think there is the screen, there is a whiteboard. So, okay, screen. And
yeah, this one.
Can you see them now?
Now we can see, yes.
Okay.
Thank you.
Thank you. So I'm going to talk about monitoring and weaning of home oxygen therapy in babies with bronchopulmonary dysplasia. I hope that by the end of this presentation, you will be able to understand and apply that a structured and monitoring and weaning pathway leads to better outcomes in these babies. I'm sure you all are aware of the definition of bronchopulmonary dysplasia, and there are multiple definitions which keep changing, but at the basic level, there is need for oxygen beyond 36 weeks post-menstrual age. So in my talk, I will demonstrate that there is so much variability in practice, both from determining when do you start the babies on oxygen, how often do you monitor, and when do you wean. And then I'll present some evidence that shows that structured monitoring does lead to improved outcomes. So once it's been decided that the baby has got bronchopulmonary dysplasia, then a group of neonatologists and pediatricians were asked, what is the oxygen saturation level at which you would consider initiating oxygen therapy? And as I can show to you that, whether you looked at nearly 300 neonatologists or nearly 300 pediatricians, American and German, and they were asked, what saturation levels, and most of them sort of go with 90%. So if the baby is not able to maintain 90% on air, then you would commence oxygen. But the point of this slide is that there is so much variability. There are different clinicians looking at different saturation levels in initiating the oxygen therapy. Now, we carried out a survey in UK. It's a questionnaire survey for all the major pediatric neonatal units, and asked them, what is it that you look at when you initiate oxygen? What is it that you look at when you wean oxygen? And the two top panels are telling you that most people look at average oxygen levels right through the night and the time below 90% through the night. But there again, there is a significant variability in clinicians looking at other things as well. And the same applies to when they start weaning. But what I wanted you to focus on is, we asked the question to the clinicians whether they were aware about the oximeter averaging times, which are used to detect the events. And I think worryingly, more than half of them actually did not know the answer to the question on averaging time. And why is that important? I think averaging time is important because with the older monitors, whether they are Nelcos or Omidas, you had averaging times of, definitely more than 8 to 10 seconds, generally it was 16 seconds. And when you have an averaging time, what does the averaging time tell you? When you look at the monitor and the number you see is actually a rolling average of previous readings. And it's how often that you average at what frequency, that's what the averaging time is. So if you have a longer averaging time, then you're likely to capture fewer desaturation episodes, as it's shown in the blue line, which is sort of the longer averaging time of 16 seconds. And the other thing that happens is that, if you have a longer averaging time, then actually the number and severity of the dips could be underrepresented. And then all the shortly clustered intermittent hypoxic episodes get combined into a sort of fewer but a longer hypoxic event. So you overestimate the duration of hypoxia, but you underestimate the number of dips in the saturation levels. And that's been shown in sort of more than one studies, which I've just illustrated here. So the averaging time is really, really important. So when do we decide in our practice that the baby is ready to be discharged from the neonatal unit in home oxygen? And I've amalgamated this information from several national and international guidelines. So clearly, the baby must be medically stable, and we generally say that they should not have had an apnea for at least 2 weeks, and they're only having infrequent episodes of desaturation. And they should be meeting targets on oximetry in a constant flow rate. I think that is really important because you're looking at stability, and you can't be sort of increasing and decreasing the flow rate at home, because that just is not good practice, and that leads to dangerous outcomes. And what do I mean by meeting targets? I'll show it to you in the next slide. I think also you need to bear in mind that when we have nasal cannula with on the baby's nostril, sometimes that the cannula could slip off a bit, and therefore the baby should be stable enough to tolerate that slight periods of desaturation. And generally, this equates to when the oxygen flow rate is less than 0.5 liters per minute. Because the higher oxygen flow rate is telling you that you have less margin of slippage, but also that the lung disease is that much more severe. In some countries, say for example in Australia, where they might have the families might have to travel very long distances to attend a clinic, they also have the practice of doing an air test before discharge. Essentially, what they look at is that once they've determined that this baby is ready to go home in oxygen in this flow rate, then they will discontinue the oxygen for 4 hours. And as long as the baby maintains saturations above 80%, then they say this baby is safe to go in the predetermined flow rate. That practice is not common in the UK because you don't have to travel these many distances, and we would have determined the safety in the previous flow rate in the unit, and therefore we don't do the oxygen discontinuation test in this sense. Obviously, they need to be growing properly, because really growth is the proper treatment for bronchopulmonary dysplasia. As you grow, you will come out of oxygen. And they need to train and educate the parents about the suitable home environment, about the fire risks, about avoiding any secondhand smoke exposure. If they're going to travel and take oxygen in the car, and letting the car insurance and home insurance people know. Now, one of the things that confuses families is that while the babies are on the neonatal unit, rightly so, and from the evidence from the boost studies, they will aim for lower, safer oxygen targets because of risk from ROP as one of the main things. But once you get beyond 36 weeks, then I think you're looking at different targets. And that's because your lungs going through different stages. And now at 36 weeks and beyond, you are into the alveolar phase of development, where there is significant new acquisition of alveoli, and that is going to improve the gas exchange area available, and that's how the baby is going to come up. As we all know that the lung volume goes up about 23 times from being born to an adult in healthy subjects. So that is really what is most important, and therefore you look at different targets. Also, your antioxidant mechanisms are more mature and better developed, so there are less concerns about oxidative damage, which was going on in the preterm lung. And I think you've got to be mindful of worsening or development of pulmonary vascular disease, because I think if ongoing low-grade chronic hypoxia can lead to pulmonary hypertension, so you want to be preventing that going forward as well. So therefore, you look at different targets beyond 36 weeks. So what target saturation do we look at? Again, this is an amalgamation of British, French, Australian, American, and ERS guidelines. I think you should be looking at least 93%. The ERS guideline talks about 90% because the studies they had included them in their guideline appraisal process were very, very rigid and only randomized controlled trials, but no observational studies, while most other guidelines will look at least 93%. If you're concerned about pulmonary arterial hypertension, then you would be more generous and aim for about 95%. And look at the total time below 90% should be less than 5%. And when I put the asterisks here, so the most guidelines just look at the two markers, the mean or the median levels and the time below 90%. We heard a beautiful talk on obstructive sleep apnea and disordered breathing. This is where the DI4 or DI3 is more important, but not so much in babies with the bronchopulmonary dysplasia, and none of the national or international guidelines really ask you to look at that. And what's about the duration of recording? I think you need to have minimum of 4 hours of data There is a suggestion that if you have sort of overnight recording, that's sufficient. You know, the group in New Zealand had compared overnight versus 24-hour recordings, and they did not find any difference in clinical decision making when you looked at the longer period. So I think overnight is sufficient, and at least 4 hours of data. So I emphasize this is probably the most important slide in my presentation, that you know what targets to look at. But I have pointed out to you earlier about the desaturation and the averaging time. So when you start looking at the newer monitors, because all the data from that previous slide is largely based on studies done on the previous generation monitors. Now, when you start looking at newer monitors, there are so many studies which have been published, which have shown that with the newer monitors with the signal extraction technology and shorter averaging times, whichever group you look at, when you start looking at beyond 36 weeks, the saturations, are above 97%, okay? And they are really spending very little time below 90%, so 1.3, 1.1, 1.95. So I think now that we all are using the newer monitors with shorter averaging times and better signal extraction, there is possibly a need to revise the targets. And this is what we have suggested in one of the review articles we wrote up for the pediatric respiratory reviews, that minimum you still say at least 93, and the higher in some sense is going to be the better, and time below 90%, because there has been sort of some studies which have looked at up to 2%. So we've been conservative here and we say less than 3%. If you do look at the ODI, then you got to be mindful that in the younger age groups, it is physiologically higher. And I think obviously if it's much higher than this, then it tells you that there is much more variability, and that has got autonomic consequences. So you want to then maybe increase the flow rate to bring the baseline to be better. And this is an example, I've got this study on the left-hand side, and this baby was ready to go home after being born 23 weeks. And you can see a study that was done in 0.2 liters, and there were significant fluctuations around the baseline, and quite a high, higher than what you allowed from my previous slide. Next day, we repeated the study in 0.4, and forget the numbers. When you just look at the baseline, you can see that there's a clear difference. And then this flow rate was then determined to be the right flow rate for this baby. So in our practice, we established a BPD service for the last 15 years, and we sent home more than 402 babies, and then looked at more than 3,000 studies. And the demographics are very similar to what you would find in any BPD studies. More boys than girls are affected. Median gestational age of 26 weeks, birth weight 840 grams. When I was setting up the service, I was worried that I'm going to create a lot more work for me. But I have analyzed, and we have a median of 7 studies per baby. That includes the first study before the baby goes home, and the final 2 air studies. And I'll explain to you what I mean by air studies. And typically when I go and see a baby on the neonatal unit, the parent asks me, how much oxygen is my baby going home in? And is that typical of what other babies do? So as you can see, that the vast majority seem to be going home in sort of, less than 0.5 liters per minute, which I alluded to earlier as sort of a safe level. But there are some babies with several caveats do go home in higher oxygen flow rates as well. The commonest flow rate seems to be 0.3 liters. And that is consistent with some old data that was published in the UK that, most babies seem to go home in that sort of an amount. Once they've gone home, then we start looking at weaning. And I think the readiness to wean is often subjective, and it's quite a complex interaction between how much oxygen they are in, what their overall lung health is, are there any other medications, what's the time of the year. You might do it faster in the summer as compared to the winter. But there is also wide variation in weaning strategies. This was a survey carried out in America, 184 questionnaires in 20 centers, and actually only 8% at the time mentioned that they use the standardized protocol, which was not described in that paper. And they look at various different things, but growth is the most important parameter to see if the baby is ready to be weaned. And whatever predictors are there available in the literature are mainly based on the neonatal unit. Most of the time, we don't admit the babies to the hospital to wean the oxygen. When you start looking at, what are the parameters, then I think studies have suggested that they can maintain SATs above 92% in air within 40 minutes of discontinuing oxygen. That seems to be a good predictor for weaning. The other marker has been sort of oxygen flow rate 0.02 liters per kilo per minute or 20 mils per kilo per minute. That seems to be a good marker as well, and I'll show you more data on that as we go along. They need to be gaining weight. I think that's will increase the chances of coming off the oxygen. We don't use steroids to get the babies off oxygen, but there is a description of that in the literature. What do you wean first? Do you wean the flow rate or do you wean the time? And I think the consensus seems to be that majority of people will go down by the flow rate. So if you go home in 0.5, the next one should be 0.4, 0.3 that way, rather than saying that you have 24 hours to go down to 23. So most people will wean on flow rate. I think there is still debate as to whether the continuous low flow and then sort of taking them off straight away, or doing sort of continuing oxygen in naps, but taking them off when they're awake. And I'll again show you some data in a minute about that. But what most people agree is that from a low flow rate of 0.1 liters per minute, you can wean them off. And I think that's the recommendation from the American guidelines as well, that once you get to 0.1 liters per minute, then you should try the air. And this is important because I think there is in the UK still practice in places where the babies are sent home in very low flow meters. I don't think that is a safe practice. There is always likelihood of people getting confused with the decimal points. And truly, once you get to about 4.5, 5 kilos, a flow rate of 0.1 and less, it means that you're essentially delivering air to the lungs rather than oxygen. Okay. And what about the targets that you look at, the numbers when you wean? And again, like initiating oxygen, there is a huge amount of variability in the number that people look at when they say, okay, if you hit that target, you're ready to wean the flow rate. What about how often do you repeat the sleep studies? There again, there is significant variability. So when do you do the first sleep study? I think people seem to be doing it at different times. Our practice is that we would do it within the first 48 hours, in fact, within the first day of going home. What you want to determine is that on the neonatal unit, when everybody was monitoring the child, and there is the baby is in a safe healthcare environment, you determine that this flow rate is fine. It will be fine at home as well, but you need to confirm that. So we would do the first study in the same flow rate at home, and then we would follow up, do studies at 3 to 5 weeks, depending on the time of the year, the growth, etc. And this is, so how often people repeat studies, there again, there is significant variability, but our standard, as I've shown you with very good outcomes, is initial study in 24 hours and then every 3 to 5 weeks. So this is the pathway that we publish. And as I said, the first study at home, and then you can go on reducing by 0.1 every 3 to 5 weeks. Once you get to the 0.1, then we used to, I emphasize the word used to, because we've changed the pathway since then. We used to do a daytime home air study, and if they can maintain above 93, then we would ask the families to increase an hour every day. So that in about 2 weeks, they are off oxygen when awake in the daytime, and then we do the nighttime air study, and then we wait about 10, 12 weeks before we do the final air study. And then if the baby has had a cold and coped well, we'll get the oxygen out of the house. And we've shown that doing this in a structured and properly protocol-driven pathway, you do reduce the duration of home oxygen therapy. So before I set up the study, the BPD pathway in Nottingham, so that's 2004 to 2006. And then we gave a 1-year break, and then we looked at data when the pathway was well established. And we've shown that you reduce the duration of home oxygen therapy very significantly, from 15 months to 5 months. And this is typically a pass and a fail study. So on my left-hand side, you can see that this baby in the previous flow rate is not meeting the targets. The average is only 91, and then they're spending a significant time below 90%. So that's a failed study. So we wouldn't go down in the oxygen flow rate, and that's a pass study. It's a really good study, meeting all the numbers. So we would reduce the flow rate. And this is the duration of home oxygen therapy in our cohort. So I think if you exclude the first outlier, then you can see that over time, we get roughly sort of a baby referred to my service once every 10 days. So you get about 30, 32 babies per year. And then that's the duration of home oxygen therapy. And I'll come back to the change we made in 2014, but you can see that consistently it's now about sort of 119 days as an overall cohort time. When I go and talk to parents and they ask me how long my baby is going to be oxygen, I use this data to inform them. So what happened in 2014-15? We looked at weight-based weaning. So I think we determined that once the babies got to about 5 kilos, then we wouldn't sort of do the daytime air study. We would just do a nighttime air study. And if they're meeting the targets, we take them off oxygen. And I think that works in the vast majority of the babies. So this is my overall cohort. And you can see that before we introduced the pathway, there were 174 babies in that group, and the duration was 156 days. And since we changed that to weight-based weaning, which we have presented at national and international meetings, and there are now 227 babies in the newer pathway, and the duration of home oxygen therapy is 96 days. And if you break that down of the 227, 5 times as many babies are likely to succeed with the new pathway. So there are still some babies who will require the slow daytime weaning, but in a vast majority are able to come up straight from point 1. You can wean them off.
Dr. Bhatt, timing reminder, 2 minutes, please.
Yeah, slides, yeah. So this was has also been confirmed by the randomized control study in America, which they looked at the similar targets as we've got, and you can see that the duration of home oxygen therapies is very comparable to what we have shown. And the final slide to show that, why supervised structured monitoring and weaning is important, because if you don't do that, then the likelihood of pulmonary hypertension is also almost twice as much, as was shown in this American study, that unsupervised weaning is more likely to lead to raised pulmonary artery pressures. I think I would recommend this ERS monograph that we've put together with a lot of good 26 chapters on respiratory diseases in the newborn, available from the ERS website. And I'll be happy to take any questions once we go into the panel discussion.
Thank you so much, Dr. Jayesh. That was very comprehensive. So we'll take the questions in the end. I'll just finish the talk. I'll be very quick on chronic cough. Let's see. Is it in the slide mode? Can you guys see? Okay. So I'm going to present a case where a child has been coughing for the last 8 years. So this is a 9-year-old child whom I have seen in clinic. He was born in India. They were first-degree cousins. He has 3 siblings. He had the first significant chest infection that needed hospitalization when he was 2 years old. And since then, he has had like several hospital admissions with pneumonia. So like various hospitals in Dubai, seen by them, various courses of antibiotics, sometimes IV, sometimes oral. Along with this, his other problems were severe failure to thrive. So when I'd seen him, his weight was 14 kilos. He's a 9-year-old boy. He has significant dysphagia. He was crying in clinic as if he had a lot of pain over there. And along with that, he had intermittent diarrhea. He was been up to date with immunization, no allergies, no pets, no smokers. So he has had some basic investigations that had shown some leukocytosis, mild eosinophilia, and hypochromic anemia. So someone coming to respiratory clinic with failure to thrive, recurrent pneumonias, intermittent diarrhea, you always think about bronchiectasis and cystic fibrosis. So he has had other investigations done, and some of the investigations we have listed over here. So this was the X-ray on the right side. You can see significant changes, very, very diffuse, a lot of mnemonic patches as well, looks like consolidation, but these were chronic changes. And I've just put another image of CT scan of the coinciding with the X-ray, and you can see significant bronchial dilation, significant bronchiectasis on the images. We had done some pancreatic enzymes, and it was on the lower side, 135 microgram, reference being more than 200 for our lab. And he has had a bronchoscopy done, which showed his TB on BAL, bronchoalveolar lavage, was negative. And he also had a barium swallow done because of his dysphagia, and that showed a cylindrical shadowing on the esophagus, and there was kind of some dilatation as well. He had basic immune functions done that showed normal CD4 and CD8 counts, but a low natural killer cells. I would have asked questions over here, but in interest of time, I will just keep on moving. So he had another CT scan done, and we did a repeat bronchoscopy. And on the left-hand side, you can see on the CT scan that the left main bronchus looks very obstructed, and in the further distally, the lower lobe is completely obliterated as well. So on bronchoscopy, we can see that it's full of pus, the left side. Then when we go further down, there is a vascular mass sitting over there. Now, we didn't do any biopsy over here because there was a risk of bleeding, and we didn't do it because we didn't have a vascular surgeon on board at that time. So what were the other investigation that we did? So on endoscopy, the first endoscopy, there was concern about Zenker's diverticulum. Then he had another endoscopy joined with my bronchoscopy, and he had some biopsy taken, which was consistent with severe inflammatory bowel disease. His repeat sweat test was normal, so this wasn't cystic fibrosis. We had another bronchoalveolar lavage that grew Streptococcus, Haemophilus, and Epstein-Barr virus. And repeat CT scan we have shown you. So along with this, genetic tests were done, and genetic tests were primarily to look for, is there any immune deficiency that we are looking for in terms of recurrent chest infections and failure to thrive. And guess what? We did have a positive result on the whole exome sequencing, and he came back as a homozygous for CARMEL2 mutation. And I must say, I had no idea about what CARMEL2 mutation is, and we had to read about it. But it is a primary immune deficiency where you do see a lot of chest infections, like presenting like similar to SCID, but not exactly severe combined immune deficiency. So how is he doing now? He has gained weight. We have managed him with different kind of milk, high calories milk. He has a gastrostomy. His bronchiectasis is under control, and he's awaiting stem cell transplant as a definitive treatment for his primary immune deficiency. So just wanted to highlight how would we approach a chronic cough in children. So I have 3 slides on that, and this particular slide is highlighting just a different, whether it's a dry cough or a wet cough. That's my first question that I ask. So by definition, in children, chronic cough is there for more than 4 weeks. It used to be 8 weeks, and that criteria has been reduced to 4 weeks now. If it is more than 4 weeks, it is chronic cough. I first ask whether it's a wet cough or a dry cough. If it is a dry cough, is there any wheeze or not? If it is a wet cough, can they be productive? Can they give us any sputum sample? And is the child looking absolutely normal to you? There are no chronic stigmata, no other markers. Then could this be protracted bacterial bronchitis in under 5 years of age? A normal, healthy looking child who's running around, but at the night time has chronic wet cough. And that's a very, very important criteria. Normal child, wet cough. No possible findings on the X-ray. So this is the work done by Ahmed Khantar, who has given a workup for how we will approach for protracted bacterial bronchitis. And if there are no specific pointers, we will do a trial of treatment for protracted bacterial bronchitis. Now, there are some work going on in terms of duration of antibiotics, but normal duration of antibiotics would be 2 to 4 weeks of antibiotics. And that's my approach if they have not been given. So many times parents will say that they had antibiotics for 3 days of azithromycin or 5 days of amoxicillin or comoxiclav, and they did see a response. They have been, but parents can't point out, was it the nebulization that made them better? Was it the antibiotic made them better? Or was it the steroid that made better? But what we are looking for in a normal, well, healthy child, no other pointers, a wet cough under 5 years of age, and that could be protracted bacterial bronchitis. But if you do point any specific pointers, child is not thriving, they have other stigmata, then you will base your treatment and you will go further to look for other diagnosis, alternative diagnosis. So what I'm trying to say here, that if the child is looking well, you're not too sure, you think it could be PBB, do a trial of longer course of antibiotics. This is a busy slide, but this is what a simplified assessment is, and it's old as well, but it still is completely valid in terms of how we are looking for. If there is VZ episode, this could be asthma. If they have other signs of atopy, if the child has typical allergic salute, and in the clinic they are clearing your throat, and you have a quick look inside their nose, and you see that there is inferior nasal turbinates are swollen or there's a polyp, do a trial of nasal steroids with postnasal drip allergic rhinitis. Wet cough is the cough that I am worried about. As a pediatric pulmonologist, they are worried about if it is ongoing, because that's what it could suggest. Something more significant, sinister, bronchiectasis, which could be cystic fibrosis, primary ciliary dyskinesia, or anything more nasty. And just rule out that there is no recurrent aspiration if there is any ongoing history with choking with feeds. There could be significant, sometimes children will come and they have a typical brassy cough suggestive of tracheobronchomalacia. I still see every month at least 1 or 2 psychogenic cough, where when the child sleeps, there is no cough there. And then there are rarer diseases like interstitial lung disease. So last 2 slides, from your perspective, what are the red flags? If there is a neonatal onset of cough, I want to see them. That's not normal for a child to cough, because that could suggest pulmonary aspiration or a problem with ciliary function like PCD, or there could be some underlying congenital lung problem, a cyst, tracheobronchomalacia, or they might be born with some kind of infection. And if they remain hypoxic, this could suggest interstitial lung disease. Second red flag sign, if it is still a moist, purulent, they can't bring out the phlegm, but you know when they are coughing in your clinic and they keep coming back to you, it's still the wet cough. They have a partial response with antibiotics, but they come back to you again. I want to see them, because we want to diagnose bronchiectasis early. By definition, bronchiectasis is a permanent airway dilatation, but now we're revising that definition. If you diagnose them early, if you treat them early, it is still reversible. So we want to see them. If there is any signs of foreign body, because I still see, recently we had a child airlifted from Kazakhstan. Parents kept saying child has choked, child had choked. They were referred to us after 3 months when he had a significant left lower lobe collapse, and we managed to remove 3 nuts from that child after 3 months. And obviously, if there are any chronic stigmatas, then we would like to see them. Thank you. Right, I think Dr. Fatima is there. Dr. Fatima, you want to take over the session? Thank you.
Yes, I'm here. A good afternoon, everyone. I'm very pleased to see you all. My dear friend, Dr. Jai is very pleased to see you. Omi and Rizwan, of course. A very nice talk, all of you. Excellent slides. Squeezed, I know, but I hope the audience had the benefit of that. We have some question shared on the side. And we have other questions as well. The first question is to Dr. Rizwana. At what stage should we refer to ENT for adenotonsillectomy?
Hi, Dr. Fatma. There are 2 questions. Hi, if you don't mind, I can combine them.
Yes.
So one is, when do you refer a child for adenoid tonsillectomy? And then there is from Meshram, thank you for the lecture. My son has adenoidectomy done, but still he has mouth breathing and snoring sometimes with persistent nose block. So for the adenoidectomy, I try with the medical treatment, which is intranasal corticosteroids and montelukast, because it's very strongly affiliated with allergic rhinitis, like seasonal allergies. So rather than referring the child directly straight away for a surgery, I try the medical management. That's number 1. Number 2, for younger kids under 3 years of age, especially, if you want to even refer for an adenoidectomy, I would do a sleep study prior to referring the child to know the degree of obstructive sleep apnea. Because if the child is significantly obstructive, then even after the surgery, you would need CPAP. Or you would need CPAP to stabilize the child and then to do the surgery. So that's number 2. Number 3 is, even after adenoidectomy, as I already said, adenoids can regrow. So it's not unusual to have persistent obstructive symptoms few months or few years after the adenoidectomy surgery. And again, as I said, it's strongly affiliated with allergic rhinitis. So if you have symptoms of runny nose, sneezing, itchy nose, itchy eyes, doing an allergy skin prick allergy testing, or like, treating allergies with intranasal corticosteroids and oral antihistamine is also a good idea. And of course, avoiding the triggers is the best thing to do. I hope that answers the question.
Thank you so much, Dr. Zuana. Very clear. I hope you're not the one driving, yeah? Okay, the next question is to Dr. Omi. What should be prolonged antibiotic cover for chronic cough?
As I said, the evidence is lacking, and there are some studies going on in UK looking at that particular question. But the consensus is 2 to 4 weeks. My practice is if they haven't been given a 2-week, 10-day to 2-week course, I will give them first 2 weeks and then call them back, review in 2 weeks' time. If there is any element of moist cough still there, you can hear the, the bulgum, what we call over here, then I would give a further 2-week course. But I might do a chest X-ray at that stage. I might do some basic blood investigation at that stage. So 2 to 4 weeks.
I think we should investigate the chronic cough first to know the reason. And if it is protracted bronchitis, for example, then we need a prolonged course of antibiotic. I think they have thought of protracted bacterial bronchitis. So chronic cough, you should investigate and solve the problem, or you should know the reason and solve the problem. If you end up by protracted diagnosis, then antibiotic course is 4 to 6 weeks. Next question is to Dr. Jayesh. Why, after so many decades, I think you can see the question, Dr. Jayesh, yeah? Have we failed to understand the whole cause of bronchopulmonary dysplasia? It's more presence of air instead of amniotic fluid inside the fetal lungs that hampers development of alveoli and epithelia and makes them dysplastic. I understand there is no alternative, but maybe some tracheal medication like surfactant therapy will help alveolar and epithelial development. Thank you for the session, Dr. Bhatt. Just thought, please share your opinion.
The first thing to say that I've just in the chat put some handouts. So I think if people wanted to look at some of the references which I presented, then you can look at the chat. Thanks, Dr. Rane, for your question. I think the cause of bronchopulmonary dysplasia at a very basic level is prematurity. If you stop prematurity, you won't get BPD. So I think that the problem is that the developing immature lungs, which are not ready to breathe on their own, get hammered by all the things we do to the baby to keep them alive, and the cost you pay is the bronchopulmonary dysplasia. Now, your question about preventing it by intratracheal surfactant and budesonide. So I think there are a couple of studies at least which have looked at airway administration of corticosteroids, and the jury is still out. I think it's not yet proven to reduce the likelihood of significant bronchopulmonary dysplasia. My talk was focusing on a child who already has got a diagnosis, and I suppose we can be here all day talking about preventing the development as opposed to doing something when the child's already got that. I hope that answers the question.
Oh yes, it does. I think we have a couple of minutes more to have some more questions. Dr. Zuana, can we do, or what are the long-term harm effects of untreated OSA in children?
Sorry, long-term harms of untreated obstructive sleep apnea, you mean?
Yeah.
Yeah. So we discussed a little bit during the talk, but long-term untreated obstructive sleep apnea has a lot of short-term and long-term consequences, and this includes mainly cardiovascular consequences like pulmonary hypertension, right-sided heart failure, metabolic consequences, which includes poor control of diabetes if there is an underlying sugar issues. In children, they're also responsible for cognitive decline, impairment of memory, intelligence, hyperactivity, and dropping in school grades. And most important than not is failure to thrive is also often linked with poorly treated obstructive sleep apnea or untreated obstructive sleep apnea, because it causes decreased oxygenation on a long-term basis, and that can lead to failure to thrive as well. Thank you.
Thank you, Dr. Rizwana. Last question to Dr. Omi. I think this question would a pediatrician love it. Does Tamiflu help in all influenza?
Right. So it definitely, if you have given the right time, if you have given in the first 36 hours of diagnosis of influenza, then it reduces the severity and the duration of illness. It's a viral illness. If you have normal immunity, you should be able to fight within 5 to 7 days. But there is evidence, and the evidence has been there for the last 20 years. If you give it on time, it will reduce the severity, the fever duration will reduce, and also the secondary complication that we see. This year, we have seen already, we have had 7, 8 empyema, and all of them, they started with influenza, and then they develop secondary complication and secondary bacterial infection. So that is a possibility of reducing the comorbidities and secondary bacterial infection. Dr. Sohrab, you wanted to ask?
I want to ask a question, which is a question of many pediatricians. If I ask you, all panelists, what is the best cough syrup people parents ask you? What do you say?
Can you say that again, Dr.
What is the best cough syrup?
These days, I have a good answer that we have seen Gambia children dying with cough syrups.
Yes.
They get very convinced very easily.
No, Dr. Omi, you are right. I mean, suppose irritant cough child has come 9 years old. Of course, a small child, we don't want to give this. Suppose a 10-year child has come to your clinic, you're having a private clinic, and all 60 patients per day, you cannot refuse all of them to go home. So if the parents ask you, what is the best cough syrup I want to give to my 9-year child, which is coughing irritant cough, well, what do you advise?
Time is the best cough syrup. I think if you have ruled out any other problems, then the cough will go on its own. If it's not a habit cough, as Dr. Omi mentioned, if there's no other underlying chronic diagnosis for the dry or the wet cough, give them time. You know, that you got to reassure. I think there is more harm caused by cough syrups than good.
Yes.
I just say home remedies. If it is a dry, irritant cough that you're talking about, I say, see, we practice evidence-based medicine. There isn't any evidence of these cough syrups because most of the cough syrups might have some suppression where they will help you to fall asleep rather than treating the cough. But yes, I don't say that you can take honey, you can take ginger, you can do steam inhalation for congestion, but that will last for a few days and then it will go away because you're absolutely right. They asked me the same question that my child is not sleeping. They are awake, I'm awake. But that phase lasts for 2 to 3 days and then it gets better.
Now the time is over. Dr. Amir is not there. It is a season for respiratory problem, but unfortunately we can't. I mean, we are already over time. I would like to thank Dr. Jayesh, Dr. Fatima, Dr. Omi, Dr. Rizwana for the excellent presentation and discussions. Hope we had time to continue. So I end the session here by thanking you once again and move to the next session. Thank you very much.
Thank you, Dr. Sohrab, for having us. Good to see you, Dr. Jayesh. And thank you for your time from UK. Dr. Omi and Dr. Rizwana, thank you all so much.
Thank you all. Thank you.
Dr. Kalpana, would you please introduce the chairperson of the next session, Dr. Leila Al-Bahri? Good afternoon, good day, Dr. Nail.
You are on mute, Dr. Kalpana.
Dr. Kalpana, mute.
Sorry. So, good afternoon,
everybody.
It's my pleasure now to introduce Dr. Laila Al-Bahri. Dr. Laila is a very senior pediatrician working in Dubai, and she is our executive committee member as well. Dr. Laila is going to chair the next session. Over to you, Dr. Laila.
Yeah, hi, good afternoon, our colleagues, our audience. It is my honor to produce our famous moderator. I know everybody knows him, Dr. Islam Al-Baroudi, consultant pediatrician in Sheikh Khalifa Medical City, Abu Dhabi. Welcome, Dr. Islam. The floor is yours.
Good afternoon, everybody. I'd like to thank you for your introduction. I'd like to thank Dr. Sohrab, Dr. Kalvana for the invitation, and Dubai Pediatric Club for performing this superb scientific meeting. And so I'd like to say happy National Day in advance for the UAE, that all of us we're gonna celebrate the 2nd of December. Today we'll in our nutrition module, for those who are they're hearing us now and they're watching us now, we're gonna talk about the so we have chosen the immunity, all the pillars of the immunity, and what is influencing our immunity, especially for our childhood. As Dr. Sohrab was talking about, that this is the season now for the respiratory infection. So we need to know what could boost our immunity. So to start with, just let me share the screen. So could you see my presentation?
Click
So
on it. Yes, we can see it, but click on it.
So is it okay now?
No, doctor.
Is it coming now?
Yes, yes.
Okay, so I will be just talking about the pediatric immunity. So just to start with, this is the causes of the death in children, those who are below 5 years. It is estimated to be about more than 8 million per year. For the newborn, it is about 41%, and for the children is 59%. And the most common cause for the death below 5 years is infection. And you can imagine that the percentage of the infection in the newborn, that it is more than 50%. It is the sepsis, and it is the pneumonia and the neonatal diarrhea. In the children, also it is the same. Diarrhea, pneumonia, and other infection is more than 60%. So infection is the main cause of death for those who are below 5 years. It is really, by the WHO, is a red flag. And just keep in your mind that immunity and infection, it is the two flips of the same coin. So talking about infection, it does mean that we are talking about immunity, or we should be keen about the immunity. What's the immunity types? Just for a refreshment. So the immunity that what we are having in our body, it is the adaptive immunity. So adaptive immunity, this is the acquired one. So we have either the natural immunity, the passive one that you are getting from your mother at the time of birth, or the active one, which is you are getting by the infection. Or artificially, you will be having the immunity passively if I'm giving you some antibodies, like the same as we are doing in the IVIG or the immunoglobulin. Or you can get it actively by the immunization, which is very crucial, and this is very important, and we will talk about it. The other type of the immunity, not other than the acquired immunity, is the innate immunity, or what we call it the natural immunity. And this is our surfaces that we are having, the anatomical barrier, the skin and the mucous membrane. Physiologically is your pH and the temperature. The phagocytic barrier, or the action of our immune system, the cells, or the inflammatory response that we are having, redness, swelling, heat, and pain. So the innate immunity is the first line of the protection. It is an immediate response, but the problem with the innate immunity is that it is non-specific and has no memory. And this is an example for our innate immunity cells. So it is the natural killers that we are having, or the dendritic cells. The adaptive immunity, it develops in response of the pathogens, but it is a bit slow, But with time, it is becoming more faster, but it is more specific and it creates immunity. And an example for that is the B cells and the T cells. So the analogy for your innate immunity is the same as if that you are having the castle. So something that it is defending you, while your adaptive immunity is the soldiers in the battle that you are doing with the infection. Both of them, they are complementing each other. Just this is the evolution that what is happening and why we are talking about the immunity in early infancy, because at the time of birth, our immunity is mainly derived from the maternal IgG, but it is declining with time. Simultaneously, you are developing, or the infant or the kid is developing his immunity, and that's why you need to support his development of his immunity. So he is developing his immunoglobulin or the IgG. So there is a gap that we call it the protection gap. And this protection gap, that this is, you are not having like a lower immunity, but it is in the low normal level of your immunity. And the evidence for that, you are having more otitis media, more diarrheal episodes at that time of infancy. Just to understand the immunity and what is happening. So for each organ that we are having, that there is a mucosa, and each mucosa is associated with a lymphoid tissue, and this is what we call it the mucosa associated lymphoid tissue, or the MALT. In our GI, there is about 70 to 80% of all your lymphoid tissue found in our GI. And what's the importance that we are talking about that? So under the effect of the nutrition, under the effect of the microbiota with its intrinsic signals or extrinsic signals, then this naive cell that we are having, or the T0 cells, it is differentiated to a different type of immunity cells, that they are playing a crucial role in the development of our immunity. The T helper 1, which is responsible for the immunity, T helper 2 for the allergy, then the T helper 17 and the T regulatory cell, which is making the balance between the immunity and the allergy. Don't forget that this differentiation, it is not only for the lymphoid tissue and because of the nutrition, but also under genetic effect. There is the STAT gene, STAT 3, 4, 5, and 6 is responsible for the differentiation of this naive cells. This is what, in confrontation with either an antigen or an allergen. So this would lead us to the definition of the immunity. So it is the normal ability to recognize dangerous and harmless, both antigen or allergens, and acting accordingly. But what's the condition? Preserving the integrity of the intestinal mucosa. So this is what we call it tolerance if you are talking about allergen, or this is called the defense, the defense that if you are talking about an antigen. So this is called the immunity, and this is the key feature of our immunity. If there is an abnormal reaction, that this reaction is becoming abnormal, means that it is exaggerated, then at that time this is called allergy or inflammation, and there is a fragile balance between the immunity and the allergy. So that's why we need our immune system that to be what? Very important, something for our immunity, that to be resilient. Means what? Resilience. Resilience in Arabic means al-muruna. In English, it is called the flexibility. Definitely, it is not this flexibility, but I'm talking about the resilient, that this is an inbuilt capacity of our immune system, so it can adapt the challenges of establishing, maintaining, and regulating an appropriate immune response. Appropriate. Appropriate means what? That it is right response in a right time, in a right way. The same as is happening in the fireworks. If any of them is missed, then at that time you will not have a proper firework. Or in our immune system, we have seen that in the corona, that when your immune system is exaggerating its response, then we have what we call it the cytokine storm. What is needed to ensure that you are having a resilient immune system so it can fit to whatever reaction? The factors that it is affecting the immune system, 20% is your genetic predisposition, that it is in your hand. Is it your destiny or not? We'll see. 80% is the environmental factor, including what? Including the nutrition, including the microbiota, and the vaccination. So these are the other three factors. So the genetic factors and these three factors, it is called the pediatric immunity musketeers. It is the genetics, it is the nutrition, the the microbiota, and definitely the vaccination. This is Sheikh Khalifa Medical City where I'm working, and this is Faculty of Medicine, Cairo University, and this is the International Pediatric Summit that we would love to see all of you in 17th to 19th of March, inshallah, in Dubai. Talking about the nutrition, Dr. Wafa today will be talking in details about the nutrition, just to let you know that there is a rapid growth and development during this period of time. And at that time, you need a specific nutritional requirement. And it is very crucial as a healthcare professional to tell them for having an access to an optimal nutrition. Optimal nutrition is very important, and always remember that the right start equals a bright future, especially in the immunity. The other one is the microbiota. All of us, we know the microbiota, and 95% of our bacterial microbiota is found in the GI, and we have, for each human cell, we have you have a 10 microbial or microbiota cells. You have more than 100 trillion organisms, and that's why they said it is about 10% only of us is human cells, while the other is microbiota. Talking about the microbiota, it is very important that regarding the microbiota to have a balance between the good bacteria, like the E. coli, the bifidobacteria, the lactobacilli, with the bad bacteria, such as the Enterococcal faecalis or the C. diff. So the increasing of the good bacteria is called symbiosis. This is a symbiosis diversity other than the dysbiosis diverse if the bad bacteria is there. Why is that important? Because symbiosis is responsible for a normal immune system and to have more regulatory cells and more immunoglobulin A, which is responsible for the surface mucosa. While having a bad bacteria or dysbiosis, so it would lead to an immune disorder, pathological autoimmune diseases, and metabolic disorders. And this is the publication showing that microbiota is playing an intrinsic regulator. It is an internal regulator for all our immune responses. That's why we need to take care of our microbiota. Many strategies to manipulate our gut microbiota. The mode of the delivery is very important. The mode of feeding is very important. The mode of the nutrition is affecting the microbiota, and definitely other environmental factors like the antibiotic is taking, then something it is in hands of the physician, or even in the market, the probiotic, the prebiotic, and the postbiotic, all of them could affect our microbiota. So microbiota, then vaccination. Vaccination is another pillar for our immunity, and it is very important to talk about the vaccination. It is not me, it is the CDC that it is saying that one-time vaccination throughout childhood is essential, and it helps to provide the immunity before they are exposed to a potentially life-threatening disease. But of course, for any vaccine, supposed to be tested to ensure that it is safe and it is effective to be received. And that's why keep it in your mind what was happening for the corona vaccines. Again, the UNICEF also is saying that vaccines will help to protect your child against diseases that can cause serious or harm or death. And this is when for the developing immune system, especially the infants. That's why it is very important also to clear any unclear message or a mysterious message, sometimes that it is delivered to the parents, that there is any relation between the vaccination and some intellectual diseases. Genetics and immunity, again, a conclusion is saying that the host genetics factors are, yes, they are important, and also they will determine the responses to vaccination, but not your genes are solely affecting your immunity responses. But there is an association between your genes and the specific responses with the environmental factor that we were talking about, the vaccination, the nutrition, and even that your genetics. This is what we call it the epigenetics. You will ask me, what do you mean by that, and how it could affect our genetics or our immunity? So whatever that you are doing by the nutrition, it is accumulated in the DNA, and this could put off your gene out of functioning. So that's why we are saying that the epigenetics or our gene is the same as the hardware, the same as your computer. So your computer, you can put it on or you can put it off through programs. You have the computer, you are not changing your computer, but you are putting it off by some programs. These programs are built in your DNA during your infancy, through the nutrition, through the vaccination. So there is some methylation of our DNA that it may put off our gene. This is what we call it the epigenetics. So it is modifying of the gene function, not the gene structure. Should we be concerned about that, or about the immunity, or that it is very important? Yes, for two reasons. So the childhood infection that it may develop frequently, even that he is not diagnosed as that he is having a primary immune deficiency, but this is a study for a monozygotic twins. So one of them is having more infection than the other. So now that you are having a unified genetic predisposition, but one is having another environmental factor. The environmental factor is different between both of them. So those that the one she was having more infection, so what happened to her? She were shorter. So the number of the infection exposure when she is having 38 other than 11 exposed, the other twin, she were taller. So the immunity would affect a physical, that there is a physical impact on that kid. The other thing is the cognitive development and the brain function. So, and again, in this study, that for every unit increase in the recorded illness, so that they are putting, like, if you're having like 10 times that this is 1 unit, any increase in 1 unit of the illness is decreasing the childhood development. In the scores, there is a scores called the PSID3. It is your cognitive development is reduced by 0.22 scores. So this is affecting your functional development of the brain. So that's why we need to be concerned regarding our immunity physically and mentally. The conclusion that still that we can boost our immunity and elevate it from a susceptible infection to be a resistant and to acquire a tolerance or a resilient. As we said, this is definitely by optimal nutrition and symbiosis, and definitely your genetics is not your destiny. And my message that a healthy outside start from inside. That's why we need to take care of the kids' immunity. This is that you can follow me, and thank you. This is the pillars of our immunity, and we'll go for more specification and more explanation by my colleagues. Thank you. So now we'll be having Dr. Wafa Al-Aish, and Dr. Wafa, she is a consultant clinical dietitian at Tadawi General Hospital, Dubai, UAE, and our beloved Dr. Wafa, she is an expert in nutrition and dietitian in pediatrics, and definitely also for the adult, and a famous media star. So Dr. Wafa, the floor is yours, talking about the nutrition and its effect on the immunity. Please.
Thank you, doctor. I will just share my slides, if you allow me. I have to, yeah. Okay. Can you see it?
Yes.
Okay. Good afternoon. I'd like to thank the Pediatric Club, Dr. Sarhab, Dr. Kalban, and all Tawfiq, and all the people who have invited me to be here with you, and for yourself, Dr. Islam. It was an amazing lecture that helped the flow for me to start my talk. I'm going to talk about briefly in very few about nutrition and pediatric immunity by answering some questions. How does diet affect a child's immune system? Does it? Well, yes. All the studies have proven that poor diet leads to malnutrition, or the diet which lacks any kind of nutrients, one or more, can really impair the production and the activity of the immune cells and the antibodies. That's why we have to go for having a healthy food for the kids. Plan it through the breakfast, which is the king. Say no to any kind of food which is high in calorie with saturated fats. Keep them hydrated. Make sure that they are having a good, healthy, balanced diet. As well as another thing can affect the immune system, which is the chronic diseases, the autoimmune and the immunodeficiency disorders, which attack and potentially disable the immune cells. So what are the causes for the low immunity in children? Child immune system, we saw and hear Dr. Islam, which have spoken about the microbiota, have spoken about the vaccines, he's spoken about a lot of things. Nutrition is one of the pillars that he has spoken about that really helps. And when the child immune system can be temporarily weakened by certain either drugs they are taking or chemotherapy or cancer treatment or any transplant or any kind of infection like flu, viruses, pneumococcosis or measles, which can weaken the immune system for a brief time. So key indication for low immunity, we see that the child have a frequent cold or cough, they have infection frequently, they delayed in healing of wound, they are underweight, they have a kind of nutrition deficiencies. So we have to assure that we're doing the tests that are needed for their children to help and enroll if there's any kind of things that affect the immunity of the children. So how does nutrition helps or what are the symptoms that shows that they have low immunity? There are signs and symptoms which are primarily indicated, like frequent recurrent pneumonia, bronchitis, sinuses, meningitis, or any kind of skin infection, inflammation, which are and infection of any kind of internal organs, or if they have a blood disorder such as a low platelets count or anemia. So infection leads to lose appetite, which reduce the nutrient intake, and this is we see it with most of the children. The first thing they stop eating. They have low appetite, so we have to increase their appetite. That infection and that less of appetite, leads to do what? They decrease their weight. They are undernutrition, which decreases the ability of healing and recovery when they are undernutrition, which goes to what? A low immunity, which reduce the external barrier and protection, weaken their defense mechanism. So it started all of about having a good, healthy eating to boost the immunity, started by defending this loss of appetite. So what does or how does the nutrition affect immunity? It can be affected by, as I said, by the microbiome, and Dr. Islam has spoken, the gut barrier function, the inflammatory process, and the white blood cells function, all impact the immune function. So the dietary pattern and the individual food have associated with increased risk and greater risk of allergy, impact immune response. We have certain, let's say, soldiers, which are micronutrients, those nutrients that are really helps in the immune system, such as folate, B9, which are found usually in the dark leafy vegetables, beans, wheat germs, yeast, peanuts, oranges, strawberries, boost the immune. We have to pay attention to it, and when we have a less appetite, we have to make sure that they are having these kind of food. Zinc, very important, and I'm telling you about this because zinc was one of the most important minerals that we had used during COVID, treating our patients when they have COVID and they are under our observation. Beside the food, we give them as a supplementation, iron as well, because which is found in red meats, in shellfish, in poultry, in whole grains. and green leafy vegetables, but we add to it vitamin C to make the absorption, especially when we are vegetarian. Add vitamin C to make the gate for iron, as well as folate or vitamin B's to be absorbed, especially B12. Copper as well, we have to pay attention to it, as well as selenium. Now, how long does it take for a child to build immunity? It takes around 8 years old. Until 8 years old, from the beginning, from actually from while in her pregnancy, and we will see, till the 1,000 days are the very important, and they start building up till 8 years. Until then, it can feel as though they catch every cough, cold, and infection they encounter. That's why they're immune, because it's building up to 8 years. It starts building the immunity. It takes 8 years. So that's why they might have recurrent influenza, or a recurrent cough, or recurrent attacks. That's why we have to make sure that we are giving them the support by good nutrition to throughout, from the day they birth till 8 years, to have a very good immunity and improve it. So what helps those children to develop a strong immunity? First, boosting their immunity, we have to make sure that they are having a good, healthy diet. And the healthy diet starts the day with a good breakfast, which boosts their energy, increase their fruits and vegetables that help them to grow, because, as I said, they have the micronutrients that really helps them. Avoid any kind of processed food, because first of all, it is saturated, hydrogenated fats that really attack the immune system by itself. Choose a very healthy fats like olive oil, nuts, which have DHA, we have EPAs, which have the omega-3s, omega-6, omega-9, that really help to boost their brain and their intelligence, as well as their immunity. And definitely we make sure to reduce all kinds of sugars and salts that they are having, because it really backfire on them. Make sure they have a good sleep, make sure they are very active, manage their stress when they are teething, when they don't have a good appetite. Make sure that you are supporting them at that age when they are weak. Make sure that they take up the vaccines, and we saw what Dr. Islam have spoken about. And of course, we have to take all the precautions when we are giving them a good meal or a good health care to boost their immune system. And diet can really boost the immune system and a good diet can really help them. But we have to make sure that to maintain the functional immune system by avoiding any kind of immune deficiency nutrients that can lead to malnutrition, or any kind of deficiency of any kind of nutrients. It's very important to know that no single food nutrient will prevent illnesses, but they can support you to have more complications and fast healing. So get enough sleep, teach them a good personal hygiene, make sure they have good fruits and vegetables, give them the medication or the supplements that they need, like vitamin D, the iron. Assure that you are testing them, you are giving them their vaccine, keep them away from any kind of pollute as much as they can. Exercise outdoors, especially now the weather is becoming better. Breastfeed for, of course, children who are younger, and make sure that they are having their good monitoring. By summary, we have two things to immune system development risk for non-communicable diseases, especially in the first 1,000 days. All these are the very important time where we build our children. In the maternal nutrition, we give them for the mother, the bearing mother, the adequate calorie intake, support the placenta growth, the blood flow, enable transfer of antibodies, nutrients to the fetus. So I'm building a good baby. After that, the nutrition during breastfeeding, and Dr. Sam also highlighted this. When we talk about nutrition breastfeeding, we have to make sure that the feedback loop of the microbial exchange between the mother and the offspring enhance the innate immunity of infancy, and he spoke about it as well. Human milk, oligosaccharides, the first let's say immune mechanism that help to protect the infant gut mucosa and immunoglobulin of the breast milk, which is direct transferred the IgA and the IgG and the IgM to the infants and enhance their immunity. After that, start eating, start monitoring their diet till, as I said, 8 years, the immunity system will be built up. So I make sure that they have enough intake of vegetables, fruits, and which decrease the risk of the non-communicable diseases, the asthma attacks, and all those viruses. Meanwhile, increased risk if I don't have a proper microbiota, if I don't breastfeed my baby or give them the proper formula that they are having, if I don't look into their nutrition for the first 1,000 days and monitor their vitamin B12, their vitamin D, their zinc, their deficiencies, all this impair their immune system and reduce the ability of the body to respond to all the viruses or all when they are weak while teething, for example, or when start walking, they need more energy, more good intake. If they don't have it, then they don't have proper nutrition, their immunity system will be sacrificed and they will have a recurrent attack of diseases. By that, I end my talk and I hope I get it by time. Thank you.
Thank you, Dr. Wafa, for the elegant talk, brilliant as usual. And now we'll move for our third talk for today with Dr. Fiji Anthony, and she is the Chief Clinical Dietitian at NMC Specialty Hospital, Dubai, UAE, and she will be talking about the effect of the iron as part of the nutrition on our immune system. So, yeah, Dr. Fiji, the floor is yours. If you can share your...
Thank you, Dr. Islam. Let me just share my slides. Are you able to see?
Still not yet.
What about now?
No.
Okay. It's not coming in my screen.
Maybe Mr. Tawfiq, you have it. Can you share?
Iron, Dr. Kalpana. I have shared with you.
No, I'm asking Mr. Tawfiq if he could share that.
Okay.
No, I don't have a presentation. So until she gets it, I think Dr. Neil can do it.
It was sent to you, Mr. Tawfiq, by email.
If
it was
I sent it again
earlier. Now I can't see it here on my system. Okay. Meanwhile, I'll just start talking. It is about iron, so I can just talk about iron, the iron and how it can impact on the pediatric population and what is the dietitian's role, how we can improve the immunity by the intervention. The nutritional intervention has to be enhanced through the dietitians properly in such a way that it will not impair the other functions or it will affect the child growth and development. For example, if the child is coming to your OPD with obesity, it's not that you have to address only the deficit in the calories. First, you have to address whether the child is developed or having any deficiencies first. Unless and until we correct the deficiencies, we are not addressing the actual problem the child has. The same way, if the child is underweight, we are going to check the actual parameters, the lab parameters in which we have to first address the deficiencies. Now, how these deficiencies affect and what is the nutrition intervention? That is where the immunity strikes. Unless and until we correct the deficiency in a proper way. And what is the proper way? The nutritional intervention through a proper regime. Now, when it comes to the regime, well, we have to check whether there is any superfood, whether there is any magic food which can solve the deficiency at once. No, there is no any magic food which can correct the deficiency with a single ingredient. Now, what is the dietitian role? The dietitian role is to check with the parent, goes into the detailed diet recall. What is the problem with their routine? What is the problem in their eating habit? Is it only dislikes and the likes? Is it only tolerance and the intolerance? Or it is only the diarrhea or constipation? But when we come into the details, we will come to know that it is actually there is no routine. When we check even the deficiency in the nutrients or there is excess calorie intake in the obesity, both ways we have to correct the regime. The regime starts with the wake up time and the sleep time with correct intake. Now the question is that is the excess food intake from the excess calories is the reason for impairment in the nutritional efficacy from the nutrients? Means are the nutrients are a problem from the unwanted food items, the excess calorie, the calorie dense food items, which comes from the ingredients which is not nutritionally healthy. My answer will be like, you have to choose. Yes, this is the slide I'll just keep. My choice is that you don't have to go with any specific food items. First, have you checked the total intake of the child? Whether the child is having proper bowel movement, whether child has developed any specific intolerance to any ingredients, why he dislikes milk, why he doesn't take fruits, why he doesn't eat vegetables. Now, how we are going to tackle it? Please don't force them. Forcing a child for eating spinach or drumstick leaves will not solve the problem. Oral nutrition supplement will solve the problem. It may give the temporary solution. What is our permanent solution? Permanent solution is correcting the eating habit, changing the routine, inclusion of various food items into their dietary pattern in a normal way. Only the normal introduction will last forever. Like, for example, the food like the raisins and we always give these type of food items for the iron deficiency. We will give this for the constipation. But is it directly influencing for the deficiency correction? I will say that it's not only deficiency correction does, it actually does the proper bowel movement. The proper bowel movement or relieving the constipation helps us the proper intake of the food items. Now, when the child has appetite, they may end up eating more food items, which is more natural than we are forcing them for a specific food ingredients. So, for example, I usually give this prune puree and the date syrup, tamar shahad. They are very, very effective. Maybe you just have to give 1 teaspoon or 1 tablespoon in a day for the child according to their age and weight. But it relieves the constipation. Their bowel movement becomes so regular, their eating habits improves naturally. So that's how we have to intervene in their deficiency, correct their eating habit, and thus increase their immunity and getting into them more healthy and fit. Of course, the other activity levels and the intervention with all other lifestyle modifications are important. But the most important thing is that how can we change their eating habit? How can we intervene naturally, which can last forever? It's not that they will reduce 3 kilograms and then gain after 2 months 10 kilograms. There is no use. The same way they gain weight from the underweight, where the growth deficit is corrected by 2 kilograms weight, and after 2 months they're again losing weight. There is no use.
We have 2 minutes left.
Yes, I'm done. That's it. That's what my conclusion, that it is the balanced diet and the specific healthy regime which will help us. Thank you.
Thank you so much for the elegant, and we'll be talking specifically maybe at the end in the remaining 5 minutes. Now we'll be having Dr. Nell Edward, and he's the director of the American Nutrition Association. and board certified clinical nutritionist, Florida in the United States. And Dr. Nell will be talking about the effect of the vitamin D, and which is, okay, a lot of talks about vitamin D. So we will see the insights from Dr. Nell regarding the vitamin D, nutrition, and immunity. The floor is yours.
Thank you. You can see my screen okay?
Yes, it is there, clear. Go ahead.
Okay, thank you. Yeah, we're going to talk about the importance of vitamin D, of course, in pediatric nutrition. Some of my credentials, just so you see, I am a clinician in the United States. And we'll talk about vitamin D and immunity specifically. This is from a research paper about 2 years ago from Emirates and Australian researchers. And they're saying that vitamin D supplements are known to aid reducing the incidence and severity of viral infection. And especially in the upper respiratory tract, the serum vitamin D levels lower the risk of upper respiratory tract infections. And this chart kind of expands on some of the ones we saw earlier with Dr. Eslam. Very important, vitamin D gets converted from the skin or from dietary intake into forms that are used by the body. And if you look on the right in the green box, the clinical effect of this is to reduce inflammation, respiratory distress syndrome, pneumonia, infections, through these very specific mechanisms that you see in the boxes above and below that. And it moderates inflammation and the immune response to appropriate levels. This also touches on something that Dr. Eslam spoke about, the appropriate immune response and not an over-aggressive one. So according to the National Institutes of Health in the United States, vitamin D will tend to lower viral replication rates, as well as reduce inflammation and increase the T cells. The T and B cells convert vitamin D into its active form. So there's a suggestion by the government there that vitamin D can modulate both innate and adaptive immune responses, again, as Dr. Eslam described. Another ability of vitamin D is fostering differentiation of monocytes to macrophages and producing proteins that are antimicrobial, that are produced by vitamin D metabolites. These are from researchers in Pakistan and Canada. And again, some of the leading researchers on vitamin D published that the active form of vitamin D acts as an immune system modulator and preventing excessive expression of cytokines, which is the excessive inflammation, but enhancing the oxidative burst potential of macrophages. They play a major role in protecting the lung and other tissues from environmental factors, including viruses and bacterial infections. So the peptides or proteins that exist in the immune cells and are used to make an oxidative burst to destroy invasive organisms are actually enhanced by the presence of vitamin D. And just a quick refresher, some of the immune cells, both innate and adaptive immunity, and some of their functions. We're not going to go into detail here, but vitamin D affects them all 5 of these classes of cells, both for innate and adaptive immunity. And we know that vitamin D deficiency impairs localized innate immunity as well as adaptive immunity. Now, this is from our friends at Al Jalila Children's Hospital in Dubai. They tested their patients for vitamin D and they found over 39% had vitamin D deficiency, defined as less than 20 nanogram per milliliter. If you're using the other system, the nanomole per liter, that's 50 nanomole per liter. And that's actually about 2/3 of a healthy level is considered deficient. So really, we want levels above this. And the rates range from about almost 45% for the female patients. The Emiratis in general had about a 40%. The average age for vitamin D deficiency was 9 years old, but about 26% did not have symptoms of vitamin D deficiency that would be noticed if they weren't tested. By the way, the prevalence of vitamin D deficiency in South Asian people is about 70%. So it's even higher than in the Emirates. So when we're looking at the origins of people and where they are in the world and what their exposure is, the exposure to sunlight potential based on where you are geographically does not mean people are getting sufficient vitamin D produced from sunlight. And there's limited sources in the diet, as we heard earlier as well. Now, the safe upper limit for vitamin D varies by age between 25 micrograms or 1,000 IU or 75 micrograms or 3,000 IU. Now, keep in mind that this is roughly about 40% of the level that is actually considered safe because of a built-in margin of safety. So when you're seeing these numbers, these are not absolute limits. There's actually, you could more than double this and still be considered safe in most cases. And in addition, the dosing for treatment of nutritional vitamin D deficiency, it's recommended at least 400 units a day be given to children. But if you're treating a deficiency for if they're less than 1 month old, you would give 1,000 IU orally per day. If they're between 1 and 12 months old, you give between 1,000 and 5,000 units a day. And then over 12 months, you would give 5,000 units a day. The usual treatment is 2 to 3 months and then retest. So that is the basic protocol for treating vitamin D deficiency in pediatric patients. So with that, I'll turn this over to the organizers. And I do want to thank Dr. Layla, Dr. Eslam, Dr. Wafa, Dr. Fiji, Dr. Sorab, and all the folks at the Dubai Pediatric Club for inviting me to speak today. Thank you.
Thank you, Dr. Nel, and it is the S&S technique, so it is short and sweet.
Yes.
Very nice. Thank you so much. Now, just talking about the question that we are having, and maybe, okay, that I'll start with you. Regarding the vitamin D, so would you love to give it, I mean, regarding the vitamin D deficiency, now we are talking about the treatment. So would you love to give it on a daily basis, or sometimes that, okay, because of the adherence and compliance, sometimes we are giving like a higher dose, but it is per week. So, and now I think it is becoming an obsolete to give like this injection with 200,000 or 300,000 international unit, like for the fear of the intoxication or something like that. So your comment about that?
Yeah, I mean, it's fine to do the weekly one, just divide that number by 7 and see if it's in that 5,000 unit range, which would be fine. A lot of doctors will use the 50,000 units as the basis for giving that. And if you divide that, that's about a little over 7,000 units per day. So they could take that every 7 days or 8 days or whatever and get an appropriate amount. Another thing is that some hospitals in the US are actually giving new mothers a packet of things to bring home, and including formula and diapers and things like that, but also a bottle of liquid vitamin D where they can get 400 units per drop or 100 unit per drop, and they could dose the infant that way, which is another appropriate means to do it. They have to measure carefully and, you know, the right number of drops to make sure they're using safe levels.
So just again to summarize, so there's no problem that we can give, like, let us say 35 to 50,000 international unit per week. This is for the treatment. Now regarding for the prevention, So it is 400 international unit, those who are below 1 year, and it's supposed to be 600 international unit for those who are above 1 year. Now talking about just to finish this point. So regarding the prevention, till what time they supposed to get it, or you are expecting that they are getting it from their daily food intake?
Well, as Dr. Wafa and Dr. Fiji mentioned, it's important to have a dietitian or someone who knows what they're doing work on the diet and make sure they're getting this, because vitamin D is not abundant in the diet unless you're eating whole fish, unless you're eating fortified dairy products or getting sunlight. And as we saw in that hospital data, a lot of children are simply not getting enough sunlight to convert into vitamin D. They're not going out into the hot sun and exposing their skin to make it. So there are limited dietary interventions. A multivitamin is always an option, but correcting the diet first, as mentioned earlier, is important.
Thank you so much. Doctor, my question to Dr. Fiji, so regarding the iron, so what do you think? I mean, because there is like a different practices, Dr. Fiji, for the iron intake as a prevention. We are here not talking about that it is very obvious as an iron deficiency anemia, but also iron deficiency by itself, that it would affect the immunity. And definitely, of course, we are not talking today about the brain development, but it is affecting the function. So Dr. Fiji, what do you think for the physician or even for the dietitian, just like to pick up that there is an iron deficiency, and your suggestion for the treatment, especially that some in remote areas will not have a very advanced investigation?
Yes, sir. The first thing is that we have to address what is the reason for the child's consultation, whether the child is weak, child is having any attention deficit, a child is having any apathy, and is there any weight deficit or growth development retardation, or such type of
recurrent infection or something like that. So yes.
Yes. But the iron deficiency with immunity is already been clarified, but how it is affecting the infection is yet to be determined. So the intervention needs to be from the lifestyle modifications, the nutritional intake, the food intake, the activity, all these parameters needs to be considered. But now we cannot conclude with a one single dosage of an iron supplement can solve the problem. No, we cannot.
Yeah, I mean, a more important point also regarding them to give the iron during an active infection or not to give. Just for you to know, I mean, there is nothing, I mean, very clear regarding that. It is obsolete not to give, or that to forbid giving an iron while during an infection, unless that there is the inflammatory marker is showing that the iron, which is one of the inflammatory marker, that it is high. Other than that, so iron, I mean, supposed to be given if someone is having like an iron deficiency, and it has nothing to do with the inflammation or with the infection. And maybe my comment regarding that, because usually we are asked, I mean, that there is one question about it, that what is the picking investigation for the iron deficiency? Maybe we can do the ferritin or the iron saturation. But the point, sometimes in some facilities that they are having this type of investigation, but we can tell them that also if you are giving an iron and you are just monitoring the hemoglobin. So if the hemoglobin within 1 month is increasing by 1 milligram per deciliter, so if it is like 11 or something, it does mean that there was an iron deficiency, and by giving the iron that you are boosting the iron deficiency. I'm not talking about anemia, about iron deficiency. And still, then at that time, you can give a therapeutic time, which is to extend for more 2 months. So just like for simplicity, so someone is having like recurrent immune deficiency you don't have the luxury to do the test for the ferritin or for the saturation. You can give the iron and monitor the hemoglobin. Any increase by 1 milligram per deciliter, it does mean that there's an iron deficiency, and you're supposed to continue for two months. This is just
And
for
protein intake to be ensured, sir.
sure, yes. Dr. Wafa, we need like a prescription for those who are going to our kids for school. So what's supposed to be in their lunch box, or what's supposed at least to be ensured by their parents from the nutritional point of view, to make sure that their immunity is kept and is kept the same, and even that it is boosted, that
no problem. No, what they can give mainly, which is, as I said, we have to have the high fiber and high fruits and vegetables. So what you have at home from fruits and vegetables, rich in antioxidants and vitamins, the seasonal one like the orange, the bananas, which is very rich in potassium, all this you can keep with them when they are having the lunchbox. As well, yogurt, you can give that small yogurt with the fruits added to it for the children to take it to as at school. Nuts, of course, as appropriate if they don't have any kind of allergies. They can have the sandwiches, which is like the labne with za'atar and all these things that have very good with olive oil that can really boost their immunity and give them the healthy food. Definitely, it depends from culture to culture, what they have at home, what kind of food they have at home, what kind of food they like. But as a mom, I have to make sure that they are rich in fibers, rich in vitamins, rich in fruits and vegetables. They are rich in vitamin Bs, as I said, zinc. I have to variate as much as I can, especially when they are eating at home with you. Of course, the lunchbox, we all now aiming that they don't have any hydrogenated fats, no trans fats, no processed meat, no things that can harm their immunity. Opposite wise, we have to make sure that they are having the proper balanced lunchbox with all the nutrients are there, similar to the healthy plate, according to their age, of course.
Dr. Sam, we are having an opportunity to have Professor Neil with us. Let us use his expertise in this by putting some question. We won't get this opportunity, please.
So again, yeah, we started asking Dr. Nell, and we will end with Dr. Nell. So like one of the question, what do you think regarding them? What is the best preparation for vitamin D to be used? We have heard about a lot of preparation and it is one of our audience question. So what is that? The other thing, how to avoid hypervitaminosis and how to treat it. One of the questions. So the preparations and hypervitaminosis D.
Well, for young children, you would typically use the drops, and the drops are typically available in unflavored, unsweetened form. They'll use an oil base such as MCT oil or olive oil, which is palatable to the children and helps the absorption of the fat-soluble nutrients.
But there is another form for the small kids, for the infants, which is, I mean, have you heard about like that there is some sprays and some something powder that it is put in for the food or something like that?
Those are fine. They're just harder to measure for the parent to get the right dosing. And, vitamin D is actually difficult to test without very sophisticated instruments that are like $500,000 instruments that most companies don't have. So they kind of guesstimate how much vitamin D is in there. And the larger companies will be more accurate in the vitamin D levels, which is important for physicians, pharmacists, etc. So make sure you're using a reputable one that's easily measured so that you can control the dosing.
Dr. Neil,
yes.
Can I ask you something? When you put the powder, a lot of things when you add to the food might interfere in the absorption of vitamin D. Don't you agree? So I have to make sure when we are adding a powder that it have the right proper ingredients to help the absorption. What do you think about that?
Yeah, there are things that can block absorption of fats and fat-soluble nutrients. So that is an important point. You can give the drops on an empty stomach since they have an oil base typically. Lozenges are another option, but again, those are a dry form and you need the fats for absorption. So that's another consideration. You're not typically going to get any kind of overdose unless you're getting up into the range of over 10,000 units a day. Probably 8 to 10,000 for a very young child. So, if you're following the protocol and giving 5,000 units a day, measuring again in 2 to 3 months, you're typically going to avoid any issues.
And for the treatment of hypervitaminosis D, if it is happening, I think it is like proper hydration and sometimes that we are giving if it is affecting like the skins or something like that. Any idea for the hypervitaminosis?
Yeah, the main issue when you get the high levels, and that's typically over 200 nanograms per milliliter, is you start getting some kidney damage and kidney function reducing. And you're not going to get anywhere near that if you're following the protocol.
Yes, sure. Now regarding the vitamin D, do you think that it is like the overcovering of the body, that it is really affecting, the conversion of our vitamin D to the active form? Because we are seeing, okay, here even like in the hot countries, still we are having a high incidence of vitamin D deficiency. Is it more genetics, or what do you think?
Well, there are genetic components, and one of the most important one is the skin pigmentation. The darker the skin, it could take up to 4 times as long for the sunlight to generate the vitamin D precursors in the skin. So that's an important issue. People who are using sunscreen, who are staying out of the sun, if you're only in the sun when the sun is low in the sky, is another issue. Across the Middle East, that's not so much of a problem. It's more the cultural things or the kids in school and avoiding the sun. Based on the pigmentation, they need more or less sunlight. But supplementation doesn't have the same restriction. You can basically give the same amount to children regardless of skin pigmentation, and it's not affected in the same way.
Thank you very much. I think Dr. Islam, Dr.
We want to ask one question.
Yes.
Can I ask?
Yes, Dr. Leila. Because it is very frequent. What is the proper timing for the sun exposure? Because usually it is also to get the vitamin D. And is it effective if it is like behind a glass or something, or it's supposed to be direct sun contact?
No, the ultraviolet B rays of the sun get filtered through glass. And the basic rule of thumb is when your shadow is shorter than how tall you are, you can make vitamin D from sunlight. If your shadow is longer than your height, you cannot. And that's because the sunlight gets filtered through too much of the atmosphere when it's shallow angle, and you lose the ultraviolet rays that cause the vitamin D to form in the skin.
So the shadow is shorter than you?
Yes.
Which is at what, 5 p.m.?
It varies day by day through the year.
It is early in the morning and late in the morning, early in the evening. Early evening.
Yeah, it is from 10 a.m.
What about
to 2 p.m.
Calcium with vitamin D.
Yeah, your shadow length is more important than the time of day.
I think Dr. Leila, Dr. Samir is ready. We are going to end the session, but already 10 minutes. I would like to thank Professor Neil, Dr. Islam, Dr. Wafa, Dr. Fiji, all in the panel action discussion. Sorry, we are forced to go to the next session because Dr. Sami is coming and going means he's ready. Thank you very much.
Thank you, Dr. Sahra. Thank you.
We are going to the next session. Dr. Karna, if you allow me, I will introduce the chairman of the next session. The chairman of the next session is Dr. Muhammad Tahir, a senior pediatric psychiatrist and neuropsychologist. He's chairman and the head of American Welfare Center at Dubai. He's going to chair this session. Dr. Taher, are you with us? If Dr. Taher is there to introduce Dr. Samir, or Dr. Samir doesn't need any introduction. I think Dr. Taher has not joined yet. Well, I will tell a few words about Dr. Samir. Dr. Samir is very well known senior pediatric neurodevelopmental behavioral consultant from New Horizon Center at Bombay. He's very well known all over the world, especially in India and UAE. Yesterday, he had an oration talk, which was appreciated by many. He's expert in this field. Now I would like to request Dr. Samir to introduce the panelists and start the session till Dr. Taher joins. Please.
Thank you so much. Dr. Saurabh, are you able to hear me?
Yes, yes, please.
Yes, thank you so much to the wonderful Dubai Pediatric Club, the entire association, and headed by Dr. Saurabh, Dr. Kalpana, Dr. Laila, Dr. Rajendra Joshi, Dr. Neelevin, and all of you for this wonderful conference, Mr. Tawfiq and Mr. Sadat. And I've been having a wonderful time in this lovely country of yours. So thank you very much. What I liked about our presentation today is, and of course, Dr. Mohammed Tahir is joining us. Just a comment before his audio is on, that this talk, this panel discussion is for practicing pediatricians only. This is not some very high scientific knowledge about the practice of neurodevelopmental disorders, but rather,
welcome, Dr. Tahir.
Yes,
thank you, Dr. Saurabh. Thank you.
Help pediatricians identify these children and what they can do as pediatricians to these children. With these words, back to Dr. Saurabh. And maybe
Dr. I introduce you in your absence. Please, now the mic is yours. You can introduce your moderator and panelists and start the session, please.
So, thank you, Dr. Saurabh. In fact, I joined, but I was not a panelist, so I could not say to you that I'm listening, and thank you for the nice introduction. It was very nice of you, and congratulations on the very nice program, well put together. Yesterday, when I was there on the ship, on the floating ship, it was nice, and so on and so forth. So let's move on. You already introduced Dr. Samir at Dubai, Developmental and Behavioral Pediatrician, New Horizon Child Development Center in Mumbai. And our panelist is Dr. Stefan Caban, clinical psychologist and neuropsychologist at American Wellness Center with us. So as Dr. Samir said that this program is for the pediatric consultants and pediatricians, we will not go in very much detail, but will give the tips and hints to look into the signs or look into the indications where person need to be really identified as if they need a mental health consult or mental health evaluation at a further level. But at the same time, we don't want to limit the pediatrician to send everybody to the mental health professional, because that will be not the right thing. So pediatric consultants are pretty much trained and educated to see that, and they are very reliable people because they are seeing the child in and out, and they are also seeing the siblings, which is very, very important to see the difference. For example, I'll just make a comment. Seeing the sibling or knowing the family is very, very important, and they have the ultimate information about it. For example, if there is a second child and the parents say that, you know what, my first child was okay, but this child looks different. So this is an eyebrow raising. We need to pay attention to it. Why parents are saying that, and we need to get more detail, like what do they mean when they say that this child is different than the other child. So then from there, the conversation starts and we do our homework and we get the collateral information. Pediatric consultants are very good, and they are almost, the first line of contact. But I would also recommend that getting more collateral information, because as a pediatric consultant, you might have to see many kids, many patients as compared to the mental health. We have a limited, but they still, if there is some indication or if there is some need, don't hesitate to get the collateral information from the parent and from the teachers. And the symptoms or any complaints, if they are present in more than one setting, this is very, very important. The two things. One is if the symptom is present more than in one setting. Number two is that if the symptom is affecting the educational, professional, or any other important areas of life, that needs a further evaluation and that need a proper diagnosis and the treatment. So over to you, Dr. Samar, please.
Thank you very much. I think moving from the earlier discussion, which was about a game of shadows, we are already beginning to shed light on this very important subject of children requiring your attention in the clinic with respect to their behavioral issues. And hence, we will now be going to the discussion that we have on the panel today. Of course, Dr. Muhammad Tahir, Senior Pediatric Psychiatrist, as you have already heard him. We also have with us another colleague, Dr. Stefan Kabir. He's a clinical psychologist and a neuropsychologist at the American Wellness Center in Dubai. And I'm sure he's going to be with us in just another moment now. So can you all see my screen? Can somebody just let me know?
Yes, we can see that.
Yes. And has Dr. Stefan joined us?
Can't see him still.
Okay, so let me know when he joins. But again, taking over from what Dr. Tahir said right now, this panel is more about, for the pediatricians, what you could do with these children. Because what happens is, usually when I have a child with a behavioral concern, the first thing is, oh, I have such a busy clinic and I won't have time to go into the family history and the other details, like Dr. Tahir so well explained to us just now. And then the entire impulse is to just refer the child away to some developmental pediatrician or to a pediatric psychiatrist or to a neurologist or to a psychologist, and thereby we limit our own learning. So this entire panel today is for the esteemed panel will be guiding the pediatricians on how you can identify these children at your clinic and what you can do with this family to help the child better, beyond which point you need to refer. So going ahead now, basically we are only going to begin with one symptom, that is hyperactivity. And very often you've been told about the labels and about ADHD and autism, but it's very important to start with the symptoms. Just like you don't always talk about tuberculosis or typhoid, you talk about fever and cough and cold. So this is a symptomatology based approach to arrive at a clinical diagnosis. And I'll be requesting our chairperson as well as our esteemed panelists both to participate and guide us. So a 4-year-old child comes to the clinic of a pediatrician for cough, cold and fever. Mother says she wants you to start an antibiotic immediately, get the test done immediately. You wonder why. So she says she's already got many complaints from schools and does not want to run into any more issues in the school. Now today, the school has become really the biggest religion in anybody's life. And everybody is more than anything else are more focused about school. And whenever there are any kind of complaints from school, the parents, as you are aware, get very, very, very anxious about it. So if you have a child whose mother says that I don't want any more complaints from the school, you would ask what kind of complaints. Very often I get the panelists to refer to say that, oh, the child may be having hyperactivity or autism or ADHD. But my point is the data does not say that. The data says that the child has cough, cold, fever. So it could just be a recurrent URTI, it could be an allergic rhinitis, it could be an atopic bronchitis. The point is, just because you have some developmental pediatricians in front of you and psychiatrists doesn't mean everything is developmental behavioral. So the key issue is go ahead and take a detailed history, as Dr. Tahir said. So the school counselor told the mother that when she asked that the child is not doing well, he is rather hyperactive, but he does seem to learn what is being taught like other children. He does not seem to have a learning difficulty. Now, if you see, I put many words in inverted commas and in italics.
Welcome, Dr. Stefan. Dr. Stefan has joined us also.
Welcome to Dr. Stefan, and we're very happy to have you. As we just said, he's a clinical psychologist and a neuropsychologist of repute at the American Wellness Center in Dubai. Very happy to have you with us, Dr. Stefan. So coming back to this child, these are the terms which are being used very commonly by the school counselor, the resource teams, and the mother and the father and the family tends to get very, very worried about all these terms. So we are all going to try and see what lies behind these labels. So if you have a child who seems to have some hyperactivity, but otherwise doing well, what would you advise? So would you refer the child to an occupational therapist because the school already has one and wants the child and the mother to enroll and pay for the same? Would you refer the child to a psychologist? Would you refer the child to a developmental pediatrician or a child psychiatrist? Or would you start some medications? So you can always answer in the chat box. But as many of you must have guessed correctly, thank you for that. None of this is the right advice at this point, because what we are doing by doing any of these things is we are being hyper about the activity. So the message from the panel is, though there is a complaint of hyperactivity, we request you not to be hyper about the activity. Hold on. There are some others who have a different advice. Oh, don't do anything. This is fine. All boys are mischievous. Schools are overdiagnosing. Do nothing, or just give some knowledge that they've seen over internet or the Instagram post. Maybe somebody posted something and they will just bypass the issue. I think this is also not the right thing to do. And I call this being hypo about the activity, not doing enough. Ideally, what needs to be done is you need to be like Dr. Tahir and Dr. Stephen, and you need to be a little bit like Sherlock Holmes. And you need to be curious as to what is this complaint about this child who's hyperactive but still doing well, and you will ask for details. So the mom speaks with the counselor who says the child is hyper for the first half an hour and then settles down. So Dr. Stephen, would you be really worried about this child? What would you advise the mother? As a pediatrician, what should the pediatrician advise the mother?
Stephen's mic is off.
Yeah. Dr. Stefan, can you open the mic and your picture? Okay, while we are waiting for Dr. Stefan, I will comment Dr. Samer.
Dr. Stefan, it is on the lower left. Lower left corner, you just click on that.
Oh,
yes.
Yeah, we can hear you.
Yeah,
we can hear you.
Thank you.
Go ahead, Dr. Stefan.
So I was going to say actually about the pediatrician facing the mother or the father or even a teacher. The first question I would ask myself is, are they seeing things that are not there? You know, is it their worries as parents, is it, their anxiety and so on? That would be my first question. Okay, and so I would certainly say to a father or mother that no, there is nothing right now to worry about. If he's hyper for the first half an hour, then settle down. It's almost like a normal behavior for a child.
Absolutely right. What a clear-cut message. If you don't find anything very different with this child as compared to your other children, and he's hyperactive only for half an hour, there is nothing wrong with this child. This, the pediatrician needs to say what Dr. Stephen has said. Now let's look at another child. This child has been hyper. Yes, Dr. Tahir.
Correct. This is very right. Thank you, Dr. Stefan. There is another point I would like to add here is that when there is a medical problem like cold, cough, or any other condition, we will not jump onto the hyperactivity or psychiatric problems and psychological issues. Actually, most of the time, psychiatric issues, psychological diagnoses are the diagnosis of exclusion. So we will assess that when all the medical things are okay and there is no problem, and still we are seeing these hyperactivity and behaviors and complaints from the school. Number one point. The second point is that when school is complaining, they usually complain about the problems or behavior which are problematic in the school. The kids who are not very problematic in the school, even though if they have a problem, they will not be pointed out and they will go under the radar. So these 2 points, I think we need to keep in mind. Thank you, please.
I think the audience must be enjoying that. It's hardly been 10 minutes, 5 minutes into the discussion, and there are such wonderful golden take-home points, both from Dr. Tahir as well as Dr. Stefan. Wonderful. Let's go ahead now. This is another child. This child has been hyperactive even before COVID. The school was on for about a couple of weeks, and then COVID hit us, and then the child was at home. But now after the lockdown, the child started going to school. This one continues to be hyper all through the class till he's taken out to the play area. Once he goes to the play area, he settles down. Now, Dr. Stephen, what would you say? What causes this?
Well, there are many things that could exist there. I mean, I see the poor child was, because of the COVID, was not going to school. He was surrounded by his parents, feeling safe, and so on. And then he goes to school, and then he sees all these other kids and teachers and so on. That creates quite a bit of anxiety. So that could be simply that. Or it could be hyperactivity. In that case, we would need to evaluate further. It could be, honestly, it could be anything.
Absolutely right. Absolutely right. So what we are seeing now after COVID is children are displaying social anxiety or stranger anxiety at a much older age. Earlier, you would expect that around 9 months or a year, but the last 2-3 years, these children have been at home. So we have been exposed to society only in the last few months. So Dr. Stephen made such a brilliant point that this could just be some social anxiety post-COVID. Now they're coming out into the open. Very good. Now let's see another child who has been hyper since day one, continues to be hyper through the class, in fact goes berserk in the play area. Now he's even worse when you take him out. He doesn't calm down. His anxiety doesn't go down. Dr. Stephen.
Again, here we're getting closer and closer to have a ADHD case here, to be honest with you, because now he goes berserk in the play area. Strangely enough, is he going berserk in class or not at all? Only in the play area?
Fantastic. So now what we are looking at is maybe there is some problem with the child and we need to look into it. So the next thing to do is go back and ask the mother for more details about what happens at home with this child. And this mother says the child is very active but not hyperactive. He's a sweetheart. He's a darling. Everyone loves him. When she says this, what would you do? On one hand, you have a child who's wonderful at home and very difficult in the school. But the message that we'd like to give here is you can't just depend on one person's history, because a child is the apple of the eye. Every child is the apple of the eye for the mother. There's only one brilliant and wonderful and well-behaved child in the world, and every mother has that child. So we need to be very clear that you go beyond just taking one person's details, and probably you ask in the neighborhood, you ask what is the report from the others in the society where the child stays. What do the others say? So here everybody says the child is very active, everyone loves him, the neighbors also love him. In this case, you have a child who genuinely is good at home and in this neighborhood, not hyperactive at all, but is hyperactive only in the school. Now, Dr. Tahir, Dr. Stephen, what would you say?
Dr. Tahir, you want to
go? Dr. Stephen, go ahead.
Okay, so again, in my position.
Yeah. So I will, in this case, I will go back to the history again. If there is any recent behavior change, if there is any other medical condition happen, or if there is anything change in the school environment, if somebody is bullying him, you know, all the information, as we said that we stick to our golden principle. If there is some behavior problem, and this behavior problem should be across the board, not in only one setting. In general, what I have seen is the kids are doing well in the structured environment. They are doing well in the school, but at home, when there is not structured environment, they are more, you know, things, but the parents can take much more than the teachers. So that's why it goes okay. But in this case, I would love to know more in detail. If we need to ask the teachers to fill in the questionnaires, ADHD questionnaire, I think that will be one thing to do. Or we need to know more about it if anything else is happening in the school.
So my dear friends, you would understand that just take the symptom of hyperactivity and see how much there is to learn from just this one symptom if you are able to take the history correctly. And here, as Dr. Tahir has said, this would point you towards that school is something going wrong in the school. But then you ask the mother more details, like Doctor said, and you ask about the history with the friends. Now, this is another child. In this case, the neighbors don't love him. They're afraid of him. The peers run away. The last time he was invited to a birthday party while the kids were playing, this chap went and actually cut the cake and ate half of it. So nobody wants to call him to a birthday party. Now, what would you say about this child, Dr. Stephen?
Well, I was going to say before Dr. Tahir he gave that his opinion, which was really precise and interesting. The poor parents, I'm always on the side of the parents. The poor parents are afraid. They worry about their child. They hear multiple actors talking about their kid. So suddenly their opinion is going to be starting to change about their child, and their relation to their child change. So as a return, the child is going to feel very observed. That interaction with his parents does not seem the way that it used to be, a normal interaction. So that child might exhibit anxiety-related behavior and not ADHD. This is so important. And you know, doctor, that the differential diagnosis here is so crucial. And the parents, of course, we count on the parents to give us some information on the child. But the parents will give you information on the child based on their fears often, their worries, and so on. And then when you observe the child, you don't see that. So we study, no one invites him to a birthday party. The peers run away, and so on. It might be ADHD, but it might be something else. As Dr. Tahir said before, it would need a little bit more investigation to understand what's happening.
They say a real expert is one who can break down things into very simple take-home messages, and that's what Dr. Stephen has done. These are very simple take-home messages that if you hear the word hyperactivity, don't jump to label the child as ADHD. Even in your mind, you may not use that word. Don't think about a label. First, think about all the details that our wonderful panelists have told us. What exactly is the atmosphere at home? What is the parenting at home? And hence, now we'll go quickly to some detailed scenarios as the child's hyperactivity along with other symptoms. So again, this is the scenario one where the counselor told the mother, child is hyperactive, but he's doing well. He learns what is being taught. He does not have any learning difficulties. So what are your thoughts of this child we discussed with so far? And hence in a child with hyperactivity, these are the things that we need to look at. So Dr. Stephen and Dr. Tahir have already told us about the home environment. Dr. Tahir, you mentioned in passing about abuse and neglect. I know this may not happen very commonly in perhaps this part of the world, but many parts of the world, this is a hidden fact. And I think maybe a minute or two, it's very important to bring about, to talk about abuse and neglect. Could one of our panelists take us on?
Yes. Yes, abuse and neglect is in fact cannot be ignored in any part of the world. We cannot assume that, and we are not the investigators, but at the same time, we can keep our eyes and ears open. I usually use saying that our eyes cannot see what our mind doesn't know.
Absolutely.
So what does it mean is that we should keep in our mind when we are taking the history, when we are observing the child, like the gait of the child, any bruises, repeated injuries, marks, and that is a whole abuse or neglect kind of symptoms. But of course, that can affect emotionally, that can affect behaviorally, and that can also affect medically the children. So that is a big area which need to be explored. In fact, in our medical record, electronic medical record, the record will not let you go to the next page unless you answer this question, if you have checked this one or not for the pediatric population. So this is that much important. The other home environment, I mean, short of abuse and neglect, is that taking the history, meeting with the parents together, and meeting the child alone and asking the question. And of course, being when you see the child alone and the level of comfort child receives, then they will be able to share the information with you. The recurrent illnesses also is very important. I mean, I'm not saying every recurrent illness is a neglect. There should be a medical reason. Of course, the immunity and the other things, hygiene or other things, they should be ruled out, but this should be in the back of the mind. Malnutrition is another, and detailed behavior in the all settings. So
Absolutely.
Over to Dr. Stefan.
Oh, thank you so much, Listen. Well, I absolutely agree with what you said. I just wanted to add something. Looking again just at the child would be a problem. Of course, I don't know if the pediatrician would like to go deeper into the relation between the parents, but if you have parents that are fighting all day together in front of the child, that child is not going to exhibit a normal behavior. I can tell you that right now. It's going to be like what we call attachment avoidant and so on. So you might see things that look like potentially caused by abuse, but it could be just unsettling situation in the family between the parents.
Thank you so much, both of you. And if you have succeeded in convincing of 460 participants right now to at least spend some time thinking about this problem and working with the parents before blindly referring this child away, I think we would have done a very good job. We've talked about even anemia, recurrent illnesses. Who better than the pediatrician to take care of it? And details actually is the key. The devil is in the details of behavior, not just at school, but at home and everywhere else. And simple advice like telling the parents to focus on having a written schedule at home, whether the child gets adequate sleep. We can have an entire CME only on the effects of lack of sleep or inadequate sleep on the child's behavior. Diet we've been speaking about today, outdoor play, parenting and behavioral management, responsive parenting, all of this is what our wonderful pediatricians should be able to do. If, however, in the next 3 months, you don't see any significant improvement with this, be sure to refer these children to the specialist after a few months, but very important, keep monitoring the child. Now we'll go on to a little more complicated scenario 2. The mother says that the counselor told us the child is not doing well. What does she mean by that? Oh, he doesn't seem to learn what the other children in the classroom are able to pick up. He does seem to have a learning difficulty. Now, here you go. These are all the big terms being bandied about here. So what are our thoughts? And I think the most important thing when you see here, and I would like to ask our experts, what we need to do is inquire, examine, go further into detail and counsel the parent. And at this point, what is very important that you go back to details as our experts said, some details of history at home, which is the birth history, the developmental milestones. The birth history could be uneventful, as pediatricians would know. Eventful history would be a preterm delivery, low birth weight child, birth asphyxia, seizures, a ventilated child, anything, a child with hyperbilirubinemia, anything that was eventful around the birth history or even antenatally, if I may say so, as well as the developmental milestones, whether they're age appropriate or if delayed, whether you have a global developmental delay, you have a specific domain which is delayed, and worse and scarier, whether there is any deviancy, the child does things which are not expected, like spinning or repeatedly flapping his hands or flicking his fingers, so on and so forth. Now, armed with this information, you see the scenario where you have a child who seems to have hyperactivity and also problem learning in the classroom. Scenario 3 could be a child who has a history only of specific speech delay. Scenario 4, he has a history instead of global developmental delay. Let's see what the history of speech delay could be. 3A. In this child, he speaks but only nursery rhymes or names or numbers or names of people. He does not follow commands orally. He has poor eye contact and does not respond to his name call as expected for age. Dr. Stephen, this certainly is getting into murkier water, isn't it?
Absolutely, absolutely. I'm sure Dr. Tahir could say even more than I on this, but that we're starting to get into potential autism here, because no eye contact, there's not following commands, and so on and so forth.
Yeah.
I think should start thinking that direction, the differential diagnosis.
Right. This is actually very characteristic scenario, and we need to look into different aspects. Of course, we have to rule out at least one elephant over here. That is the spectrum, autism spectrum. And I think our all consultant pediatricians, they know that there are three categories, there are three requirements for autism diagnosis as in the DSM-5, but the most important thing is the reciprocity of the conversation, reciprocity of the change of the affects with the child. For example, the meaningful eye contact, not a fleeting eye contact. That is very important. There can be a speech delay. I have seen families in which the speech delay is up till 5-6 years of age, and they say, oh, my mother told me that my uncle spoke at the age of 5 or 6. So speech delay could be possible, but the most important thing is the communication. If the child is able to communicate by gestures or can respond at least, at least we can rule out this thing, and then we can look into the other areas like voice learning. Is this learning is something new, or this has been continuously happening since the child was born, nurseries and going to the KGs and so on and so forth, or this is something new. So again, history. But the communication at this age, especially younger age, we need to be very mindful of the quality of communication, quality of the eye contact, as well as the reciprocity of the interaction. That is very important. If those things are there, then we have to look for the other reasons for this kind of global delays.
Ladies and gentlemen, I think Dr. Tahir has made such a brilliant point that you look for the other aspects of interaction and communication besides speech. For example, look at social interaction, look at non-verbal communication, look at whether the social reciprocity, whether when the father puts out his hands or arms, does the child respond by running into his outstretched arms? These are very, very important. Does not follow commands. So I would submit that the scenario 3A is not even a case of a problem of speech. It is far beyond that because he is speaking repetitively. So this is a deviancy. He's repeating nursery rhymes without understanding what they mean. He's repeating numbers without understanding what he means. So this is not even a speech problem. This is a problem of social interaction. Social non-verbal communication is abnormal. Behavior is abnormal. and also speech is abnormal. So what would we do as pediatricians? Always, 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 one thing we can do is look for vision and hearing and get this child checked for hearing on an audiogram, on a proper audiological evaluation, check the red flag, suspect autism. Very important, counsel the parents. You don't need to use the autism word. You can say that, look, it's not only a speech problem. He is speaking, but he's speaking repetitively without understanding what he means. Meaningless speech, purposeless speech. He does not have good eye contact, poor social interaction, poor social reciprocity. So these are the things that you need to bring it out to the parent without even using the word autism. But this is a child you need to refer to a developmental pediatrician or the child psychiatrist or the clinical psychologist, but always, always monitor, because even at times the expert may make a mistake. And if you have referred, you need to monitor the child and find out what's happening. So again, hyperactivity, but turns out to be totally different. So these are the red flags, as we know: no big smiles or joyful expressions by 6 months, no consistent response to name call by 10 months, does not use non-verbal communication, and does not say single meaningful words by 16 months. Here is scenario 3B. Now, this child doesn't speak anything at all, not even repetitively, but he also does not follow eye commands. However, he has good eye contact, but he does not respond to name call as expected. However, he has excellent use of gestures and pointing to communicate what he needs. This is a child with very good nonverbal communication. What would you inquire and examine as a pediatrician? Dr. Tahir, would you just take us through this?
Yeah, of course. I mean, in this case, we need to have a hearing testing done, and we need to take the proper history for this, of course. And as you said, that if he has a good eye contact, meaningful and reciprocal eye contact, and non-verbal communication is very good. So hearing evaluation, of course, the vision, hearing aids. Yeah, I mean, in this case, we need to know more about it, and we need to find out if there is anything else going on, like a failure to thrive, or the vitamin deficiency, and some toxic, toxicology screening. So there are many things pediatricians do, but in this case, I think at least we are, little bit satisfied that his nonverbal communication and eye contact is good. So there will be something most likely will be treatable or replaceable.
Absolutely. And this is probably the only isolated case where you can directly start with some kind of speech training after the hearing aids, but do not make the mistake of starting with speech for a child with autism, because social interaction, social reciprocity, social behaviors need to be learned before you can go on to that. So this is a case that all of us would have seen in our life, I'm sure. As Dr. Saab said, there could be a case for a genetic evaluation and the connects in gene, and this runs in families sometimes, or it could be because of the exaggerated use or the intensive use of antibiotics maybe in the neonatal period. So going ahead now, let's go and see what can be done. You have to counsel the parents about all these things about the child's education. Now, moving on from isolated delay, let's look at a global developmental delay. Now, same child, hyperactivity, seems to have a learning difficulty. He also has a history of global developmental delay. What do you do next? Well, this is where your examination as a pediatrician comes in, where you check for clinodactyly, you check for dysmorphology, you check for the ear, the preauricular ear tags, as well as check for an entire detailed CNS examination. I don't need to tell all you brilliant pediatricians how to do that. But if this child has a history of global developmental delay, here's a scenario. He is unable to keep up with his peers socially, or at play, or at academics. He is not able to catch up with what the other children of his age are doing. He needs repeated instructions. Of course, he does little better with one-to-one attention. If you sit with him, keep talking to him, keep explaining, gradually, slowly, he will be able to catch up. But he finds it difficulty to translate what he has learned at home into what he may do in the neighborhood or at school. So the mother at home sits with him one-on-one, spends a lot of time teaching him. He may be able to pick up some academics, but once he goes to the school, he's again lost. He runs around, he is not able to follow. And nothing significant on medical history. I've put that in inverted commas again, as if the rest of what we discussed so far, and both our experts are telling us to keep asking the history, as if that is any less important. I mean, that's not political history. All that is medical history. So we need to not look down upon this clinical history that we spoke about. And in this case, again, Dr. Tahir, Dr. Stephen, what would you suspect? Maybe Dr. Stephen would like to take us through about this child.
Well, we're saying that he's unable to keep up with his peers socially. That's the first thing that sticks to my eye, to be honest with you. He needs repeated instruction. He does better with one-on-one attention and nothing significant on medical history. Again, here we have a case in terms of differential diagnosis that could be a kid with having learning disorders. Potentially, there's some potential autism, but they're not completely developed, to be honest with you. But the repeated instruction does better with one-on-one attention or ADHD. So we have three possibilities, but I think I would look better. I would look more into the learning disorders here, in my opinion.
Absolutely. Dr. Tahir, a quick word?
Yeah. So I think, again, the apple doesn't fall away from the tree. So we will look at the parents and ask their history. What are they doing? What are their, socioeconomic level? What is their professional levels and all these things, and then get the history from them. Of course, the medical is ruled out. In this kind of situations, we need to rule out, especially the communication, the social interactions. I mean, it's quite possible in intellectual kind of disabilities as well. I'm not saying the mild, moderate, or severe retardation, but those areas can be also considered. And we need to actually know if there is a recent change or this is going on for a long time. So here I would like to say two things, irrespective of the circumstances. In social problems, social deficiencies like in autism or in childhood disintegrative and other disorders, not in childhood disintegrated disorder, but in the autism, there is a gradual not achieving the developmental stages, milestones, physical as well as mental. But if there is a decline, for example, once they achieve the mental and physical goals and then they started declining, then we need to look into the different diagnoses or different problems. For example, childhood disintegrative disorder, in which like child achieve certain capabilities and then they lose it. In the later age, early adolescents are the children, if they achieve the developmental milestones, physical, mental, and then they start declining, maybe a psychosis. So we need to be very careful when we take the history, what happened 2 years ago, what happened 1 year ago, since when these children are showing more deficiencies in times of learning, in times of social capabilities, are they losing what they have already learned, or they did not even learn to begin with the social interactions and the things. So at this level, I would see if the pediatrician, the pediatric consultant is concerned about that, he should be seen by the neurodevelopmental psychologist or psychiatrist.
Absolutely, very good messages and simple things. What the pediatricians can do is don't rush too much into the diagnosis, but counsel parents that, look, your child is learning, but a little slower than what children at this age should be learning. So what could we do? Set small goals for these children. Simple things like the activities of daily living, simple things like simple household chores to be done at home. Spend more time with the child, go one-on-one. Even you have a larger family, you might just blurt out the instructions and 3 of the kids might be able to understand it. This one kid would not. You need to focus one-on-one with this child, and you will find that the child is doing better with this, and monitor this month on month. Call the child back to your clinic. If you see that the mother says, yes, when I set small goals and I work with him one-on-one and I keep repeating that instructions for one particular goal, then he does pick it. And once he picks it up, he doesn't lose it. Then that's a very important history. And why we're saying this, it's very important for you to monitor this over a period of time. This is not a spot diagnosis, and you don't need to refer for diagnosis unless you are looking at the next pregnancy. But what is very important not to miss is this case that I'm showing you now from my clinic in Mumbai, in Bombay, where this child is around 8 years old now. When he came to us, he had this history of mild developmental delay across all domains after birth. And he went from one doctor to the other, one developmental pediatrician to the other, from one therapist, psychologist, special educator, one school to the other. We've got a remedial program in school. Parents are paying through their teeth. And eventually when he came to us, just a detailed family history. There was a history of fetal loss in the mother. She had 3 miscarriages. Also her similar history in her sister. And as you can see right now, this is very evident. It was clinically, we tested for Fragile X and it turned out to be possible. So typically when we say this case 4A, keep Down syndrome, keep Fragile X in mind as a prototype. Now going ahead, 4B has all these features of 4A. difficult to adapt, difficult to learn in social situations, difficult to learn cognitively. In addition, he has an eventful perinatal history of seizures, dysmorphic features, the so-called medical history. And in this case, again, these are the things that you need to do. And probably Dr. Tahir would like to quickly tell us, because this is typically a case of perhaps, like an HIE with a cerebral palsy with an intellectual disability. Just a quick checklist, and maybe Dr. Tahir would add a point or two.
Yeah. I think with the CP or cerebral palsy, I mean, of course, there is a lot of a lot of systems involved in the brain areas. Different brain areas are involved. Of course, we need to have a baseline. What is the baseline? Get the testing done. Of course, the vision, hearing, electrophysiology, and neuroimaging may show something. Genetic evaluation is also very important if there is a child having the same thing, or if there is a family history of any problems, So if there is any medication used for the child, as well as medication used during the pregnancy, there are some effect. Substance abuse during the pregnancy, mother's mental health issues, for example, the mood stabilizers, depakine, lithium, they are the very, very, for the effect during the child in the pregnancy. The mothers who are taking these medication during pregnancy, it can affect the children. So all these things must need to be ruled out before we jump into the conclusion that this was a unknown cerebral palsy or there is no finding. So we need to know the toxic ingestion during the pregnancy, or the child's toxic ingestion early as a. So these are the medical issues and problems. But of course, this child probably will need to see the neurologist for the either history, if this is a febrile convulsion or this is really the grand mal or petit mal or something. So after the neurology clearance, this child need to be evaluated as a baseline, the mental status. So by the neuropsych evaluation assessment, and that can actually shed light on the different areas of the brain which are affected, and can help us develop the individualized treatment plan to help him achieve the maximum of his potential.
Excellent. Just before we go to Dr. Stephen, just a quick point. Vision and hearing are common to each and every child you see with any kind of a symptomatology related to behavior. Electrophysiology, that is an EEG and an MRI CT scan, are probably overused and abused in all these children. This is the first case where we have shown specifically you may need an EEG and a neuroimaging just on basis of these symptoms. Otherwise, one would not need to do all these tests. Genetic evaluations, of course, Dr. Tahir told us about it, and the medications. Dr. Stephen, is there any role that you would see as a clinical psychologist about evaluating this child in terms of his intellectual potential or cognitive potential? Quickly, can you tell us what the pediatrician can do in the clinic to check this?
Well, again, Dr. Tahir mentioned the neurocognitive evaluation. I think in a case like this, obviously we need to know how the brain is doing in terms of cognition, memory, attention, and so on. It's also going to depend on the age of the child. That's going to be very important. At certain ages, it's very difficult to evaluate the child neurocognitively. And with me as a psychologist, I would certainly say if the child is, 6, 7, 8 years or older, I think a neurocognitive evaluation would be helpful to understand better what could happen also in terms of prognosis for the child.
So, dear friends, we heard it from the neuropsychologist himself that at this age, at 4 years, it's very important for us as a pediatrician to take this history and to talk to the parent and not just depend on these high-five psychological evaluations at 4 years. But if the child grows older and they're going to come to that, that's where there is a history. For example, the case scenario 5, no history of developmental delay. This is a child who has no significant birth history, no developmental delay, no dysmorphology. Examination largely normal except for some small findings that you may have. But on history, he has some confusion with right and left sides. He wears the left shoe on the right side. He's a little confused with above and below. Some confusion with spoken language. Would you say ask instead of ask or something like that? And he has difficulty learning alphabet sounds between B and D, P and Q, between M and N. He makes mistakes. He would read TAP for PAT. Now, this sounds a little different from all that we have seen in a child with hyperactivity. This is a child with hyperactivity who doesn't have any of those other issues. He's good at communication. He's good at behavior in general, Dr. Stephen. But what is this on the right side that we are seeing now? What is this confusion about?
Well, obviously there are some learning, some brain disorders, in my opinion. That doesn't mean that they are very important, but it sounds like dyslexia. To be honest, if I look at someone who has a confusion, it disappeared the list of. Anyway, it sounds like dyslexia. It seems to have a problem with letters, words, and so on. If I remember well what was in that slide, because it disappeared. So that's what I would do. Again, another evaluation potentially with a speech pathologist, not just the psychologist. Speech pathologists can also bring their important contribution to a case like this.
Absolutely. And then again, vision and hearing is equally important. No investigations mandated. No MRI, CT scan, or an EEG or a genetic testing is mandated for these children. Expensive genetic biochemical tests are not needed. No neuroimaging. And here this is the role of the specialist like Dr. Stephen, where you would have to do evaluations for a specific learning disability, of course, in an older child, 7-8 years of age. And he would then also need to rule out other comorbidities and ADHD along with the specific learning disability. There could be an anxiety that is coming up, a depression that is coming up. And hence, please go ahead, Dr. Stephen.
No, I said absolutely. I was agreeing with you.
Yeah. So what do you see about the role of, how do you see children developing anxiety or depression? Because these things have been missed. Have you seen that coming on as well?
Listen, the child, and I'm sure Dr. Tahir will have quite a few things to say about that, but remember, the child who's having these problems is going to be having problems with his peers in school, with the teachers sometimes, and so on. So we're going to have a double effect: the potential brain problem, dysfunction, and the interaction with his peers in school and so on. He might find himself completely isolated, unable to communicate properly, and so on and so forth. So yeah, the psychologists here, psychiatrists, and so on will be central to help the pediatricians. I mean, to have a better idea of what's happening.
Absolutely. I think the important message is that not everything is inborn or acquired at birth itself. A lot of it is acquired not due to the biological problems, but what the environment does to the child. And hence, inability to suspect this child early, and worse, not do the right thing, probably ignore it or do the wrong thing, is actually going to worsen the child's condition and going to add the so-called comorbidities, which have been a gift of the environment and all of us, and not Mother Nature by herself. And hence, what is required is a program not just for remedial education for these children, but also for their behavioral and emotional concerns, including the child, the family, the parents, as well as the school teachers. How do we behave with all of them? So thank you so much. Monitoring is very important. Counseling the parents and child is important. What will we do hence about hyperactivity? Don't refer it in a blanket way. Simple things, the approach matters. Take a simple history. Our experts have told us about the pregnancy, the perinatal history, the developmental milestones in infancy. The first 1,000 days is a hot concept going around now about early childhood development. And when you talk about school, don't talk only about academics, talk about behavior and communication. And hence, dear friends, explore each symptom in some detail. Very important, explore symptoms in combination with each other. We looked at how hyperactivity with speech delay looks as compared to hyperactivity global developmental delay. And that is very important. All of us are aware about the examination. Don't miss the good old-fashioned general examination and the CNS examination. Simple things like counseling the parents about nutrition and sleep, adequate sleep time, decreasing and if possible completely limiting the screen time, responsive parenting, which is a very important part of nurturing care, early childhood development programs. Most of the countries in the world have it. You can just go and check this on the UNICEF website. They have some wonderful information on nurturing care, both on UNICEF as well as WHO websites. Of course, wherever recommended, a developmental screening at 18 months, at 24 months, an MCHAT can help you pick up with the child with autism. And very important about the safety and security, Dr. Tahir made a very impassioned plea for looking at the safety and security of the child. And if you do refer, make sure the child comes back to you with a specific working diagnosis. We don't want traffic policemen to do this, do that, and that's it. Go do OT, do speech therapy. That's not going to work. We need an expert with a specific working diagnosis and not just a traffic policeman. So some take-home messages: do not be in a hurry to label especially the symptoms, speech delay, learning difficulty, not doing well, slow learners. These are terms now being picked up by the parents and come to you with a lot of anxiety with these terms, which are nothing but labels. Please, 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 as a pediatrician, you are more well placed than any of the so-called experts like us to counsel the parents, because the parents trust you. They don't know us, they know you. You've been there with them since the time their child was born. Make sure you tell them that these are just labels. Let's go beneath, let's look at the symptom. Let's not consider hyperactivity to be a disorder. Let's not consider speech delay to be a disorder. Analyze the symptoms, map the approach like our experts told you today. Look for the comorbidities, some given by Mother Nature, many more given by the rest of us. Do not initiate or rush into symptom-based therapy or intervention unless you have a working diagnosis of what's happening. Well, thank you very much, my wonderful panelists. And I want to compliment Dr. Tahir. He's a chairperson, but he agreed because we wanted to have a very interactive session, and he agreed to join Dr. Stephen as a panelist. Dr. Stephen joined and participated so well. We wanted this presentation in a way how you see the child in the clinic rather than talking about ADHD. And both these experts have come down from their highly esteemed positions as experts to explain to the pediatrician what you as a pediatrician should do. So if there are any questions, I would be very happy to answer them. But thanks once again to our wonderful chairperson and panelist, Dr. Muhammad Tahir, as well as Dr. Stephen Kabain. Thank you very much. I'm going to stop the presentation and let's hope we have some questions waiting for us.
Thank you. Thank you, Dr. Samit. Thank you. It was a wonderful way of presenting case. And in fact, we touched so many areas, so many topics, and it's a very good learning. So I will just make a last comment and then I will send it to Dr. Saurabh. I like your way of presenting in a way. The one thing which you mentioned is that the one problem can start, and if it is left untreated, it can lead to many more other problems, and the original problem may be hidden in there, and then it can mislead the diagnosis and the problem. So look at the things at the bottom and their starting point and solve it over there, and try to ask more things and divert them accordingly, not to label everybody. And my comment on this one is also, I like the way you say the person has a problem. This is not he is not an autism. He is not an autistic child. The child has an autism. Those kind of especially thinking is very, very helpful for us as a clinician and for the parents to hear about the child, because child is not sick. Actually, child has an illness. So thank you very much, Dr. Samir and Dr. Stefan and Dr. Saurabh for this.
Thank you very much, Dr. Tahir, Dr. Samir, Dr. Stefan. It was an excellent discussion in a different way. I'm sure our viewers, nearly 500 viewers nearly following us. Thank you very much. We have a time factor limit, so we have to go to other session. I would like to thank all of you. Inshallah, in future, we'll have more sessions. Thank you very much.
Thank you so much.
Thank you so much. Thank you. Thank you so much.
Now, next session is pediatric infectious disease. We are also having eminent speakers and panelists from United States and UAE. Dr. Parveen Khilnani last night, he was with us. He's supposed to join us from India. I don't know if he has joined or not. If not, I will introduce him and then introduce our moderator, Dr. Zainab, to introduce the panelists. Actually, Dr. Parveen Khilnani is a senior most pediatric infectious disease specialist from India. He's a pioneer of pediatric intensive care in India. Sometime back, United States declared 5 pediatric intensivists. One of them was Parveen Khilnani from India. He's very well known. So till he joins, I'd like to introduce our moderator, very well known, Dr. Zainab Malik, Senior Consultant Pediatric Infectious Disease from City Hospital, Dubai. Now I would like to request Dr. Zainab to introduce the panelists. We would like to welcome Dr. Kenneth also from United States. Please, floor is yours.
Hi, good afternoon, everyone. Thank you, Dr. Saurabh, for this introduction and for hosting this amazing meeting. We've got some wonderful panelists, so hopefully we'll have a lot of interesting discussion today. I'd like to welcome all of you and our first speaker, our guest from the US, Dr. Kenneth Alexander, who's agreed to join us on his Thanksgiving weekend. Happy Thanksgiving, Ken.
Thank you. It's a delight to be with my friends.
So we hope you enjoyed the turkey.
Thank you. Yes.
So as many of our listeners know, Dr. Kenneth Alexander is the Chief Division of Infectious Diseases at Nemours Children's Hospital in Florida, the United States. And he's going to give us a brief talk, followed by Dr. Walid Abu Hamur, whom we all know and love, who is a consultant in pediatric infectious diseases at Al Jalila Children's Hospital in Dubai. And last but not the least, Dr. Ghassan Gatache, who's a consultant pediatric infectious diseases and head of department at the WAM Hospital in Al Ain. So I'd like to request Dr. Kenneth Alexander to start as our guest. Thank you.
Okay. So I'm now sharing my screen. Can you see it okay?
Yes, fantastic.
Okay, very good. So what I'd like to do is talk for just a few moments about syndromic diagnosis and some things that, to be honest, I've learned recently because of patients I've cared for even just in the past month. As you're well aware, syndromic diagnosis is something that we're using now to make more rapid diagnosis for our patients, especially in the hospital. And where syndromic diagnosis is important is that it really reflects the way that we think. Now, I say syndromic diagnosis, perhaps the thing you're most used to thinking about are these biofire panels where you'll maybe send a respiratory sample or a gastrointestinal sample, usually a stool sample, or a sample of spinal fluid. And instead of doing a test one organism or virus at a time, in fact, we're doing the whole panel. So for instance, if we think about the respiratory panel, rather than testing first for rhinovirus and then for influenza and then sending a test for RSV and then for parainfluenza, instead, the way these panels work, of course, is they test for everything, or at least for a collection of things. And what that collection of things is, of course, is your and my differential diagnosis. When we see a child with a fever and a nasal discharge and a cough, what's in our differential diagnosis? And that's what's in the panel. So syndromic diagnosis is really a way of approaching differential diagnosis in one test. Let me give you another example, of course, is meningitis. And this is something, of course, we all see. It's something we all fear. And we learned long ago in our training that meningitis, especially in babies, has a broad differential diagnosis. And I've put up a list of viruses and bacteria associated with meningitis in young children. Of course, the challenge that you and I have as clinicians is that meningitis caused by an enterovirus doesn't look terribly different from meningitis caused by group B strep. Meningitis looks like meningitis. You've got an unhappy baby, and it's very hard to sort out. And where these panels come in is that rather than doing one test at a time and waiting for everything to come back, of course, we get our answers fairly quickly. And so this is an example of one of the panels. This is one that we use for diagnosing meningitis and encephalitis. And of course, the child comes in, perhaps seen in the emergency department. Some spinal fluid is obtained and it's sent off. And all these tests are done by PCR in the single panel. And you can see here that the sensitivity and specificity are very, very high. So how should it work? And so first of all, what I'd like to give you an example of how one of these panels works really well. So perhaps you have a 3-week-old former full-term infant who shows up with a fever, 8 hours of irritability, maybe a shrill cry. The child has vomited, spit up a couple of times. Maybe the child's brother or sister has a cold. And so this is a baby in the emergency room. But because of the irritability, a workup is done. And of course, what you and I are worried about is sepsis and meningitis. And you appreciate that, of course, the differential diagnosis in a 3-week-old includes group B strep and listeria and gram-negative rods and all these things. And in fact, at 3 weeks, it's really rather difficult because not only do we have the pathogens that affect the newborn, but the pathogens that affect the older child. And so all these things need to be looked for. Now, the old way for doing this, of course, was we sent off a gram stain and culture, a cell count, protein, and glucose. Maybe we sent an HSV PCR. Maybe we sent enterovirus, but these were all send-out laboratory studies, and they were going to take anywhere from 3 days to 2 weeks to come back. And then you put the baby on antibiotics, and you sat there and you worried. And this is typically what we did. The new way with syndromic diagnosis is that the baby is seen in the emergency department, the spinal fluid is collected, it's then sent to the laboratory, and this is usually done in a hospital laboratory, where all these test results are available usually within 90 minutes. And where they're important is not only is the assay sensitive, right, around 95%, but it's highly specific. So we can believe a positive when we see it, and we can generally trust a negative when we see a negative test. So in this more modern situation, antibiotics can be discontinued fairly quickly, and the infant is sent home the next day, where we would have previously been still waiting for culture results. So this is a really nice way to go. The trouble is, it's not perfect for everybody. And so I'll share with you a case here I just had about a week ago of a 14-year-old female who came in. She had a rare tumor that had been excised. It had direct intracranial invasion. And following complete excision of the tumor, she was left with a large intracranial cyst. And so 3 months ago, an Ommaya reservoir had been placed to allow for drainage of the cyst. Well, the drainage occurred, but unfortunately, this young woman has been sick a lot since. She's had severe headache and vomiting and has been febrile from time to time. The neurosurgeons did a CT scan and showed that the reservoir was working, the cyst had collapsed, and therefore their approach was problem fixed. We don't have any more to deal with, and your problem is to deal with the fever. So ultimately, the child sort of bounced around and ended up in our emergency department when the pain became severe and she started having mental status changes. And of course, mental status changes and fever means you need a lumbar puncture. And so our emergency department team did the right thing. They did a lumbar puncture, and you can see the results here, right? The child has meningitis, has a high white count with 92% neutrophils, a lot of bacteria, a moderately high protein, and the glucose is okay, but not terrible. But there's a problem. Nothing grew. And what's interesting is that the PCR panel showed nothing. Nothing showed up on that PCR panel. So all of a sudden, the emergency department team and the PICU team are going, well, maybe there's something else going on, and this patient doesn't have an infection. We want further evaluation from the oncologist. So that begs the question, how certain can you and I be that this patient does not have a bacterial infection? And where else should we as consultants be looking? So let's go back and look at that panel for a minute and see what's on this panel. Well, in terms of bacterial infections, you can see that on the left, which is certainly what we would see in a patient with community-acquired meningitis, especially if we add E. coli K1, a baby. But what this patient ended up having was Klebsiella. And as you can see, looking back at the list, Klebsiella is not on the list. And this is because these panels are really optimized not for patients with hardware, but are optimized for community-acquired meningitis and encephalitis that occur in the absence of implanted hardware. Organisms seen in the presence of implanted hardware are different. Often they more accurately reflect what we see in positive blood cultures. staph, strep, gram-negative rods, and things that the panel won't detect. So let's do another one. And we'll just do two, but this is the other one I want to share with you because this is another story that's just happened in the past few weeks. A 7-year-old male is brought for evaluation of fevers and new onset seizures. And he came in from a community hospital, and the seizures were actually quite difficult to control. They managed to control the seizures in the emergency department pretty much by general anesthesia, and the patient was taken for a brain MRI, which was fortunately normal. So then a lumbar puncture was performed that yielded spinal fluid with the following findings: only 42 white cells, the preponderance of which were lymphocytes, 2 red cells, glucose and protein were in the normal range, and the gram stain of the spinal fluid showed 1+ white blood cells and no bacteria. Well, this is not terribly helpful for you and me, is it? This doesn't really give us an etiology. But when the CSF meningitis panel came back, it was positive for HHV6. Now, what to make of human herpes virus 6 in a PCR? Now, you and I know that HHV6 is the causal agent for roseola. And when we think of patients with HHV6, we think of the young child with a very high fever who's febrile for 3 or 4 days and then develops a rash as the fever comes crashing down. And what we need to remind ourselves is that for all of us, we have HHV6 latent in our lymphocytes. So this is a normal finding in people. So in this child, I don't think that we can attribute this patient's symptoms to HHV6. Instead, I think what we're finding is that HHV6 is a normal finding in cerebral spinal fluid lymphocytes of children and adults. So then you may ask, well, why is HHV6 on the panel? The reason HHV6 is on the panel is that in your bone marrow transplant patients, in your patients with severe combined immunodeficiency, people terribly deficient in T cells, HHV6 can be a cause of encephalitis. But in the immunocompetent child, HHV6 from a multiplex PCR is nothing more than an incidental finding. So to close out, while meningitis and encephalitis panels are very useful for children with community-acquired meningitis and encephalitis, the panels are not appropriate for children with intracranial hardware. And remember that HHV6 is a normal finding in the cerebral spinal fluid of most children. So with that, I'll stop there.
Thank you so much. That was very, very interesting. And I'm sure that we're going to have a lot of questions because we use PCR panels here like candy, CSF and respiratory and GI. And unfortunately, that leads to a lot of positive things that we find. And then the question comes up, what do we do with that? So, so hang on. Hopefully, we'll have lots of questions. And our next speaker is Dr. Walid Abu Hamur, who's going to give his talk. Welcome, Dr. Walid.
Thank you, Dr. Zainab. Thank you again for Dr. Sohrab, Dr. Kalbana, Mr. Tawfiq. And I'm glad to see all my friends on this panel discussion. For the sake of the timing, you know, this is a lengthy story. An infant 6-month-old who admitted to our ICU and for a month and still in the hospital. So I will try to be as brief as I could. Can you see my presentation? Hello?
Yes, we can see it. Perfect. Thank you.
Okay, thank you. This is 6-month-old female infant admitted to another hospital actually with URI symptoms, low-grade fever, petechial rash noted on the lower limbs, and 1 episode of seizure, a prolonging of the eyes. The significant history, baby was in India 1 month prior to this presentation. And this is the differential diagnosis. I will keep it for you to think about it. The baby was born in United Arab Emirates, full term, no previous hospital admissions, immunization up to date. Initial labs in the other hospital showed hyponatremia. Hemoglobin was okay. Leukocytosis, platelet, if you notice, 38,000, which is really low. CRP slightly high. Bicarb, definitely the patient was acidotic. Creatinine was okay. Coagulation derangement, PT high, PTT also very high with the prolonged INR. CT brain was done at that hospital and transferred to our hospital. So this is a 6-month-old, was in India 1 month prior to this presentation, presented with URI symptoms, a seizure, fever, petechial rash noted on the lower limbs, and showed hyponatremia, deranged coagulation profile, leukocytosis, thrombocytopenia. Think about the differential diagnosis. Okay, baby was given IV ceftriaxone and transferred to our hospital. On admission, the general condition, sick looking, drowsy. There was spontaneous opening of the eyes, but lethargic and having weak cry. Vital signs are okay, except tachycardia. Blood pressure was maintained. Eyes, there was a sluggish reaction to the light. Lungs, tachypneic but clear. Heart, tachycardic. Abdomen, liver was 3 to 4 centimeter below costal margin. Bilateral edema of the feet was noted. Prolonged capillary refill with cold extremities. Petechial rash was noted, and the baby remained drowsy or lethargic. What's your diagnosis or differential diagnosis? Keep it for yourself till the end. We started cefotaxime and vancomycin. So we continued the same antibiotics. Neurology consult was done and Keppra was started. NBO, IV fluid, remained lethargic. And actually, I was called at 2 a.m. in the morning by the intensivist, by the specialist, that the baby became more drowsier and having hypotensive episode 50/13. So with the prolonged capillary refill. So now the baby was in shock. So what you will do? So knowing this history and now the baby in shock, what's the next step? At that moment, I instructed to give IVIG 2 grams per kg over 12 hours. High dose pulse therapy 30 milligrams per kg over 1 hour, and I recommended urgent bone marrow in the morning, urgent bone marrow biopsy in the morning. Of course, on admission, we send the MISC panel. We have a standing order for MISC panel for hyperinflammatory immune response. And for the sake of the time, also, I will show you graphs of most important labs. Here, if you look at the white blood cells, initially there was leukocytosis reaching maybe 37,000 and started to drop. And final at the course, you can see recovery or normalization from leukopenia. If you look at the hemoglobin, if you recall, it was 10 on admission, went down to 4 grams per deciliter, and improved. The platelet count went down even to 17,000. Neutrophil absolute is okay. Lymphocyte ended with lymphopenia, severe lymphopenia. Regarding the PT, very prolonged, 35.2, PTT 58, almost 59, with increased INR. Liver enzyme, ALT 2748, EST more than 4,200. Ferritin was 33,511. And fibrinogen was low. LDH was really high, more than 7,500. Triglycerides 128, so it's normal. D-dimer was prolonged. Pro-BNP was high, 3,146. Troponin was a little bit high. COVID antibodies positive. For dengue fever, because it was in the differential diagnosis. Non-structural protein 1 antigen was positive. IgM weakly positive. IgG was negative. So the differential diagnosis on admission, we thought of multi-system inflammatory syndrome in children, MISC, post-COVID, severe dengue, hemorrhagic fever, or dengue shock syndrome, actually, with multi-organ dysfunction. HLH, it could be primary or secondary in this patient. And of course, septic shock with multi-organ dysfunction, including acute liver failure. For the sake of HLH, secondary causes, we did all the enzymes listed here: EBV, CMV, Parvo, Adeno, HIV, HSV, hepatitis A, B, C. Everything came normal. Echo, it showed minimal pericardial effusion, pleural effusion also noted even on the echo. Abdominal ultrasound showed ascites. Bone marrow done the next morning, and it showed a picture remarkable for HLH. So till we got the bone marrow results, we continued methylprednisolone, given for 3 days, high dose pulse therapy, and then shifted to dexamethasone according to protocol of treating HLH. Patient improved for a while and then deteriorated, so we elected to add anakinra. Started with 10 milligram per kg per day BID. However, this patient used to wax and wane and to improve and to deteriorate. And so, of course, this is MDT treatment, multidisciplinary team treatment, rheumatology involved in this case, as well as the hematology. And we had meeting, and we elected to start another biological medication. This is just X-ray showing the pleural effusion. So there was debate to start etoposide or JAK inhibitor. However, interleukin-2, which we were ordered, came really very high. Interleukin-2 receptor alpha soluble 3,482. So the decision was taken to start JAK inhibitor. We started with the Jakavi. There was improvement in the chest X-ray. The hospital course marked improvement, and actually on a Friday, the baby off the ventilator, just nasal cannula, we transferred the patient to the regular floor. Of course, we asked for whole exome sequencing, genetic test, and came on a Friday. I chased them to have the results before this presentation. And fortunately, we got it, and it is normal. This is to show you the course of the labs and normalization of the abnormal results. Thank you so much.
Thank you so much, Dr. Walid. This case generates a lot of questions, which we'll hope to address in the Q&A session. But very interesting, and glad to know that the baby is doing well. I'd like to welcome our next speaker, Dr. Ghassan. Welcome. Please start your.
Thank you, Dr. Zainab. And I would like to thank Dr. Sohrab for the invitation. I would like to share my screen, but something pops up that you cannot share the screen while the other participant is. I think, Dr. Walid, your presentation is somewhere hanging.
Thank you so much, Dr. Ghassan.
So can you see my screen? Okay, can I start?
Yeah, we can see it, Dr. Ghassan.
Okay, great. So first, I would like to thank Dr. Kenneth because I think we have something common here about using the PCR or the BioFire for making a diagnosis of a few cases. So I labeled my presentation, or the title is A Stroke of Great Luck or an Indication. And perhaps, you know, the challenges that we faced during the management of this case has created this kind of title. So talking about using laboratory tests in the context of, you know, complex human physiology and disease response, we as a clinician teaching the juniors all the time that we should never base our, you know, diagnosis based on a single laboratory test alone. And we are in need to inquire all the time, do the test results match with the other pieces of the puzzle? Because when we approach a patient with some signs and symptoms, probably it's a puzzle that we need to put it all together. And we use sometimes the paraclinical testing to help us into making the diagnosis. But again, as mentioned, specificity, sensitivity of these tests has to be taken in consideration. So what I'm going to tell you, I'm going to tell you a story in form of, you know, day-by-day progression of the case that admitted to our hospital. So this is a 4 years, and I'd like to make a mention about the age of the child. She's a 4 years old, a premature baby. She arrived to our institution with fever and seizure activity. Going back 4 or 5 days prior to presentation, she had fever, and she approached a private hospital where she was admitted for 1 day, treated for quote-unquote nasopharyngitis. She received IV antibiotics, I believe ceftriaxone, and then she was discharged on oral amoxiclav. 1 day prior to presentation to our institution, she respiked fever again, and the fever measured as 38.5 Celsius. And at the day of admission, she developed what is believed to be a seizure activity that described by the parents as right-sided body stiffness, gazing, salivation, and teeth clenching. The duration lasted for about 15 minutes, and she needed the lorazepam in our emergency room to abort the seizure activity. That was followed by sleep. So at day 1 of hospital admission, she was hospitalized with you know, a suspicion of CNS infection. Giving the history of pre-treatment with IV antibiotics, the oral antibiotics, a presumptive diagnosis of partially treated meningitis was made. And the first challenge that we faced is that fact that the parents refused to consent for a lumbar puncture. And subsequently, we started the patient on ceftriaxone plus vancomycin empirically. The initial laboratory tests in terms of CBC and CRP, they were unremarkable. Day 2, the patient, she developed a new seizure activity, but at this point, she became kind of delusional, delirious. She could not, you know, recognize her parents. She was saying unrelated phrases, and the initial laboratory test in terms of glucose particularly was normal, while the YBC, CRP, procalcitonin, and they were elevated. Anyone would think about the possibility of meningoencephalitis in the context of mental status changes. So the patient was started on top of the antibiotics, the cyclovir, and this is what is suggested by the International Meningitis Consortium by making a diagnosis and starting cyclovir as an empirical therapy. Day 2, after midnight, the patient suffered another seizure activity, and because of the frequency of this seizure activity, she was moved to the PICU, and an EEG was made in the PICU, revealed mixed theta and beta with widespread slowing and no epileptiform activity. CT scan did not show anything. The patient was encephalopathic in the PICU. So in day 3, we managed to convince the parents that we need to do the spinal taps. It's very, very important into further decision-making. And as you can see here, the spinal tap showed only white BCs with 50-50 segments and length. The rest of the cytology and the chemistry of the CSF seems to be normal. And back to, the biofire or the meningitis encephalitis panel, it was, did not show any DNA particles of any of the viruses included in the panel. Day 3, due to recurrent seizure activity, the patient was intubated. MRI was done, and it showed a high signal in the left temporal lobe. EEG showed electrographic seizures. And at that point, the differential diagnosis some kind of took another path in terms of considering autoimmune encephalitis, FIRES, which stands for fever-induced refractory epilepsy syndrome, and metabolic diseases. And the decision was made by the PICU to stop acyclovir based on the PCR results and to start pulse steroid. And the issue was this could be more or less autoimmune encephalitis, and the management for this part of steroid therapy was guided by our pediatric neurology team. On day 6, as you can see, the patient still spiking fever, and these neurological changes remains unchanged despite using the pulse steroid for 3 days. And to be honest with you, it's a bit puzzling. This fever that persists despite using the antibiotics, despite using the steroids, and the seizure that did not stop, made me to think about what if there is something that we need to look further. So on day 6, what I decided, I asked the team to repeat the spinal tap once again. And of course, as Dr. Wali just mentioned, we need to take in consideration the MILC as one of the differential diagnoses in many patients who are coming with very unusual presentations. And I suggested to the team to restart acyclovir, awaiting the repeat culture, the LP results. The second LP was done on day 6. As you can see, there is a bit elevation in the white BCs from 8 to 11, with more or less same distribution of segments and length. And there is nothing really kind of impressive in terms of chemistry. But what the patient continued to have the seizure. She went into refractory status epilepticus despite using multiple anti-epileptic medications. And she needed ultimately to be started on ketamine infusion to control the seizure activity. She was in a very bad status epilepticus. And this is what we get from the second spinal tap. So we have the human herpes virus 6 DNA is detected. And again, as Dr. Kenneth mentioned, what you are going to do with this. To me, I wanted to interpret this result in the context of the clinical presentation, maybe questioning the results, but again, there is a change that need to be done or an action that need to be done at this point. So what we decided to stop acyclovir and to start foscarnet as a first-line treatment for a patient with human herpes virus 6 encephalitis, extrapolating, of course, from the post-transplant patients. And we decided to send whole blood human herpes virus DNA just to compare and see where we are. On day 9 of hospital admission, the patient continued to experience seizure activity. To control seizures, she needed a thiopental coma, so things were kind of worsening day by day. On day 13, which is about 1 week of antiviral therapy, at some point we attained the burst suppression. So there was minimal lung suppressions. There was no clinical or electrical epileptic discharge, and at that point we started to wean off the thiopental coma. On day 17, which is equal to day 11 of antiviral therapy, the patient was off thiopental coma. There was no clinical seizures. She started to have some movements of hands, and there was a cough reflex. MRI that was done showed no abnormalities, and as you can see here, the other differential that was partially excluded by having the autoimmune encephalitis panel as negative. And this is still can be used to argue this may be what we are dealing is a human herpes virus 6 attributed meningoencephalitis in this immunocompetent patient. Day 22, which is about 2 weeks into antiviral therapy, we have another fever spikes. Again, the patient was somehow in a stable general condition when she started to have more frequent seizures, and we have a new fever spikes. And of course, a patient in the PICU will go complete investigations in terms of ruling other bacterial infections and plus the antibiotics, and ultimately this has been done, and nothing out of these were positive. So to me, I was questioning why would this patient, after 2 weeks of antiviral therapy, which I believe it was attributed to human herpes virus, why she would break through again fever or seizures. And of course, following the international guidelines, I just want to make sure that what I'm using in terms of therapy is really effective or not. So we decided to go for the spinal tap again and look for the presence of the human herpes virus in the CSF. As you can see here, we have almost normal CSF in terms of cytology and chemistry. And after 2 weeks of therapy, we have the human herpes virus still positive in the CSF. And this, of course, will create many questions. And the most important, if we still believe this is a human herpes virus attributed meningitis, meningoencephalitis, what is the next step? So I decided, based on literature review and extrapolating from other guidelines, that I will add a second agent, because I was in between 4 possibilities to choose in between, and I elected to go for addition of ganciclovir on top of foscarnet, because the patient was in a very bad general condition, hoping that we might do something for a young lady. So on day 27, which is about day 4 of dual therapy, foscarnet and ganciclovir, the patient continues spiking fever, but as you can see in the graph, it's a bit less, and EEG suggestive temporal lobe electrographic seizures, less frequent than previous. And by day 27, we received back the human herpes virus DNA in the whole blood. And as you can see, it showed 663 copies, which is about 2.8 log. This is questionable. It needs to be kind of looked at further, because it might mean something like chromosomal integration of the virus. So on day 7 of dual combination therapy, the patient became afebrile, and she was extubated. At that point, the Glasgow Coma scale was 10/15. There was a spontaneous eye opening. She was awake and off sedation, moving the lower extremities more than the upper extremities. Day 36 of hospital stay, which is about 2 weeks into dual combination therapy, the patient general condition was relatively stable. And we have the human herpes virus from the blood. This is a second sample, was done in 1 week from the previous one. As you can see, there was an increase in the total copies of the human herpes virus, almost a double, and the log was increased a bit from the previous one, but it is high. And this log of PCR in the whole blood question that this is a chromosomally integrated virus or just a viremia concomitant with the human herpes virus encephalitis. I decided to wait and see how things would go by repeating the samples while carrying on with the treatment, because these numbers to me did not look very much high, where the chromosomal integration usually we see higher numbers. So a fourth spinal tap was done after 2 weeks of combination therapy. As you can see, the YBCs in the CSF was normal. The cytology and chemistry of the CSF almost normal, and we achieved negative conversion of the human herpes virus DNA from the CSF. And that was something great and very reassuring. Day 46, which is about 4 weeks of dual therapy, we have a seroconversion from the blood as well. So there was the DNA of the human herpes virus was not detected. And this would speak against the chromosomal integration of the human herpes virus in this particular patient, maybe proving that the entire clinical presentation was attributed primarily to human herpes virus 6. Day 60, which is about 6 weeks of dual therapy, we elected actually to go to the maximum duration of therapy in order to get the maximum benefit, especially that within the first 2 weeks, we did not manage to get anything from the CSF in terms of conversion to negativity as well as in the blood. So by 6 weeks of dual therapy, the patient was awake, alert, more attentive. Glasgow Coma Scale was 14/15, and at this point in time, we decided to stop the antiviral therapy. Day 90 of hospital stay, she was sent home. She was awake, aware, more attentive, but she's still unable to sit or balance herself. There was totally no clinical seizures, yet she was on multiple anti-epileptic drugs, and she was traveling abroad for neurorehabilitation. This brings us to the end of this story, which I think this patient benefited from insistence into maybe repeating the spinal tap. I'm not really sure if it was a great luck or it was an indication. I just extrapolated from the treatment of human herpes virus patients when you sometimes need to repeat the spinal tap when you are in doubt. And I was personally in doubt there is something in this particular patient. Maybe it's an infection. So I tried to look it up, and repeating the second spinal tap was maybe favoring the diagnosis and initiating the proper treatment. Lastly, I would like to end with Patch Adams says that you treat a disease, you win, you lose. You treat a person, I guarantee you win, no matter the outcome. Thank you so much.
Thank you so much, Dr. Ghassan. Fascinating case. I'm sure that it must have been really stressful for you to manage this patient, because it was very stressful going through the presentation and wondering what's going to happen to the child, but glad to know that she's doing well. So I'll open the floor for questions. And while we're waiting for the audience to ask any questions, just a quick question, Dr. Ghassan, was there any immune evaluation done for this child?
Yes.
Any concern about immune
Yeah, of course.
deficiency?
When a patient coming with such kind of severe presentation of a human herpes virus, you would think that maybe he or she is an immunocompromised. She went the entire immunology workup by our immunologist, and nothing really there. She's immunocompetent. So this is what was done completely, of course.
Right. It's very interesting. We had a case also out of the blue. A 9-year-old came with severe seizures and neurological deterioration. The only thing that came positive was HHV6. And because that was the only thing that was there, and cultures are negative, there was no other reason, autoimmune, we did decide to treat him with ganciclovir, and he recovered. So I don't know whether it was, were we treating HHV6 or was there something else that was self-limited? It's just, but when they come in that sick, you really want to make sure that you're not missing anything. A question for you, Dr. Kenneth. How reliable are these PCR CSF panels in children who are incompletely vaccinated? So like you presented your 3-month-old, you always worry, this is a kid who's not vaccinated, or somebody who's a 2-month-old, incomplete vaccination. Should we wait for the CSF cultures before discontinuing the antibiotics, even if you have a positive CSF PCR panel?
So this is an excellent question. And of course, what's being asked is if the pretest probability is higher, does that change how we respond? So I think the answer is not necessarily. I think that the panels are sensitive probably in the range of 95%. And so in the case of most of the meningitis we see, I think a single panel result is useful. Now, to Dr. Ghassan's wonderful talk, I think it points out that if you have doubts, I think it's smart with any assay that if you have doubts about the result you're seeing, do it again. In the CNS panels, the weak link is actually herpes. So if you have a clinical suspicion of herpes virus particular, there the sensitivity is somewhere between 90 and 95%. Absolutely continue the acyclovir and repeat the assay in a couple of days. But I think for most of the pathogens for which you and I would vaccinate, I don't think there's any reason to think that there would be greater doubt.
No, I
Thank
agree
you.
with you, Dr. Kenneth. You know, one time I had a patient with herpes virus encephalitis, actually, clinically and imaging, you know, consistent with the first PCR was negative. We repeated it was negative, but clinically and imaging studies consistent with herpes already was started on acyclovir, and we agreed with the neurologist to continue.
Yeah, and I think that's very wise.
Interesting enough, after a month, it came human herpes virus 6, human herpes virus 2 in the culture. So we have to trust our clinical judgment sometimes, particularly when it comes to HSV.
Yes, completely.
You know, regarding the human herpes virus 6, we recently published the 3 cases with the variable presentation of a human herpes virus 6 encephalitis. And after we published these cases, I would say I had another 3 cases of a human herpes virus 6 encephalitis also. Interesting enough, all of them immune competent except one. And the one who was immune deficient, the outcome was horrible. So as Dr. Zainab mentioned about the question if immune system evaluation done, I think it's prudent whenever we have a human herpes virus 6 encephalitis to do immunological work up for that patient.
Well, and I think Dr. Ghassan also made an excellent point. I think there is some suggestion in the neurology literature that the patients who do get into trouble with human herpes virus 6 are the ones who have integrated virus. And that may be a process entirely separate from their immunosuppressed state, which, as you suggest, may be a contributor to symptoms in patients who are otherwise immune competent.
Dr. Kenneth, there is a trick, you know, we can do with the chromosomally integrated HSV6. Usually I do PCR in the blood and serology. If the serology there and PCR is there and repeat the CSF, very unlikely to be a chromosomally integrated human herpes virus 6. In addition to the context of the clinical condition.
I think the chromosomal integration, it has to do with the numbers, particularly the blood. Usually, it's very less likely to see these low numbers in terms of 2.83 logs. It's very low for chromosomally integrated. You would expect these in millions. And if they are in millions, then most probably this would be a chromosomal integration. And for confirmation, you need to have a somatic cell testing, like hair follicles that need to be tested. And this is the only way that you can confirm the chromosomal integrations. But the higher the numbers in the blood, it might be less in the CSF, then you may question the chromosomal integration. But as I mentioned, these numbers in our patient were very low, actually, even to think about it. But I wanted to do it and to look at the, you know, the trend of the PCR. And as if you have seen, it went as negative in maybe 2 weeks from starting the combination therapy.
What was the serology, Dr. Hassan?
What do you mean serology? You mean antibodies?
Antibodies, yeah.
We did not test for antibodies.
You did not?
No.
I think sometimes it is helpful, you know, to do particularly quantitative IgG, IgM to differentiate between both chromosomally integrated and...
I think what they use also in a transplant, they look at what's they believe the CSF blood ratio. It is not really very commonly used, but I mean, if the number above 1, so it's most likely to be a chromosomal integration. If it's below 1, it's going to be more of an infection. But in our case, we did not have quantitation of the, you know, the PCR in the CSF, unfortunately. It's only in the blood. We have either positive or negative in the CSF, but the numbers, they were only in the blood. But again, as I mentioned, these numbers were low enough even to think this is very less likely to be chromosomal integration from the start. Because of this, we were very consistent into, you know, upgrading even the antiviral therapy just to overcome the bad prognosis for this patient.
So Dr. Walid, coming to your case, do you think that the HLH was triggered by dengue virus infection, or was this something else?
Most probably, the only positive is dengue fever infection. In addition, the patient had COVID antibodies was high. So one day I was chatting with Dr. Kenneth, about this, after the COVID pandemic, we have better understanding for previous diseases, about the pathogenesis and pathophysiology, and ended most of them with cytokine storm, which, it's really very hard. But the point here, high index of suspicion and awareness, and to be very aggressive in the treatment. We don't have to worry about either dengue or MISC. We have severe cytokine storm. We have to focus on this. I would say, Dr. Zainab, most probably the immune system was dysregulated by the COVID or whatever, and this infection just, put the immune system on fire, and we have massive cytokine storm. In addition, if you remember, we discussed this issue before, that maternal antibodies, it has to do with also severe outcome of dengue in infants. But for dengue and HLH, not really that common complications of dengue, particularly in infants. So the point here, it is not clear, to be honest with you. I can't tell you which is which. If I have to lean, I will lean towards that the triggering endpoint is the dengue fever, which is consistent with the history of travel to India, and also which was recent infection, because non-structural protein 1 was positive, and usually it is very diagnostic in the first week of the infection. IgM, usually it is not positive in the first week. It was, we repeated after 1 week or so, it was weekly positive. IgG was negative. The take-home message from this case, for the diagnosis, we have sometimes many etiologies that we don't have real therapeutic treatment against it, but we have to treat what's the consequences for this viral infection, like cytokine storm.
Right. Well, glad the baby is doing well. Do you envision that he's going to need another infusion, or watch and wait and see how he does?
To have what?
Is he going to, he got a JAK3 inhibitor therapy?
Yeah,
right?
JAK inhibitor will continue, and based on the clinical and the inflammatory markers going down or normalized, it's still not back to normal. And he is on tapering doses of dexamethasone, and anakinra will be also on tapering dose. He is on low dose of anakinra.
I see. Well, hope he does well. We have a question from the audience that says, how can we do early diagnosis for HHV6 related infections?
Early diagnosis is the PCR, that's why Dr. Kenneth and Dr. Ghassan stress this point. We have the BioFire nowadays. Clinical index of suspicion, it is really good, because Dr. Kenneth and Dr. Ghassan, my colleagues all, the first case when I was in the state, still there was no BioFire on the CSF, and the human herpes virus 6 was not in, it was, we have to ask specifically. And the patient started with, started with the typical case of a human herpes virus 6, with the erythema and irritability, etc., and then complicated by encephalitis when it started to have seizures and neurological deficits. But nowadays we are so lucky. Anyone whom we think CNS infection, we just do BioFire of the CSF. This is the early diagnosis, and also the other dilemma about whether it is chromosomally integrated or not. My friends, Dr. Kenneth and Dr. Ghassan, explained it clearly to us and to our audience.
Great, thank you. And I think we just have 2 minutes left before our session ends, and a quick question for Ken and Ghassan. You know, when we treat babies with HSV and meningitis, encephalitis, we do expect that they're going to have subclinical reactivation of the herpes virus in their CSF, which is why we put them on prophylaxis. And HHV6, considering it is a herpes virus, if we have an encephalitis in an immunocompromised person, would you also put them on long-term prophylaxis?
Wow, that's a really good question. I think the answer is going to be something like this, and I'll defer to Dr. Ghassan here, but I suspect the literature is probably inconclusive or completely non-existent on this, and that what you and I consider is that the toxicity of acyclovir and the expense of acyclovir is minimal. And of course, what we're playing is a game where we are battling to save IQ points. So for my part, in the absence of any compelling information, I would certainly give very serious consideration to putting a child on prophylactic acyclovir, at least until we had some semblance that their T cell function was again normal. Dr. Ghassan, what do you think?
Well, I think the issue here that we have two strains of the human herpes virus. We have the A and B, and we don't know about the resistance pattern of this. I think the most commonly is the B. And if you're going to put this patient on something like oral valganciclovir as a prophylaxis for something like months or weeks, you will be challenged by the susceptibility issue. And this is a thing that will be, just as Dr. Kenneth mentioned, it's a toxicity with no added benefit. So there's nothing really mentioned outside there about immunocompetent patient to be on long-term prophylaxis. This is a bit very rare to find, to be honest. I second Dr. Kenneth that I won't be using it for now, at least until some new evidence comes up.
Sounds good. Food for thought. Great. I'd like to thank all of you for this amazing session. And I'd like to pass the stage to Dr. Saurabh. Thank you very much.
Thank you.
Dr. Saurabh, are you here?
Pass it to Dr. Kalpana.
Oh, okay. Dr. Kalpana. To close the session.
Mr. Tawfiq.
Very much. Thank you very much. Excellent presentation and discussion. I would like to thank Professor Kenneth, Dr. Zainab, Dr. Hassan, Dr. Walid, Dr. Parvin. He was flying to India. We can have an excellent discussion. I would like to thank all of you. I would like to thank all viewers following us in this Sunday. Well, I would like to give a last remark, final remark regarding this conference. We ended with an excellent session of pediatric infectious disease. So really I enjoyed. I'm sure there are many other questions, but because of lack of time, we cannot complete. I would like to thank the management of NMC for this conference, which is semi-accredited. We are expecting about 16 points for both sessions, physical and virtual. I would like to thank all speakers, chairpersons, moderators, panelists. For a long time they had the preparation and they presented really all viewers. They enjoyed, I'm sure, yesterday in physical and today in webinar. I would like to thank the organizing committee, especially Dr. Kalpana Sengupta, the secretary of the club, and Dr. Diari Muhammad, chairman of the academic affairs, and other members. I would like to thank our sponsors, especially Mr. Tawfiq, the country business manager of the Vita Biotics, for sponsoring this conference, and he's sponsoring since 2015. I would like to thank all the viewers and see you in our 9th annual Dubai Pediatric conference, which will be on 29th and 30th of April. This time we are going to have it earlier so that to have more speakers and better topics. Thank you very much. Thank you all. See you next year. Thank you very much. Dr. Kalpana, are you with us? Dr. Kalpana, to give a remark? I think she is not there. Thank you very much. See you next year. Good day.